Hello. Good morning, all. Delivering a healthy baby is the pivotal dream of any mother and family, and the onus and responsibility of fulfilling this dream lies with us, obstetricians and sonologists. In this context, the antenatal scanning and evaluation is the most precise and sensitive way to ensure delivering a healthy baby and, in turn, lead to a healthy society. So, without a delay, we are starting our today's first session. For this, I would like to invite Dr. Shilpa Satrakar ma'am. Madam is a senior radiologist in Aurangabad. She is really a very good teacher. She is national coordinator of Samrakshan team of area working for preeclampsia screening to reduce perinatal mortality. She have many national and international presentations and publications. Over to you, ma'am. Thank you.
Thank you very much for this kind words of introduction. So let's start with the topic because we are learning. We have started a bit late with the inverted pyramid of the fetal care. The anomaly scan, which was scheduled first in the 20 weeks, now has shifted to during the NT scan period, and we have to say that the NT scan, the name should be changed to first trimester anomaly scan, where NT&B evaluation for aneuploidy as well as preeclampsia should be a part of that thing. So in the first trimester, we all know that we focus basically on the common trisomies, but there is just the tip of iceberg, and what can we have below that are the fetal defects. We have to screen for genetic syndromes, we have to screen for preeclampsia, FGR, preterm things, and many more things. Like in twins, we have to identify the chorionicity, the amnionicity. So many things are there in the first trimester, but at present we are focusing only on the trisomy thing. But if you see the frequency of complications which occur in the first trimester, you can see that the fetal defects, means trisomy is hardly some percentage, but the fetal defects and the preeclampsia and FGR and IGR, they contribute a very significant part of the pregnant population. So we have to focus on these part also. Today we will be focusing basically on the structural defects. So if you see the prevalence of common trisomies, it is for trisomy 21, that is down, it is 1 in 1. This is the Western data, not the Indian data. So it is around 1 in 500, while for trisomy 1813 it is 1 in 4500. But the prevalence for fetal defect is around 1 in 50. So we have definitely to focus on the fetal defects in the first trimester between our 11 to 14 week scan. So can we detect anomalies in the first trimester? Yes, definitely we can detect the anomalies. And this is the 2017 meta-analysis, which shows that yes, the detection rate for in low risk population is around 32%, while in high risk population, means who have previous CHD or who have some previous abnormalities and like things, it is around 61%. And then what are the factors that affect the screening performance in the first trimester? So the structure protocol and the routine, the route, basically how you evaluate the fetus. Yesterday you have seen the transabdominal and the difference between transabdominal and transvaginal scan. So a combined transabdominal and a transvaginal scan will give you a highest detection rate for the fetal anomalies in the first trimester. And this is how the importance of the structured protocol was studied in this study. So this is a 2021 study. They studied around 53,000 fetuses with a very structured protocol, where they evaluated this in 14 different sections, and they found nearly 1,578 fetal defects, where the detection rate comes to around 43%. So yes, in first trimester we can definitely detect the anomalies. These are the IUCG guidelines of 213 for the first trimester scans, where you can see multiple stars are there. Stars means it is optional. If you want to take, you can take, or if you don't want to take, you can't skip it. But that should not be the way. We have to follow the new guidelines, where they have removed all the stars of the minimum fetal requirement, and now they have included all the basic things that should be included in the fetal scan in the first trimester. And these are the basic things. I'll be discussing that as the slides come. And apart from this minimum requirement, a more advanced level of best practice is indicated, where they have added certain things because of the advanced technology and all these things. We are using high-end machines, so that benefit should pass on to the fetus, and therefore these basic things are included, which are very well seen in the first trimester anomaly scale if you focus apart from NT. And this is better seen when you use a combined route of transabdominal and transvaginal. So in the first, in head and neck, apart from the intact intracranium, the butterfly and choroid plexus, We have to look for the thalami, brainstem, cerebral peduncles. Yesterday we have shown all these things. Face was not included in the previous thing, but now they recommend to evaluate the forehead, the orbits, nasal bone, maxilla, the retronasal triangle, and the mandible along with the nuchal translucency. In diaphragm, in thorax, we have to look for the diaphragm, which we discussed yesterday. In 4-chamber heart, previously it was only to look for the heart rhythm, if the position of the heart was thoracic, and the size of the heart. But now with advanced technology, we have to include the 4-chamber heart in color and black and white. We have to look for LVOT, the 3VTV view, and we have to again look for the TR and the DV. In stomach, previously kidneys were not included in abdominal view. Now a bilateral presence of kidney needs to be evaluated. We have to evaluate the spine in detail, all the extremities with the 3 segments and free movement. Then we need to evaluate the placenta. Aniruddha yesterday has told us about how the placental anomalies can be there. And then we have to, a very important thing which is included is the evaluation of the cervix and the previous uterine cesarean scar. This is an absolutely important topic. And then again we have to evaluate the cord insertion in the placenta. Amniotic fluid quantity, the amniotic membranes, these also need to be evaluated. So now which route is recommended? Transabdominal, transvaginal and combination. A combination gives the optimum results in the first trimester. Yes, there are definitely limitations of the transvaginal scan, that the manipulation is very limited. It can be very well used up to 13 weeks, because after 13 weeks the fetus becomes vertical and so it becomes very difficult to evaluate. But between 12 to 13 weeks, yes, a transvaginal scan is absolutely fantastic. In fact, in my clinic, my NT scan starts with the first trimester anomaly scan, which is always on transvaginal scan. And then I go for transabdominal, where I do take the NT and NB. Therefore, transvaginal scan is really amazing, and majority of my images which you will be seeing are all on transvaginal scan. So defects which we are not going to miss in the first trimester. So I am not going to tell you what is this. What is this? What is this? Anencephaly, yes. Then we are not going to miss omphalocele, very common, means very easily detected, not that common. Then this is the limb body wall complex. Here you are not going to miss such anomalies. Holoprosencephalus we are not going to miss. Then this gross megacystis we are not going to miss. And then this placental anomaly. So here you can see there is a thick placenta with multiple lacunae there, but the retroplacental complex is very nicely seen. So this is thick and placenta associated with triploidy. So this we are not going to, definitely not going to miss in the first trimester. And then there are different types of these anencephalies, like the shapes, depending on the shape, there are different type of anencephalic are they are proposed. And then in the early trimester, the hyperechoic amniotic fluid, when there is twin or even in the singleton, because of sloughing out of the brain, the amniotic fluid becomes hyperechoic, and then you can identify this difference very well in the twins or even in the singleton, where the amniotic fluid becomes echogenic. And in the first trimester, when we evaluate the fetus for the anomalies, a pattern recognition is absolutely important. You have to identify what is, in first trimester anomaly scan, it is really very simple. There are very few things to be seen, and then a pattern recognition should be there, a very perfect pattern recognition. If you identify any deviation from that pattern recognition, yes, the anomaly you can suspect. And you have a window of second early anomaly scan at 14 to 16 weeks, nearly 16 weeks, where you can re-evaluate the fetus and confirm the anomaly. So what we have to see in the axial section, yesterday we have demonstrated the intact cranium, the head shape should be normal, the midline falx should be there, choroid plexus should almost fill both the ventricles, this typical butterfly sign should be there, and then these are the thalami which we have seen, this is the aqueduct of Sylvius, and these are the cerebral peduncles. And then slightly when we go towards the still a caudal view, we get this fourth ventricle and the cisterna magna here. So the butterfly sign, we have to see this, and when it is not seen, we suspect holoprosencephaly, right? And then in holoprosencephaly, when we have to evaluate the fetus in detail, where you can very well see this is the case, the monoventricle is seen, there is the ventricle is connected here. You can see the very closely placed orbits here, and there's this proboscis is seen. So the diagnosis of holoprosencephaly, that to Erlobor holoprosencephaly, is very easy in the first trimester. And again, yesterday somebody asked, what is the crash sign? So this is the pattern recognition in the first trimester. These are the thalami, these are the cerebral peduncles, and then this is the aqueduct of Sylvius. This is the aqueduct of Sylvius. So what happens in open neural tube defect? The fluid in the posterior fossa, it totally drains out, the fluid in the fourth ventricle drains out, and here what you are going to see, this aqueduct, which is, sir yesterday told you that it should be around more than 1.5 centimeters. Here eyeballingly you can say that yes, this aqueduct is very near to the this occipital bone, and then you can see this shape of these cerebral peduncles is rounded here it has become square, and so if you draw a tangent from here, the cerebral peduncles, this tangent will meet here, while if you draw tangent from here, the tangent won't meet, and therefore it is a parallel cerebral peduncular sign. Now this is the crash sign. All these structures are just gone and crashed to the occipital bone. And then in the midline section, a pattern recognition is absolutely important. 4 echogenic lines and 3 hypoechoic bands. So the 4 echogenic lines, the first line is of the sphenoid bone, then second is the posterior border of the brainstem, third is the choroid plexus of the ventricle, and last line is that of the occipital bone. And then these are the 3 hypoechoic bands. This is the brainstem, this is the fourth ventricle, also called as intracranial translucency, and then this is the cisterna magna, and this is our regular NT. So in this section, we know that we totally focus on this area and never look at the fetus and the other parts, but the facial profile tells us lot of things. So basically these part, if you focus, you can identify the absent nasal bone, then the cleft lip and cleft palate. When it is bilateral, such type of protrusions are seen right from early pregnancy. Then in this you can see, this is the palate which we have demonstrated yesterday. Here you can see this cleft palate things, and then you can also very well identify the micrognathia. Here you can see the mandible is regressed too much, and in the 3D it is very well clearly seen. When you focus on this area, we can identify the anencephaly, the encephalocele, and the holoprosencephaly we have seen. The encephalocele can be as big as this, almost equal to the size of the brain. And then this area we know what we are going to see, increased NT, then absent IT, which we are going to see in the open spina bifida. And when these ITs increase, then we have to suspect the posterior fossa anomalies. Now, what are the posterior fossa changes in the open spina bifida? So, yesterday someone was asking what is brainstem angle and this thing. So, what happens as the CSF drains out, this brainstem becomes large, it becomes big, and the IT is absent. Therefore, the 4-line 3-band pattern goes off, and it becomes 2 lines, 3 echogenic line and 2 bands. And this is the brainstem which now goes posteriorly. So the brainstem diameter increases. As the brainstem diameter increases, the brainstem to the occipital bone distance decreases, the ratio increases, the cisterna magna width decreases, and the IT becomes absent. So this is a case, normal case for comparison. 4 echogenic line, 3 bands, this pattern we have to keep in mind. And now look at this fetus. Okay. See, you are visualizing only 2 bands and 1, 2, 3 lines. So this is a typical case of open spina bifida. Also the shape of this brainstem, which is a just a band like thing, now it has become a Z shape like thing. So these are the changes you have to identify, and then when you go to the spine, you can very well clearly see the defect, and this is the picture of the abortus. So the identification of the open spina bifida in the first trimester is very easy. Now the ISUG guidelines in 2013, the face was totally optional, but now in 2022 they have asked us to look for all these things, and believe me, these are very easy if you do both TA and TVS. So in this section we are going to identify the forehead, which is very clearly seen, nasal bone, we do it as a part of our NT scan. Then we have to look for this palatine part of this maxilla. Upper lip is seen in this section also, and then we look at the mandible here. In the this palate thing, this part is the vomer, and then this is the maxillary part of this is the palatine part of the maxillary bone. And this hypoechoic line, when you see with a continuous echogenic thing, then we rule out the cleft palates. the midline cleft palate. And in the face, then yesterday we have seen the orbits with the lens, and this is the retronasal triangle, which is very well seen. Any defect here can be demonstrated. Then we have to look at this mandibular gap sign. So when we pass this line or in the retronasal triangle, here the mandibles are seen, and here a gap is seen, which is a normal thing. When there is retrognathia, the mandibles go like back, and when you pass this line here, you can see a continuous thing here. The mandible is seen as a continuous thing, and it is the absent mandibular gap sign, which is diagnostic of the micrognathia. And then upper lip, this is better seen on TVS. Upper lip and these things also can be very well evaluated. So now coming to the cardiac anomalies. Can we detect cardiac anomalies in the first trimester? Yes. In low risk population, nearly 55%. In high risk population, nearly 70% cardiac anomalies can be detected. And believe me, cardiac anomaly detection is very, very simple if you follow certain rules. What rules we have to follow? We have to follow pattern recognition. Again, the same thing which we did in brain, we have to follow that in the heart also. So this ISUG guideline, what have the recent guidelines say, that you have to look for the cardiac activity, the position of the heart. It is very simple to identify position. Cardiac axis is also simple. Size of heart, we can with all the second trimester protocols of the fetal echo, they are included in the first trimester, and believe me, they are quite easy to identify. The important thing is that we have to identify the 4-chamber view, and in that we have to put the colors so that we get two parallel tracks of same color depending on where the position of the spine is. And then we have to identify the LVOT, and in the 3-vessel trachea view on gray scale as well as on the color Doppler, and we have to look for the tricuspid regurgitation and the ductus venosus A wave, which is a routine part which we do in our scan. So the recommended planes for the T1 cardiac evaluation are first, as in the second trimester the fetal echo, in the first trimester also it starts from the axial view of the abdomen, and the situs demonstration has to be done on trans-abdominal and non-transvaginal, this remember. So then we have to evaluate the heart in the 4-chamber view. It is the same like the second trimester. TVS gives an absolutely amazing view. 4-chamber view, again you have to demonstrate these two colors of same direction, same width. And they should have there should be no discrepancy in this size of this jets. And then in the 3-vessel trachea view, we have to demonstrate this pulmonary artery and the aortic arch. And again the protocols are same. We have to demonstrate the position, axis, situs, then the 2 inflow tracks. It is very easy to demonstrate. The 2 inflow tracks are very well demonstrated. And then we have to demonstrate this crisscross. The crisscross demonstration is absolutely simple in the first trimester because the heart is so small. Means in second trimester it becomes very difficult to demonstrate this section. But in first trimester it is very easy. And then we have to demonstrate the outflow track, which is recommended, LVOT. Even if you don't demonstrate LVOT, this crisscross will tell you that yes, definitely the heart is normal. And when we see this dash and dot thing, that tell us that yes, these 2 vessels, the 2 great vessels have crossed each other. If they are not crossing each other, they will be parallel. But when these 2 cross each other, when you see like this in a section, you will find there is one line and the other vessel will come as a round, right? So this is a dash and dot. And that will tell you that yes, these vessels have crossed each other. And this is the X sign, which is the crisscross sign. And then this is the V sign, which is the 3-vessel and the trachea view. This is the ductal arch, this is the aortic arch, and this should always be on the left side of the spine. So this evaluation, it is in a very a quick evaluation is possible. And when you identify these pattern, you will rule out majority of the cardiac disease which we can detect in the first trimester. And again, the cardiac axis detection is absolutely important because this study has shown that the cardiac axis in early gestation, it is more sorry. It is more helpful for diagnosing, or it points towards the cardiac congenital heart disease. So detection of cardiac axis deviation becomes also important. Then position of the heart, this is the case of pentalogy of Cantle, where you can see the heart is placed outside the chest cavity. Position of heart is important. Again, axis, situs and size becomes important. This is how we take the cardiac axis. You can see that this heart is almost perpendicular to this, and there is significant axis deviation here. And here you can see that the axis is altered, the situs is altered, the size is altered. So in one sweep you can identify all these things. Now this is a case, this was almost 102 kg lady, she came at the CRL of 67. Here you can see that there is some chamber discrepancy. Thank you. And then when we just put the color, we can see only a single outflow tract is there, and in the 3 vessel trachea view, we want the V to be seen in both in the same colors. But here now you are visualizing that yes, there is a blue color line, and then there is a other vessel is small and it is of red color. So when we suspected that yes, there is some cardiac problem, and we again called her at 16 weeks, where the chamber discrepancy is very well demonstrated. The reversal of the flow in the aorta is seen. Then she was having a single umbilical artery by 16 weeks. There was echogenic bowel. The femur was short. We did her amnio and it turned out to be Down syndrome, and the cardiac disease in which she was having left hypoplastic heart syndrome with aortic atresia. Now this patient came at 12 weeks 4 days, and here you can see that yes, definitely there is some chamber discrepancy, right? So chamber discrepancy is significantly seen, and there was I expected 2 parallel outflow tracts here in the 4 chamber view, but something was going wrong here. And when I came cranially towards the 3 vessel view, I could visualize only single outflow tract, and when I slightly made it oblique, 2 parallel outflow tract was seen. So this chamber discrepancy, some cardiac anomaly, at least we can identify this, yes, something is going wrong here. And then you can tell the patient counselor that yes, I am suspecting something, the fetus is too small, I wish to see you again at 14 to 16 weeks. If you are confident, you can give the diagnosis there and there only, but you can again call her at 16 weeks, and so we called her again at 14 to, at 14, 15 weeks she came. And here you can very well say this is the 4 chamber heart, this is the VSD through which the blood is going and you can see that in the 4 chamber heart only one inflow tract is seen. The inflow tract to the right side is not seen, therefore this was a case of tricuspid atresia with VSD, and here very well you can see the outflow tracts coming. So this is the case of tricuspid atresia VSD with double outlet right ventricle, which is diagnosed even at 12 to 13 weeks also. And then this is a case of common arterial trunk. So 4 chamber view, a single vessel is coming out here. The crisscross is not seeing, 2 vessels are not seeing. This is a single large vessel coming, and can you see aliasing here? So there is flow in systole as well as diastole. So this is a common arterial trunk. And this was a case of twin pregnancy. She continued the twin pregnancy, and we got the postnatal follow-up of these case. So this was a truncus arteriosus type 1. So I had a complete case, but here I have presented only the T1 part. And then this is the outflow tract anomalies, which you can very well see the right aortic arch with the ulsa, where you can see this U sign, the trachea is in the center. So cardiac evaluation, pattern recognition become very important. Any deviation from this pattern recognition, you have to suspect something. And then in the thorax, as we have, as Praveen sir has yesterday told us, we have to evaluate this echogenicity difference, and then this we could identify this diaphragm here. And then this is the paper from Dr. Lakshmi. She has evaluated, yesterday somebody asked that can we diagnose diaphragmatic hernia in the first trimester? Yes, we can diagnose it. Deviation of the mediastinum, deviation of the heart, and then if you want to confirm, then you have to look for the superior mesenteric artery. That superior mesenteric artery, instead of going down in the abdomen, if the bowel is herniated, the direction of the superior mesenteric artery goes towards the thorax, goes towards the head. So this is the identification. And then in the abdomen, we have to identify the stomach, which we all know that is in the left side of the abdomen. Bladder, we have to see if it is filled properly. A completely filled bladder has to be demonstrated in the first trimester, and eyeballingly you can tell that the bladder is normal or not. If it should be always less than 7 millimeters. Then we have to look for the intact abdominal wall, anterior abdominal wall with the cord insertion. We have to look for the umbilical arteries which border the bladder, and then we have to look for the kidneys, the bilateral presence of kidneys, which you can see on black and white. And if you are not sure, just put on the color aorta, and then you can demonstrate the renal arteries, which we did yesterday. And then coming to the mid-serratal plane, here in this section, we take this section very regularly for the CRL. Just extend your eyes to this level. See if there are any anterior abdominal wall defect. For bladder, look at this area. Bladder demonstration is must. And here you have to look for the intactness of the skin to rule out any open neural tube defects, which at times are very, very subtle. This skin part is very clearly seen in the first trimester. And then in the abdominal wall defects, we have to look for the insertion of the cord basically. Basically the detection of anterior abdominal wall defects become very important, because the management, the counseling becomes totally different. And on ultrasound, we have to look for the relationship of the defect to the cord insertion. Basically, that will differentiate what is the anomaly. And then again, it will be very helpful in the parental counseling regarding what test to be indicated and how will be the prognosis in this case. So this is the classical case of omphalocele. Here you can see it is a midline defect which is well covered with smooth margins, and then the usually liver and stomach is herniated. And the most important point is that the cord is inserted over the omphalocele. So that is a differentiating point. While in gastrocystis, it is a right paramedian defect and the cord is inserted at a normal level. These are the differentiating points between omphalocele and the gastrocystis in the first trimester. If you see here, the chromosomal anomalies, association of chromosomal anomalies is very strong with omphalocele, and trisomy 13 association is very important here. And therefore, when you see omphalocele, you have to suggest counseling in that patient, and depending upon what the result is, the prognosis is there. Small omphaloceles of 7 to 8 millimeters may disappear by second trimester also. This also we need to remember. And this is a case of limb body wall complex, where you can see that this is the amniotic sac. Majority of the fetus is in the amniotic sac, but there is a gross herniation in the extra-amniotic area. So these are the bowel loops, these are the liver, all this is herniated outside, and this is never to be missed in the first. You can't miss that. And this is a case of pentalogy of Cantrell, where you can see there is a abdominal wall defect which is supra-umbilical. This is the insertion of the umbilicus which goes below this defect here. And then we have, as I told you, bladder extrophy can also be suspected in the first trimester. How we can suspect that there is a persistently non-visualized bladder. So you can see here the 3-vessel cord is seen, but the bladder is not seen. And when this patient came again in second trimester, this was a very classical defect seen here. The bladder was again not seen. Amniotic fluid was normal. Dr. Sudhir Hirve from BEAD, he has given me this case. And this is the picture of the abortus, where you can see very well this extrophy of bladder. Now, visualization of the kidney in the first trimester is absolutely possible. The kidneys look echogenic with this anechoic pelvis. On color, we can very well demonstrate that. And then we have to look for the kidneys in all the 3 planes, the sagittal plane, the axial plane, and then the coronal plane. Demonstration in coronal plane becomes very easy. Yeah, we can identify the position of the, this is the large lobulated kidney. And then fused kidney we can identify. We can see even the sleeping adrenal sign in the first trimester, which can demonstrate the absent kidney. But again, here you have to confirm with the color. And this is the case of an obstructive dysplastic kidney. So this is the first trimester where this kidney was very typically obstructed. And when she came in the second trimester, this was the obstructive dysplastic kidney. So this diagnosis is also possible. Meckel-Grubel syndrome in first trimester, yes, bilateral enlarged kidney with occipital encephalocele and polydactyly. This is very much possible. Urinary bladder, we have seen absence of urinary bladder is, that is prognosis. And what I suggest that whenever you start the NT scan, first look at this dynamic structure of stomach and bladder. Once you see them, then your life becomes easy. And then if you don't see them, you intermittently in between just focus on bladder, if I am visualizing bladder or not, if I am visualizing bladder or not. And if you don't see, make the patient sit and again reassess the bladder. You have to identify the bladder with this vessels here. It should always be less than 7 millimeter. Megacystis, we are not going to miss in the first trimester. Here you can see this diameter is 12 millimeters. Again, you can see the kidneys are echogenic and hydronephrotic. This is other case of megacystis here. And this is a case where you can very well see the keyhole appearance. This is the posterior urethral valve. And this diagnosis was made in the first trimester. Evaluation of the spine, we have to look for the contour of the spine and then the skin behind. So this is a case, here you can very well demonstrate that yes, there is a sharp angulation here, and you can very well see the hemivertebra here. You can see this triangular. Something is going wrong. At least identification of that much things is really important in the first trimester. So this was a case of hemivertebra. And as I told you, the visualization of the skin becomes very important. So this here you can see the skin is broken somewhere here. Here this was a case of open spina bifida, but this can very well be demonstrated, and on 3D you can see this very nicely, this defect in the skin as well as in the connecting with the spinal cord. And the evaluation of these 12 long bones with foot and palm is very easy in the first trimester. Yesterday we have seen we have to demonstrate this. We have to demonstrate the position of the foot in relation with this, this part of the leg. Evaluation of the hands and foot is very easy in the first trimester. We can identify the radial ray defects, then the polydactyly, amelia, then some part of the limbs can be missing, that can be identified. Serenomelia identification is very easy in the first trimester, because in second trimester onwards, as the serenomelia is associated with renal agenesis, many of the times there is severe oligohydramnios, and therefore limb evaluation becomes very difficult in second trimester. Therefore in first trimester limb evaluation becomes very important. The recent guidelines have said that not only visualization is important, but we have to see for the movements of the limbs in the first trimester. Now you can see here in this case, at this lower limb at the level of knee, it is hyperextended. So she was a case of arthrogryposis congenita. And then yesterday, as Anirudh has told us, we have to evaluate for the spine. If she is a case of LSCS, then visualization of the lower uterine segment becomes very important. And there you can visualize the retroplacental complex is totally gone. You cannot visualize the placenta. The placenta is thick with multiple, these lagoons are seen, vessels are there. So this was a case of morbidly adherent placenta. And this again, as I told you, this is the case of the triploidy, which I showed you in the beginning. So to conclude, you have to be aware of this iceberg. And you have to think that yes, I can do that, or otherwise your naya may duke down. So to conclude, it should be a first trimester anomaly scan instead of an NT scan. Along with the NT, you can do these things very easily. Pattern recognition is the key. Fix the pattern recognition in your brain. Any deviation from that, you have to suspect an anomaly. Follow the protocols. TA, TVS combined approach is very useful. If you suspect anything, do an early anomaly scan at 16 weeks. And when the whole world is now embarrassing new scientific thoughts and technology advances, it is always wise to be with the flow. And I don't have machines, I don't have time, I have so many patients, this excuses will not be there, because now world is moving to first trimester anomaly scan. We should at least start NT anomaly scan. And thank you very much for your patient listening.
Thank you, ma'am. For the next talk, I would like to invite Dr. TLN Praveen sir. Sir is senior most radiologist. He is practicing since last 35 years in fetal medicine. Past Vice President of National Area, past President of IFUMB, past President of Society of Fetal Medicine. He is passionate about fetal well-being and interested in performing invasive procedures. He is a great teacher in teaching and training of postdoctoral students. Over to you, sir. Thank you.
Very good morning, everybody, and I would like to thank the organizers for giving me this opportunity and spend some time with you sharing my experience as far as the fetal heart is concerned. Yesterday we had a wonderful workshop on anomaly scan as well as the first trimester, where we tried to demonstrate fetal heart as well as other aspects of the fetus. And today I am specifically going to talk to you about the cardiac evaluation. Now, the title which was given to me was the basic evaluation of the heart. There is nothing like a basic evaluation of the heart. Whenever you try to evaluate the fetal heart, it has to be a comprehensive evaluation of the fetal heart rather than a basic and advanced evaluation of the fetal heart. So, all the present laid down guidelines and the protocols have very specifically mentioned that whenever we try to evaluate, we have to evaluate the heart in toto. So, keeping that in mind, yesterday I have taken you through evaluating normal fetal cardiac anatomy. Basically, unless you understand the normal cardiac abnormality or anatomy, it becomes very difficult to comprehensively to identify cardiac abnormalities. So, the essence of today's talk and yesterday's workshop was to take you through a particular sequential segmental evaluation of the fetal heart, which gives us a comprehensive idea about the fetal cardiac anatomy. As you all know, the fetal heart is a very complex structure, and not only it is complex, it is dynamic, and not only it is dynamic, it is small. So evaluating the fetal heart definitely is going to be a challenging task. Now, whenever we try to evaluate the fetal heart, there are certain factors which will influence the evaluation of the fetal heart. First and foremost thing is the gestational age of the fetus. We all know the fetal heart as it appears at 11 weeks or 12 weeks or 13 weeks of gestation, fetal heart which appears at about 20 or 22 weeks of gestation and at term. So each one of them have got their own limiting factors which will influence our ability to evaluate the fetal heart. That is one. Second most important thing is that we need to be, as I yesterday showed you, that we need to be opportunistic, because fetal heart is one thing that once the position of the fetus is not in appropriate position, it becomes very, very difficult to comprehensively identify or to evaluate the fetal heart anatomy. So whenever the baby shows you the heart, better evaluate the heart at that time rather than wait for finishing all other protocols and then coming back to fetal heart becomes very difficult. So that is the reason why you need to be opportunistic. So fetal position is extremely important for us to evaluate the fetal heart. And then the second thing is the presence of adequate liquor. Whenever there is a oligohydramnios, it becomes very difficult because quite often the fetal parts will be crowding. When they are crowded, it becomes very difficult, but quite often what happens is either the shoulder or the forearms or the hands are right in front of the chest or the thorax. That makes it very, very difficult to evaluate the fetal heart. Then comes the maternal habitus, which is one of the greatest hindrances that we are going to face in our practice, because as things are progressing, I come to see mothers who are very, very obese, high BMI patients. It becomes very difficult. It's almost you sit on them. So in order to compress their anterior abdominal wall, which is quite thick, bulging, and then so that of course we can't avoid. That is part of our life. So we have to get going with it. So that is one thing which also influences the ability to evaluate the fetal heart. And of course, the mission settings, appropriate mission settings. Yesterday I have taken you through the various mission settings that have to be followed in order to get an optimal image of the fetal heart. So these are all the factors which will influence the evaluation of the fetal heart. Now, basically, we all know that heart is in the middle mediastinum and the lungs are there on either sides, and at the same time, 1/3 of the heart is onto the right and 2/3 to the left. At the same time, the apex is always to the left and anterior, and understanding this abnormal cardiac anatomy can be simplified by following what is called as the sequential segmental evaluation or analysis of the fetal heart. So that is the basic criteria. So today's talk is to, first and foremost thing is to clarify various descriptive terms that we are going to use, because it has to be universally followed. That is one. Two is segmental sequential analysis is a systematic evaluation of the fetal heart. So if you go through this particular image, you can see that there are almost about 7 sections that we are going to take. First and foremost thing is start with the upper abdomen of the fetus, wherein yesterday I have shown you very clearly what are the factors that you are going to look for in the upper abdomen. Then as you move your transducer cephalad, that is towards the cranium, what happens is you see the fourth chamber, then you see the left ventricular outflow tract, then you see the short axis view, that is the right ventricular outflow tract, and then you have the 3-vessel view, and then the sagittal sections which tells you about the aortic arch and the ductal arch as well as the bicable view. So these are all the things that you are going to do as far as the fetal heart is concerned, and this approach is what is called as the sequential segmental evaluation of fetal heart. This is very, very simple. If you follow the technique, it becomes very easy for us to do it, practice it daily. Now, when you start off, there are 2 things that you can do. One is what is called as the sweep technique, where you sweep your transducer from the upper abdomen of the fetus to the upper mediastinum. The second one is what is called as the rotation technique, where you rotate your transducer in order to get the outflow tracks. But then this rotation technique is a little complicated, so I would not advise you to practice that. I would definitely advise you to practice a sweep technique where you use your transducer, gradually move your transducer upwards. As you can see here, I have started evaluating the fetal abdomen, and you know all the structures which we are going to look for as far as the fetal abdomen is concerned. For example, you have this one where you can see that the fetal abdomen, where there is a stomach, you have the abdominal aorta, and then the superior inferior vena cava. And this relationship between these two vessels is extremely important. Then I move on to the next step, that is the four-chamber view. As I take the sweep upwards, then I see the four chambers view. Here there are certain factors which I am going to concentrate upon. Similarly, later on then I will go for the left ventricular outflow tract, that is the LVOT, and then the RVOT, and then we get the three-vessel trachea view. So this is how you are going to take your transducer, sweep your transducer. So from tomorrow morning, when you go back to practice, start evaluating the fetal heart in this fashion, so that you will be very comfortable identifying various normal anatomical structures. Once you get the hang of identifying the normal various abdominal structures, then you can use the same sequential segmental evaluation of fetal heart for identifying complex cardiac abnormalities. I will show you how you can identify the complex cardiac abnormalities using the same technique. Now, whenever you see this sort of a sweep technique, the things that you are going to look for are the heart size. You know, always you compare it with the thorax. Then you have the shape of the heart, which also tells us something about the abnormalities of the fetal heart. Then the contractility of the myocardium is extremely important. That tells us about the myocardial status. And then we need to determine the atrial and visceral situs. That is what is called as the laterality. Yesterday we had a good discussion about the laterality of the fetus, how to identify or label the laterality of the fetus. When I say laterality of the fetus, it is basically intending that which is the right side of the fetus and which is the left side of the fetus. That is then we have four-chamber view, where we try to evaluate the chamber morphology, chamber sizes, chamber orientation, chamber relationships or connections. And then we have the five-chamber view, which is nothing but the left ventricular outflow tract, and then the short axis view, where you can see the right atrium, right ventricle, pulmonary artery, and then the bifurcation of the aorta. Then we have three-vessel and bicaval, of course the sagittal sections, which are intended to evaluate the superior vena cava and inferior vena cava opening into the right atrium, as well as the aortic arch and the ductal arch. You can use M mode in order to identify the rhythm of the heart, as well as the rate of the fetal heart rate. And then cardiac biometry can also be used in order to identify the chamber discrepancies. And then invariably, whenever you evaluate the fetal heart, it is always essential that you have to put the color on and evaluate the fetal heart. So these are the things that you are going to take care of. Now, coming to the fetal heart shape. Normally, you all know that the fetal heart has got an elliptical shape. Why is it elliptical? Because its length is more than the width. That is one most important thing that whenever the width becomes more and the length becomes less, it becomes globular. So whenever you have a globular heart, the shape of the heart itself indicates that there is something wrong with the fetal heart, and that is one clue that you pick up as early as not only identifying the size, but also identifying the shape of the heart. Then comes the contractility of the heart, wherein normally we know that the cardiac contractility is the one which has to be evaluated, and there will be what you call it as the right and left ventricular contractility should be equal, and there should not be any paradoxical contractility or paradoxical movements of the interventricular septum. This is extremely important. Whenever you have asymmetry, that is, whenever you have that there is a contractility which is abnormal, wherein you have the left ventricle contracting on its own, the right ventricle contracting on its own, invariably you will end up with finding a what you call it as the paradoxical movement will be there, and which tells you that there is a contractility abnormality or rhythm abnormalities which are present. So these are the basic factors that you are going to do whenever you try to evaluate the four-chamber view. Then comes the visceral situs. This is yesterday we had an extensive discussion. I'm not going to take you through the whole thing. Basically, it indicates the right side and left side of the fetus. And when you want to do, I ask 3 questions. One is the presentation, second is the lie, and the third is the relationship of the fetal spine to the maternal spine. If I can answer those questions, I know which side is the right side and left side, putting myself in that same position so that it becomes easy for me to identify the right and left side of the fetus. Now, once that is done, then we have the heart size. Heart size basically is intended to evaluate and most important thing is that the cardiothoracic ratio is always, the mean value is about 0.45 at 17 weeks and 0.5 at term. So, the heart size does not, the ratio between, that is the cardiothoracic ratio, will always be consistently 0.5, less than 0.5. So, that is one thing which you have to keep in mind. Then evaluating the fetal heart chambers, you can do it, the size of the chambers can be most often done subjectively, because when you eyeball them, which is bigger and which is smaller. As we all know, all the chambers should be of equal size, and whenever there is a discrepancy between the sizes, then you call it as a discrepant size of the fetal heart, a particular chamber, and that gives you a clue about the possible cardiac abnormality. Then next is there are certain parameters by which you can measure the fetal heart and conclude the size of the heart, or you can put it on to percentiles or z-scores also. And remember, one most important thing is RV-LV ratio is always less than 1.29. So that gives us the ventricular discrepancy very easily identified. If you just measure that one and try to evaluate the ratio, if it is less, it should be always less than 1.29. Anything altered definitely indicates that there is some discrepancy in the ventricular size. Now, the next important thing is, of course, this is the situs. And now, when we come to the 4-chamber view, there are certain factors that we have to do. First and foremost thing is, getting 4-chamber view is very, very easy, because it is nothing but the axial section of the fetal thorax, wherein you can get the 4 chambers very clearly delineated. And then when you want to get this one, you go from the abdomen upwards, and the first section that you are going to get after the sweep is the 4-chamber view. And subsequently, the probe is cephalid, and then the limitation, most important limitation that you should keep in mind is that 4-chamber view has a limited value in evaluating conotruncal abnormalities. So that is one thing which you have to always keep in mind, because and then if you take the abnormalities that you can identify based only on cardiac 4-chamber view is only about 40%. So you are going to miss about 60% of the conotruncal abnormalities, which can be easily missed if you just concentrate only on the 4-chamber view. That is the reason why the guidelines have extended it to saying that you need to do an outflow tract evaluation also along with the 4-chamber view. Now, when you try to evaluate the 4 chambers, what are the points that you are going to look for? First and foremost thing is, are there 4 chambers or not? That is 1. 2, compare the sizes of each of these chambers. 3, what are the morphological features of each of the chambers? And then we need to identify the coronary sinus in case if it is seen clearly, but then quite often it is not seen. But if it is seen, the second important question that you are going to ask is there any left superior vena cava, persistent left superior vena cava? Not only that, you again immediately your mind should work in such a way that you are going to think about any ventricular discrepancy, because coronary sinus being prominent is usually seen in coarctation of aorta, which is also associated with left superior vena cava. And then the crux of the heart. Crux of the heart is an extremely important thing. So, for example, you can see this is the drumstick appearance of the crux of the heart, and this is the one which is responsible for the development of the ostium primum, a membranous portion of the ventricular septum, septal leaflets on either side, that is the mitral as well as the, all 4 things are the ones which are dependent on the crux of the heart. And so identifying or looking for the crux of the heart is extremely important as far as the 4-chamber view is concerned. And then the ventricular septum is evaluated. 2 atrioventricular valves, that is the mitral as well as the tricuspid valves, have to be seen. Flow across the ones, once you put the color Doppler on, you can clearly evaluate. And another important factor which I always insist on a 4-chamber view is, don't forget to see the area behind the heart. Do you find anything abnormal in these images? Any one of you? It's a challenge. Very good. So there is a double vessel behind the left atrium. You all agree that this is the left atrium? Yes, no? And do you know these are the pulmonary veins? Yes? Normally, what is it that you have to see? Single aorta, whereas here you are seeing two vessels. So this is a double barrel sign. So identifying or looking for the area behind the heart is extremely important. So that is one thing which you have to always keep in mind. And then you have to identify the at least two pulmonary veins opening into the left atrium and presence or absence of the pericardial effusion or pericardial masses. Once that is done, I think this is the same thing. Now, chamber identification. How are you going to identify the chambers? There are certain features, that is the relationship to the adjacent structures. We all know that the anterior-most chamber is the right atrium, right ventricle, and the posterior-most chamber is the left atrium. Am I clear? Okay. Then that is one identification. Second important identification is that the presence of the morphological features or outflow tracts. You can take into consideration the outflow tracts. If you find the left ventricle, that is, you have the posterior-most chamber, that is the left atrium, and the one ventricle that is communicating with should be the left ventricle, and you look for the outflow tract. If you find the aorta coming out of it, you know that you are sure that it is a left ventricle. If the pulmonary artery is coming from it, that indicates that there could be a discordance or discordant ventriculo-arterial connection or atrioventricular connection. Next is this is the left ventricular outflow tract, where you can see that it is called as left ventricle because of the aorta coming out of it. The third one is the pulmonary artery coming out of, and then the location of the atrioventricular valves is also an important factor which tells us which chamber which we are dealing with. And then we have the opening of the pulmonary veins and then the flap of the foramen veil as well as the chamber morphology. So these are all the factors which will tell us about the ventricles or the chambers identification. So basically, when you start evaluating the four chamber view, first and foremost thing, you have to identify the relationship, which is anterior, which is posterior, that is one. Two is which is the outflow tract that is appearing from that particular ventricle. Two. Three is to identify the atrioventricular valves. So once you see the atrioventricular valves, you know that very well that the tricuspid valve has an offset. It is closer to the apex. So this tells us that it is the tricuspid valve. And remember, one more important thing is these atrioventricular valves are wedded to the ventricular mass. If it is a tricuspid valve which is onto the right side, between the right atrium and the right ventricle, if the right ventricle moves on to the left side and it becomes the left-sided right ventricle, the tricuspid also moves along with it. It is very faithful to it. It does not deceive it, and it doesn't remain on the other side. So remember that whenever by identifying the tricuspid valve, if there is an outset onto the left side, you know that there is a ventricular shift. Is that clear? Am I clear? Yeah. So that is one important thing. So this is one thing which can tell us about the ventricle which we are identifying. And along with it, we have what is called as the moderator band, which tells us that it is the right ventricle. So these are the factors that you have to keep in mind. Now coming to the outflow tracts, we have two vessels, that is the aorta and the pulmonary artery, and the connections have to be established whether they are appropriately connected to that particular ventricle. That means the aorta is connected to the left ventricle and the pulmonary artery is connected to the right ventricle. Size of the vessels, great vessels, are also important. Position of the great vessels and adequate opening of the arterial walls, as well as the great vessel approximate size and crossover sign. These are the things that you are going to look for as far as the outflow tracts are concerned. Now here we can very clearly delineate that this is the left ventricular outflow tract. You can have a smooth walled left ventricle, and then you can see that there is the left ventricle. As you can see gradually, you can very nicely appreciate that is the left ventricular outflow tract. Am I clear here? So this is the interventricular septum, that is the root of the aorta, and this is what is called as the septo-aortic continuity. You need to establish the septo-aortic continuity. Once you identify the septo-aortic continuity, you know that you can rule out the possibility of a ventricular septal defect, particularly at the membranous portion. The reason why I am telling it to you is that when you are evaluating the fetal heart in the apical four-chamber view, that is, when you are seeing the heart from the apex of the heart, there is always a possibility of an echo dropout at the membranous portion of the ventricular septum. Whenever that is there, you need to tilt your transducer in such a way that you are going to get this the septo-aortic continuity. Establish this one, then it indicates that there is no ventricular septal defect. If you cannot establish this, yes, you have to think in terms of a possible membranous portion of the VSD. That is one. Second important thing is, you know that this is an obtuse angle, isn't it? Instead of that, if it becomes an acute angle, then you know that this is an overriding of the aorta. So these are the two things that you have to keep in mind. Not only that, along with it, you can also find what is called as the aortomitral continuity can also be established. So these are the things that you are going to look for as far as the left ventricular outflow tract is concerned. And coming to the right ventricular outflow tract is concerned, you know that this is the vessel which is arising from the anterior chamber, that is the right ventricle, and you always need to look for the crossover, which Silpa has also showed us that. You remember that the right ventricular outflow tract pulmonary artery is arising on the right side and moving towards the left shoulder, whereas the aorta, that is the left ventricular outflow tract, arises from the left side and moves towards the right shoulder. So they are going to crisscross. That establishing the crisscrossness is very, very important. As you can see here, this is the crisscrossing that you have to establish every time. Once you establish this crisscross, then you know that you are not dealing with a parallel vessel abnormality. So this is one more thing which will help us in identifying the abnormalities. Then comes the three vessel view, where you are going to identify all the three vessels. We know that the three vessels are the pulmonary artery, aorta, as well as the superior vena cava, which is also known as pars. And these things, they are the things that we are going to look for. Is one and most important thing is the sizes of the vessels, alignment of the vessel, and then the position of the vessel, as well as the direction of flow. These are the four factors that you are going to look for. That is, the alignment is pars, that is left to right, anterior to posterior is pulmonary artery, aorta, and superior vena cava. That is left to right and anterior to posterior. And then we have what is called as the size is, the largest is the pulmonary artery, second largest is the aorta, and the smallest is the superior vena cava. Then all these vessels are, these two vessels, that is the aorta and the pulmonary artery, are always left of trachea. That is 3. 4 is the direction of flow. Always the flow in both these vessels are similar colored. That is, either they are moving, because the blood flows away from the heart, depending on the apical four-chamber view or the basal four-chamber view you have taken, it depends the color coding, and that color coding should be same in both these vessels. So this is how you are going to look for as far as the three vessel view is concerned. Now this is the classical example where you can see that there are three vessels used, and you can see the sizes is left to right. You can beautifully demonstrate that this is the pulmonary artery, aorta, and the superior vena cava. These are the intermammary vessels, and then this is the thalamus, which you can see here. So these are the things that you have to look for. Now coming to the other things is, now I'm coming to the most important aspect. Am I overshooting? Have a little time? Because this is one most important thing is that we can use this sequential segmental evaluation in evaluating normal as well as abnormal hearts. That is one most important message that I wanted to convey. Simple abnormalities like a ventricular septal defect, or for example a pulmonary stenosis, or for example an aortic stenosis can be easily made out. But then complex cardiac abnormalities are the ones which we need to have a systematic approach, which will help us to reasonably come to a good conclusion. That is when you start evaluating the complex cardiac abnormalities based on sequential segmental evaluation. What is the sequential segmental evaluation? Whether it is a normal heart or an abnormal heart, there are three segments that we have to keep in mind. What are these three segments? One is the atria, 2 is the ventricle, 3 is the great arteries. Remember all these three segments, evaluate each one of them based on certain factors which you have to consider, and that gives you an answer about the cardiac abnormality. So that is how you are going to follow this, and that is how this sequential segmental evaluation helps you in identifying complex cardiac abnormalities. Now, most important thing here is, you are not going to label a chamber based on its position, but you are going to label a chamber based on its morphological features. For example, if you have a left atrium, you are going to call it as a left atrium because there are two pulmonary veins which are opening to it, and not only that, there is a foramen ovale which is bulging towards that, and not only that, it is posteriorly, most posterior chamber. So these are the factors which are, and similarly, you have the right ventricle, you have to have the moderator band, you have to have the caudal tennae which is attached to the interventricular septum. So these are the things that will tell you morphologically that that is the right ventricle. So depend on the morphological features, not on the spatial relationship. That is 2. Then next is the atria are separated from the ventricles by what is called as the AV valves, that the atrioventricular valves, which are located at the atrioventricular junction. Similarly, the ventricles are connected to the arteries by what is called as the ventriculo-arterial connections. So these are the factors that you have to keep in mind. So the three segment template that is being used for sequential segmental evaluation is: 1 is the atria, this is the atria; 2 is the ventricle; 3 is the great arteries. The connections are the atrioventricular valve, this is the tricuspid, this is the mitral valve. Then we have the great arteries, that is the aorta as well, pulmonary artery and the aorta. So these are the things that you are going to evaluate, and this all is what is called as the connections and relationships. So this is very, very, very important, and this is going to help us in identifying complex cardiac abnormalities. So how are we going to go about it? Step 1 is that first and foremost thing, you are going to identify the atrial situs is determined. We know how to determine the atrial situs, isn't it? Once you have established the laterality of the fetus, you know which chamber is on which side, and based on that you can identify the atrial situs. That is one step. Step 2 is to identify the atrioventricular and ventriculo-arterial connections. They have to be established whether they are there or not. If they are there, then next step, that is the third step, is whether the appropriate atria is opening into the appropriate ventricle, whether the appropriate ventricle is opening into the appropriate artery is what you have to establish. So that is the third step. And the fourth step is to ascertain the spatial relationship, whether right is onto the right, left is onto the left, anterior is onto the anterior, posterior is onto the posterior. Am I clear? Because this is an extremely useful thing that if you start practicing from tomorrow onwards using this particular technique, identifying complex cardiac diseases becomes much, much more easier for you. So that's the reason why I am spending a little more time on this. Am I clear till now? I am not able to hear it. Yes. So you are all awake. Good. Now coming to the laterality, yes, we have already discussed about the laterality so many times, so I don't need to repeat once again. Now there are three things that you are going to do. One is the situs solutus, 2 is situs inversus, 3 is situs ambiguous, isn't it? Now when you call it as a situs salutus, what does that situs salutus means? That means the right-sided structures are on the right side, left-sided structures are on the left side. That means right-sided structures like the liver, inferior vena cava, superior vena cava, right atrium and its appendage. This is what is very, very important. Right atrium and the appendage is onto the right side, and then the trilobed right lung as well as eparterial bronchus. Of course, the trilobed right lung as well as the eparterial bronchus we cannot identify. So basically we depend upon the liver, inferior vena cava, and the right atrium as well as the right atrial appendage, which tells you that this is on the right. And the left atrial structures or the left-sided structures are on the left side. Like suppose, for example, the stomach, spleen, and the left atrial appendage are onto the left side. So this is, once you identify these structures by doing a sweep technique from the fetal abdomen to the upper abdomen, thorax, then you know that the situs is solutus or not. That is, is it the left-sided structures are on the left side and right-sided structures are on the right side. That is one. Step 2 is to identify the inverses. Inverses is nothing but a mirror image. That is, the same situs solutus, the right-sided structures become left-sided and left-sided structures become right-sided. So that itself is what is situs inverses, in which the incidence of congenital heart disease are hardly 5%. The rest of all is usually normal. So we are not really bothered about it, but then still we follow the same protocol. Then the third one is the situs ambiguous. This is one thing which is very, very important. When I say ambiguous, I mean that it is either a right isomerism or left isomerism. What are these words? Isomerism, right isomerism, left isomerism, they are very complex and it really puts you down. But simple way of understanding is when I say right isomerism, it is more of right-sidedness. This is a simple way of understanding, and the left-sided isomerism means it is more of left-sidedness. What does that mean? That means if I say right isomerism, which means that there is a more of right-sidedness, that indicates that more of right-sided structures are present. So, for example, the right atrial appendage, which should be seen only on the right side, instead of being on the right side, is also seen on the left side. That is one. Second thing is the right-sided is more. So, what happens? The liver becomes bigger, isn't it? So that the stomach becomes smaller, the spleen becomes absent. So, that is right-sidedness. Is that clear? Similarly, if you take left-sidedness, the left-sided structures are more. That means what happens to left-sided structures? The left atrial appendage will be seen on both sides. Not only that, the inferior vena cava, which is right-sided, gets disappeared. So, it is replaced by azygos continuity. That is when you have this double barrel sign. Am I clear now? So, this is how you are going to identify the right-sidedness and left-sidedness. So, that is one thing which tells us about the situs ambiguous. So, okay. Now, it is very easy to tell that it is right atrial appendage, left atrial, but then it's to identify is what is important for us, because in day-to-day practice, when you find this sort of a broad outline on both the sides, it is definitely the right atrial appendage which is prominent on both sides. Whereas when you find this sort of a finger-like projection, can you see this finger-like projection? This says that it is a left atrial appendage. So, this is how you are going to identify the appendages, which is not that easy when you are trying to evaluate for the first time. When you see the 4-chamber view, try continuously to get these appendages so that you can be able to identify when it is really required. Now, the reliable science that you can follow is taking the upper abdominal section. See, I have been insisting so much on this upper abdominal section. The reason is that this is absolutely normal situs, isn't it? You have the left-sided aorta, right-sided inferior vena cava, which is above and anterior. Whereas on the mirror image, you have the right-sided, the inferior vena cava is onto the left side, aorta is onto the right side. Then when we have a left isomerism, as I said, the left-sided more, what happens is either the left atrial isomerism, what happens is you have the aorta and the aorta and this thing, or is it aorta and the azygos vein, because the left-sidedness is more, so inferior vena cava disappears and the continuity is by the azygos system. Whereas in the right-sided isomerism, both the vessels are on the same side, whether it is on the right side or on the left side. Am I clear till now? So, using this particular section itself, you can definitely identify whether there is any ambiguity or not, or whether there is any inverses, situs inverses or not. This is as simple as that. That is one. This is supposed to show you that this is the double vessel sign, where you have both the vessels are adjacent to it. Here you can see the anterior and posterior relationship of the inferior vena cava and the aorta, which are parallel to each other in the abdominal wall. Then comes the right side isomerism, where you can see that the right-sided structures will be more. So, you can see both the vessels are adjacent to each other at the same level. So, this is one thing. Associated with it, abnormalities, I am not talking about them. I will take you through them a little later. Now, coming to the atrioventricular junction. So, once you have identified the atrial situs, then you are coming down to the atrioventricular junctions. Most important thing is the AV connection is the continuity of the atrial chamber to the ventricular chamber. That is what is called as the AV junction. The connection of the atrium and the ventricle, if a right atrium communicates with the right ventricle and left atrium communicates with the left ventricle, it is what is called as the biventricular AV connection. Am I clear? Because this is an extremely important thing that you should understand. Biventricular AV connection. This biventricular AV connection can be concordant. When do you say concordant? When the right atrium opens into the right ventricle, left atrium opens into the left ventricle, you call it as a concordant biventricular AV connection. Am I clear? Right. So, I will show you the image. Now, here, can you appreciate this? This is the right atrial appendage, which is broad. This is the finger-like left atrial appendage. You know that the right atrium is communicating with the morphological right ventricle. Left atrium is communicating with the morphological left ventricle. So, this is definitely a concordant atrioventricular junction. You agree with me? Yes. Now, you tell me what is this. What is happening here? This is the right atrial appendage. this is the left atrial appendage. Right atrial appendage is communicating with left ventricle, whereas the left atrial appendage is communicating with right ventricle. So it is a discordance, that is atrioventricular discordance. Now, next one. How about this? The same thing you are here, only thing is that there is a flip, isn't it? The left atrial appendage is onto the right side, right atrial appendage is onto the left side, but the left atrial appendage is communicating with the left ventricle, right atrial appendage is communicating with the right ventricle. So there is no problem, it is only a mirror image, right? Whereas here you can see that the left atrial appendage is communicating with the right ventricle, whereas the right ventricular appendage is communicating with the left ventricle. So this is a discordance. In spite of reversal, that is the mirror image inversion, there is a discordance also. So there is an inversion associated with the discordance. That is one. Second, now here we have isomerism. What is isomerism? Here you have both the right atrial appendages. Both the appendages are right atrial appendages and they are communicating with the same right ventricle and the left ventricle. Whereas here you have the right atrial, here the right ventricle is onto the right side, left ventricle is onto the left side. Whereas here the right ventricle is onto the left side and left ventricle is onto the right side. Am I clear? Because I don't want to confuse you. This atrioventricular communications, if you can understand clearly, after the atrial situs, if you understand these AV connections, whether it is a biventricular, if it is biventricular, is it concordant, discordant or ambiguous, you are done. You most of the complex cardiac abnormalities you can be able to easily identify it. Similarly, you have the other things also, that is the left atrial isomerism. Now, once you have established the atrioventricular junction, there are situations where you may find that there is a communication of two atria into one ventricular mass. Am I clear? Two atria opening into one ventricular cavity. Once it opens that one, then you call it as what is called as the univentricular AV connection. Till now we have agreed about the biventricular AV connection. Now we are talking about the univentricular AV connection. This again univentricular AV connection can be double inlet ventricle or it can be absent right AV, absent left AV connection. So I will show you these things. So this is here. What is the morphology of this ventricle? Right ventricular morphology. So both the atria are opening into it. So the dominant ventricle is, so this is what is called as the double inlet right ventricle. We don't call it as double inlet left ventricle. Am I clear? So based on the morphology of the univentricle, you will call it as either a double ventricle right ventricle or a double ventricle left ventricle. Right. Now, the second situation is, the scenario is that absent right atrial connection, atrioventricular connection. That is, here you can see the right atrium, you can see a hypoplastic right atrium, you can see that the left atrium is opening into the left ventricle. Okay? So this is concordant, but then there is an absence of right AV connection. Similarly, there can be absence of left AV connection. So, hypoplastic right heart, hypoplastic left heart are the ones which you are going to see as a univentricular AV connection. Am I clear till now? Right, very good, wonderful. So, this is nothing but you can see here, very nicely seen, where you can see that. Tell me what is this? Come on. Aorta? Yes, you see, you know, all of you know it, tell no, you have to talk. This is aorta. You can see both the pulmonary veins opening into the left atrium. This is left atrium. This is the ventricle. Which ventricle is this? Right ventricle. So there is a atrioventricular discordance. Agreed. Right. Here you have a univentricle. There is one ventricle because this is absolutely obliterated and both the things are opening into this. And this ventricle is right ventricle because moderator band is there. So this is a double inlet right ventricle, okay, and hypoplastic left ventricle. Am I clear? Right. So you have other situations where you have a double inlet left ventricle because both the atria are opening into a ventricular chamber which has a morphology of the left ventricle. That's why I call it as a double inlet left ventricle. Am I clear now? So what are the things? Atrial situs, biventricle or univentricle and their connections. Is that clear now? So this is what you are going to do. The second important thing is the atrioventricular valves can be atretic or patent or whatever it is. Then next is the arterioventricular junction. The first most important thing is, that means we need to first and foremost thing identify the which vessel it is. How do you identify which vessel it is? The aorta will never branch. Am I clear? Whereas the pulmonary artery is the one which branches. If you have a vessel which is coming from a chamber, which is branching, it has to be pulmonary artery. If you have a vessel which is coming from a chamber, which is not branching, it has to be aorta. So based on that, the communication with the ventricular mass is what you have to identify. That will tell you whether there is a concordance or discordance. Am I clear up to this? So based on that, what we will do is, we will have a concordant, discordant, double outlet right ventricle or double outlet left ventricle, single outlet, that is the CAT, that is there is a single arterial communication. So here what do you think so? Okay. Oh, sorry. Tell me, what do you call this? What is chamber this? Morphology. So first go to the morphology. What is this chamber? Left ventricle, agreed, because this is the moderator band. How about this vessel? So there is a ventriculo-arterial discordance, agreed? Right. Then what about this? One second, I will freeze it and show you. Now, this is the which chamber? Moderator band, right ventricle, and you have both the vessels coming out of it. You can see here also. See this? Both the vessels are coming from this. So it is a double outlet right ventricle. Then comes the common arterial trunk. You can see there is only a single ventricle, a single artery which is coming, and then the pulmonary artery is arising from the root of the aorta. So this is a classical common arterial trunk. So these are the various things, and of course whenever you have the atrioventricular valves or the arterioventricular valves which are straddling or overriding, this is when you see that this sort of a overriding of a great vessel. Am I clear till now? Yes? Or I have confused more? Confused more? No. I hope I have not. Now coming to the venous connections. Now venous connections are systemic connections. Systemic venous connections are inferior vena cava, basically inferior and superior vena cava. Whether the inferior vena cava is opening into the right atrium or not, whether the ductus venosus is opening into the superior vena cava, the inferior vena cava or not, these are the things that you are going to look for as far as the systemic connections are concerned. And pulmonary venous connections are concerned, whether both the pulmonary veins are opening into the right atrium or they are forming a common chamber and opening into the right atrium. That tells you about the venous connections, and that tells you about the possibility of a TAPVS, that is total anomalous pulmonary venous drain. Am I clear? So this is how you are going to approach the whole of the cardiac complex. So cardiac position, of course, depending on that. So the algorithm is very, very important because we have a 3-step template. The 3 steps are the atria, ventricles, great arteries. In the atria, we have the atrial situs. That is, by establishing the laterality, you say that situs solitus, situs inversus, situs ambiguous. In the ventricle, first and foremost thing is the atrioventricular junction. In the atrioventricular junction, we have either a biventricular configuration or a univentricular configuration. In the ventriculo-arterial junction, we have concordance, discordance, or double outlet or single outlet. Am I clear? So all these things are nothing but connections and relationships. Am I clean? So using this sequential segmental evaluation, using these connections and relationships or identifying these connections and relationships, you are 100% sure that complex cardiac abnormalities can be easily identified. You agree with me or no? Very good. So tomorrow onwards, you are going to do that. Thank you very much.
Thank you, sir. There is slight change in this program. Now there is third talk is Dr. Manoj Jadhav, sir. It is a case presentation. Dr. Manoj Jadhav, sir, is a consultant radiologist and fetal-maternal imaging consultant at Barshi. He completed his fellowship in fetal medicine. Over to you, sir. Thank you.
The other talk by Dr. Sujit will be after the inauguration ceremony. We shall have the inauguration ceremony just after Manoj sir's lecture, that is at 11 o'clock. All are requested to please be seated in the hall. We'll have the Municipal Commissioner, Mrs. Teli ma'am. She will be there as chief guest. So because she's coming at 11, we shall just have the inauguration first and then we shall continue with the lectures. The students who have given poster presentations and have been told to come at the have been told to collect backstage for a small discussion with the judges. The students are already informed, so please please go backstage along with Anirudh sir and Praveen sir.
Slides are not seen. Good morning to one and all. Thank you, SFM, for giving me this opportunity to present my case. I would like to thank Vaibhav Meru sir and Sujit sir for giving me this opportunity. We are running very short of time, so I will be very quick. So, history, 22-year primary, non-consanguineous marriage, came to me for growth and Doppler at around 30 weeks, with NT and anomaly scan being normal. So, this is the first section, the heart. If you see, situs is normal, the chambers are normals, the atrioventricular concordance is normal, crux is normal. So, apparently this heart looks normal. When you put color, it also looks normal, no obvious VSD. If you go to the LVOT, it also looks normal. So, when I go to the 3-vessel tracheal view, I see one extra vessel which is left to the pulmonary artery. When you see extra vessel, first thing which comes in your mind is persistent left SVC. But here, very important point to note that the superior vena cava is dilated. It is dilated as big as your aorta. So that is one important point. Second, if you go to the upper section, in upper mediastinum, if you see a brachiocephalic vein, in PLSVC, brachiocephaly is most of the time it is absent. Now here we can see the brachiocephalic, and not only it is present, but it looks to be dilated. This is a PLSVC. Compare with this, the size of the SVC, as well as in upper mediastinum, there will be absence of the brachiocephalic. When you put the color, you get this image. You see the direction of the color flow. It is different. One is showing red, one is showing blue. Compare with this PLSVC. Both vessels are showing the same color. That means the blood is flowing towards the hearts in both vessels. Here, blood direction is different. That means we are not dealing with the persistent left VSC. So, when I go to the again, I will go to the 4-chamber view to look carefully the left atrium. Now you can appreciate the left atrium wall is very smooth and pulmonary veins are not opening into the left atrium. Now here you see this is a normal heart. See how the pulmonary veins are opening into the left atrium. And in this clip you see the coronary sinus is normal. Here you see the coronary sinus is normal. In case of the PLSVC, the coronary sinus would be dilated. Okay. So then on color I try to demonstrate the pulmonary vein, but here it is appearing that the pulmonary veins are opening into the left atrium. So you get confused on color. So you have to use your color very cautiously. You have to adjust your balance, you have to adjust your scale. Now you can appreciate that there is a thin membrane which is separating the pulmonary veins from the left atrium. And on grayscale also you see there is a confluent vein behind the left atrium. Okay. So I tried to trace that confluent vein, it is going above. Okay. On color also, if you see, the pulmonary veins are opening into this common chamber. Okay. So when I did a pulse Doppler of the pulmonary veins, this is the abnormal waveform I achieved. Okay. And when I measured the brachiocephalic vein and the diameter is absolutely above the normal, and post LS space index is abnormal. I will explain in later section what is post LS space index. So this is a 3D stick acquisition of this abnormality. This is a top view of the fetal heart. This is a pulmonary, this is aorta. If you see, this is a vertical vein which is joining the brachiocephalic and then connecting to the superior vena cava and finally draining into the right atrium. Now this is a posterior view of the fetal heart. You see, this is the left-sided pulmonary veins. These are the right-sided pulmonary veins forming a confluence here. They are joining to the vertical vein, then communicating with the brachiocephalic and finally draining into the right atrium via superior vena cava. You note the color direction. Here it is red, here it is blue. That means they are moving in a different direction. So to summarize the findings, we see the pulmonary veins are not opening into the left atrium. There is baldness of the left atrium. There is a confluent vein behind the left atrium. There is increased retroatrial space. There is vertical vein in prevessal tracheal view. And you see a dilation of the brachiocephalic as well as the superior vena cava. And there is abnormal pulse wave Doppler of the pulmonary veins. So all these findings are very typical for the supracardiac type of TAPVC. So after diagnosing, I informed the gynecologist and counseled the couple that this baby need to be delivered in a tertiary care center. So, but unfortunately, the baby delivered in some rural setup. But good thing is that the normal baby delivered, 2.9 kg healthy baby. After 2 or 3 days of delivery, the parents called me, ki baby is feeding well, everything is fine. You said there is problem, but the baby is absolutely fine. So I said there is a problem, you need to confirm postnatally by doing an echo. So this is a postnatal echo. Okay. So you see there is a confluent vein or common chamber behind the heart, and there is a vertical vein. So now why baby is not symptomatic? If the pulmonary veins are not draining into the right atrium, not draining into the left atrium, baby should have cyanosis. But here, if you see the echo report carefully, you see they have mentioned unobstructed type. That is first important thing. Second important thing to note that there is a large atrial septal defect with right to left stent. So because of that, the blood which is coming to the right atrium, finally going into the left atrium and then the systemic circulation. Because of that, baby is not symptomatic at this point of time. And this kind of large ASD are life-saving to this baby in this patient. So moment the ASD will close, baby will have respiratory distress and baby will go into the cyanosis and eventually baby will die. So if you see here, the saturation is 89 because there is mixing of the arterial and venous blood. So the baby weight was at delivery it was 2.9 and baby was not symptomatic. So they suggested the conservative management at that point of time and the surgical correction at 2 to 3 months of age, because the weight less than 6 kg will have the poor prognostic factor. So we will review some literature, what is the detection rate of this rare anomaly. This is the largest, some older study. They studied 424 cases. You see there is only 8 cases they could detect. That means 1.9% detection rate. It means practically zero detection rate in the past. Even some patients has a family history of CSD, still they could not detect. Another study from USA, if you see the detection rate of various congenital heart disease, TAPVC is at the top. That means the lowest detection rate. And if you see the hypoplastic left heart syndrome, which is having the highest detection rate. Interestingly, both are the abnormality of the 4-chamber view, but TAPVC is having the low detection rate. Another study from France, they studied 10 cases. If you see carefully, the gestational age as which it was detected, lowest was at 24 weeks. So it is really difficult to detect in the early gestation. So why it is difficult? So there are technical factors and there are some inherent factors, like these cases can be isolated. So isolated, if it is there, then it becomes difficult to diagnose. And as we know that as compared to the adult circulation, in fetal circulation, only 13% of the cardiac output goes to the pulmonary at around 20 weeks. It may increase to 25 in later gestation. Because of that, the pulmonary veins are very small. With the previous grayscale and color resolution, it was difficult to detect these pulmonary veins. So in next slides, I will review the anatomy of the pulmonary veins. I will tell you the patterns of the TAPVC and I will give you some clues to detect the TAPVC. So as we know, during the formation of the left atrium, there are 4 pulmonary veins, 1 pair on each side. They drain directly into the left atrium. On ultrasound, on 4-chamber view, what we see here, the two pulmonary veins, what are they? Inferior or superior? Inferior pulmonary veins. They drain directly into the left atrium. Okay. On color, you see the two pulmonary veins that are directly draining into the left atrium. So what is this extra cystic-like structure? This is esophagus. Don't mistake this as azygos or the confluent vein. So when you do the routine four-chamber view, you see two pulmonary veins with little difficulties. But when you reduce your PRF, increase your gain and get the lateral four-chamber view, you can demonstrate all four pulmonary veins. And by adjusting the balance, you can demonstrate the crisp and clear pulmonary veins in one section also. So when you do the pulse Doppler of the pulmonary veins, you get the waveform like this. This is biphasic pulsatile waveform, something similar to the ductus venosus. This is systolic peak, this is diastolic peak, and small dip, that is a atrial contraction. In case of the TAPVC, there is obstruction to the pulmonary veins. Because of that, there is a loss of normal waveform. You will get this kind of waveform. Like in this case of HLHS also, because of there is increased pressure in the left atrium, there is deepening of the A wave. So with the help of advancement in the technology like stick, we can demonstrate the all four pulmonary veins in one section. Okay, how to get that? Get the lateral four-chamber view, reduce the PRF, adjust your balance, get the stick volume acquisition. Once you get these four images, make it single like this. So this is a raw image, you get it. Okay. Now you have to play with your SDF threshold, you have to play with your silhouette, you have to play with the color gain, and now you get these kind of images. So this is something looking like a crab. So someone has described a pulmonary vein attachment like a crab sign. So what is this anatomical structure? This is Coumadin ridge. This is a pericardial reflection tissue into the left atrium, which separates the left atrial appendages from the left superior pulmonary vein. So when you see that, you also almost rules out TAPVC. Okay. So what is post-ALS space index? Kawazu from the Japan, they studied 8 cases and they suggested called as post-ALS space index. Actually, it is a ratio of distance between the posterior wall of the left atrium to the diameter of the aorta. So they used a cutoff of 1.2 and they got sensitivity of 100%. Means in almost all cases they got the post-ALS space index more than 1.2. So what, another study used a cutoff of 1 and they also got the sensitivity 100. What exactly they want to say? In normal condition, the area behind the left atrium is smaller than the diameter of aorta. Just keep eyeballing on this and no need to measure in routine cases. Okay, so what is the TAPVC? It is a total anomalous pulmonary venous connection where all four pulmonary veins drains abnormally into the right atrium, either directly or indirectly via the systemic venous circulation. And depending upon the level of systemic venous circulation, it has been divided into the 4 types. Supracardiac is the commonest one, seen in about 50% of the cases. Second common is infracardiac, third is cardiac, and fourth is mixed, a combination of all these above. It can be divided as a total or partial based upon the number of pulmonary veins draining into the right atrium. And clinically, it can be classified as obstructed or non-obstructed. So supracardiac is obstructed in about 50% of the cases, and infracardiac is almost always obstructed. So it is a surgical emergency. So this is an image of the supracardiac TAPVC. You see 4 pulmonary veins forming confluence behind the left atrium. Then there is additional vertical vein which is joining the brachiocephalic and superior vena cava, and finally draining into the right atrium. Because these 2 vessels are receiving extra blood from the pulmonary circulation, because of that these vessels are dilated. Now in cardiac type, there is again formation of the confluence, but they drain into the right atrium directly or by coronary sinus, which will be dilated. And in infracardiac, confluent is formed again, but the blood goes below the diaphragm and drains into the portal vein and finally into the IVC, then into the right atrium. So what are the signs to detect the TAPVC in prenatal life? There are some direct signs which are very common to all TAPVC, that is confluent vein or absence of connection of pulmonary veins to the left atrium. And there are some indirect signs which are common to the all TAPVC, like increased retroatrial space, abnormal Doppler in pulmonary veins, smooth wall of the left atrium. And there are some signs which are specific to the type of TAPVC. That is additional vessel in 3-vessel tracheal view, dilatation of superior vena cava and brachiocephalic vein, or dilatation of coronary sinus in cardiac type of TAPVC, or vertical descending vein in case of the infracardiac TAPVC. And when you get, like Praveen sir just told us, when you get isomerism, you need to look for the area behind the heart. So which type of isomerism, right or left? Pulmonary veins are the left-sided structure. So in right isomerism, baby don't know about the left-sided structure. So in right isomerism, always look for the area behind the heart. And also in case of the abdominal situs or single ventricle or dextrocardia, also look the area behind the heart. So I will, now you are well versed with the anatomy, basic anatomy of the TAPVC, and then how to look the pulmonary veins. Now I will share a few cases in short. So now you see this is the 3-vessel view. Now you can see one extra vessel. The first thing you think of PLSVC, but note here the SVC is dilated and it is as big as your aorta. So it is not a PLSVC. So now you have to go to the 4th chamber, look for the confluent behind the left atrium. There is a confluence. So diagnosis is supracardiac TAPVC. Case 2, again you see 3-vessel tracheal view, you see a one extra vessel. Now note here the color direction, it is different. In persistent left SVC, you should see the same color in the extra vessel. Now here different color as well as SVC is dilated. So now I have to demonstrate the confluent. Now see the wall of the left atrium, it is smooth. There is confluent which is going above. That is a supracardiac TAPVC. Now this case, now when you see this kind of appearance to the heart, now you see there is a single ventricle, single atrium, there is whether it is a large unbalanced AVSD or monoventricle or monoatrium morphology, but always in this kind of cases, always focus on the area behind the heart. You see the confluent vein behind the heart. Now if I go to the parasagittal section of the heart, now I can see the one extra vessel. Apart from the IVC and the thoracic, descending thoracic aorta, there is one extra vessel which is crossing the diaphragm. So on color also we can confirm there is one extra vessel. So this is a infracardiac type of TAPVC. Now I will share last case. Now interesting case. Now see, there is a confluence in the 4th chamber view. We are now well versed to see the area behind the heart. Now if you see carefully where it is opening into the right atrium. You can confirm on color also. So normally pulmonary veins should drain into the left atrium. Here they are forming confluence and draining into the right atrium. So this is a cardiac type of TAPVC. Okay. So now what is this? You may think this is confluent vein, but don't mistaken this as a confluent vein. This is the trachea, tracheal bifurcation at the level of carina. If you trace this structure, it joins the trachea. So don't mistaken this as a confluent vein. Put the pulse, put the color and confirm it is not a confluent vein. Okay. So there is an approach to diagnose the TAPVC. Routine 4th chamber view, demonstrate at least 2 pulmonary veins connected to the left atrium. If you demonstrate that, you will rule out TAPVC in about 90% of the cases. So you are thinking that it is a normal heart. If you are not sure that there are 2 pulmonary veins which are connected to left atrium, then look for the increased retroatrial distance or confluent vein behind the heart. So if you see that, then you are suspecting the TAPVC. Okay, once you suspect the TAPVC, look for the 3-vessel tracheal view. If you see additional extra vessel in 3-vessel tracheal view, as well as dilatation of the superior vena cava or brachiocephalic vein, your diagnosis is supracardiac TAPVC. When you go to the upper abdomen, if you see one extra vessel between the IVC and aorta, then it is a infracardiac type of TAPVC. And when you see a dilated coronary sinus or direct connection of the pulmonary veins to the right atrium, then your diagnosis is cardiac type of TAPVC. And in routine 4th chamber view, as Praveen sir just told us, we have to look for the right and left heart chamber discrepancy. The normal ratio is 1.2. Okay, when you see a discrepancy, make sure that it is not physiological in the 3rd trimester, rules out the coarctation. If you rule out everything and if you see significant chamber discrepancy in the 4th chamber, then look for the signs of the TAPVC. So to summarize, it's a rare diagnosis, but I don't know whether it is rare or we missed in past a lot of cases, that's why it is rare. So always look the area behind the heart. When you are looking for the 4th chamber view, always demonstrate the 2 pulmonary veins directly connected to the left atrium. If you demonstrate that, you are ruling out almost all cases of the TAPVC. And when you see an extra vessel in a 3-vessel tracheal view, Look for the SVC. If it is dilated or big as aorta, then more often than not, it is a supracardiac type of TAPVC. And use your all instruments, weapons in diagnosing like grayscale, color Doppler, pulse Doppler, stick to come to your final diagnosis. Thank you.
Thank you, sir. Any questions from audience?
Okay. Twig sign is formed when the confluence of the pulmonary veins is formed behind the left atrium. It looks like a twig. Yeah. Just remember that the area behind the left atrium is always smaller than the diameter of aorta. So if you see a area behind the left atrium is bigger than the aorta, then you need to suspect the TAPVC. Just eyeball, because you cannot do in every patient post LS space index. It is not practical also. So you just have to eyeball whether aortic diameter and the area behind the left heart. Just compare with that. So you have to take distance from the posterior wall of the left atrium to the aorta divided by the aortic diameter. So if it is more than 1.2 or 1, it is that the area is increased. Thank you.
Space. You will falsely create an increased, retro LA space, and that is where the mistake happens. Wonderful, Manoj.
I request, these are the posters that the students have made while we are awaiting the guests. I would like every one of you to please pay a kind attention on all the posters. They'll be running in a loop, and these are the posters that have been judged today.
I request Chaudhary sir to please felicitate our speakers. Dr. TLN Praveen sir. Yes, he's there. I request to join Jamma ma'am, Tapadia ma'am.
So it has been a great learning experience for all of us today, and thank you so much. Thank you so much for that lecture.
I request Gurram sir to please felicitate Shilpa madam. I request Dabde sir, please felicitate Dr. Manoj Jadhav sir. Anjali ma'am, please join.
Kindly run the posters again on the screen. Just to save time later on, we shall be completing the rest of the felicitations of the speakers. So I kindly request Chaudhary sir once again to please come forward to please felicitate Anirudh Kulkarni sir. I request Naseem ma'am to please kindly come forward to felicitate Sumit Chamaria sir. Sumit sir. He's not. Special request to Ajit Gandhi sir to please come forward to felicitate Bimal Sahani sir. We have a chief guest here. Please welcome sir, welcome ma'am. Please come. Good afternoon, everyone. On behalf of Society of Fetal Medicine, Marathwada Chapter, Solapur Obstetric and Gynecological Society, and Solapur Chapter of Maharashtra State Branch of Indian Radiological and Imaging Association, MSB-IRIA, I, Dr. Anshu Sharma, extend a warm welcome to all the faculties and delegates and our chief guest and guest of honor for the day, on the second day of the scientific program of this third quarterly meet of SFM. Friends, this is a gathering of healthcare professionals and fetal medicine experts united in their quest to teach and learn about the advances in science and practice of fetal medicine, to improve the maternal and fetal care and shape the future of antenatal care. To set the ball rolling, I request the dignitaries to take their chairs on the dais. Mrs. Sheetal Teli Ugle, Commissioner, Solapur Municipal Corporation, our chief guest for today. Welcome, ma'am. Please come. Dr. Basavraj Lohare, Medical Officer of Health, our guest of honor for today. Dr. Bimal Sahani, National President of Society of Fetal Medicine. Dr. Anirudh Kulkarni, President of Society of Fetal Medicine, Marathwada Chapter. Dr. T.L.N. Praveen, Immediate Past President of Society of Fetal Medicine. Dr. Anjali Jamma, President of Solapur Obstetric and Gynecological Society. Dr. Jyoti Thapadia, President of MSBIRIA, Solapur Chapter. Let us now come to the most auspicious and symbolic part of the inaugural ceremony, that is lighting of the lamp. I request all the dignitaries to please come forward for lighting the lamp. The lamp here represents the light of knowledge, and lighting of the lamp signifies the acquisition and dissemination of knowledge and understanding. It reflects the universal human desire for achieving wisdom and enlightenment, and thus symbolizes the arrival of positive energy and happiness. The act of lighting a lamp by multiple individuals signify unity and solidarity, emphasizing the importance of coming together to achieve common goals. I thank all the dignitaries for doing such an important job of lighting this lamp of knowledge. Welcoming one and all is our pleasure, and here is our very own Dr. Vaibhav Meru sir, past Vice President and Joint Secretary of MSBIRIA and past President of MSBIRIA Solapur chapter, and the man instrumental in bringing SFM to our city of Solapur to give his welcome address.
Good morning, everyone. Respected dignitaries on the stage, seniors, friends and colleagues, on behalf of Solapur chapter of MSBRI and Solapur Obstetric and Gynecological Society, I take this opportunity to welcome you all. I extend a warm welcome to our chief guest, respected Mrs. Sheetal Teliugle ma'am, Municipal Commissioner of Solapur. I extend our sincere thanks to her for taking time from her busy schedule for this particular inauguration program. I also extend our warm welcome to Dr. Basuraj Lohare sir, MOH Solapur. We are extremely thankful to Lohare sir for guiding us through this CME. Friends, we are fortunate to have all the stalwarts in the field of Society of Fetal Medicine. We are pleased to welcome Dr. Vimal Sahani, National President, Society of Fetal Medicine, Dr. TLN Praveen Sir, immediate past President, Society of Fetal Medicine, Dr. Aniruddha Kulkarni, President of Society of Fetal Medicine, Marathwada Chapter, Dr. Sujit Konkar, Secretary, Dr. Shilpa Satarkar Ma'am, Vice President of Society of Fetal Medicine, Marathwada Chapter, and Dr. Veena Panath, Treasurer of SFM, Marathwada Chapter. It is a great opportunity for all of us to enrich ourselves in the field of fetal medicine. I'm sure it's going to make difference in our perspective towards fetal medicine in our duly routine schedules. The purpose of this meet is to undertake and learn practice of fetal medicine to grassroots level. We certainly hope that today's scientific deliberations will help them in routine practice. So let's try and make best of it. Now I request Anshu to carry forward the program. Thank you so much.
As you all know, today we have Amit Sah's distinguished personality, Mrs. Sheetal Teliugle, as our chief guest, an IAS officer of the 2009 batch. She has served as Assistant Collector at Nagpur and Chandrapur, as CEO of Zilla Parishad at Jalgaon, as District Magistrate and Collector at Raigad, Additional Commissioner and Police at Pune Municipal Corporation, as Metropolitan Commissioner at Nagpur, as Textiles Commissioner and Managing Director, Maharashtra State Handloom Development Corporation, Nagpur, before she came to Solapur as Commissioner of Solapur Municipal Corporation and became a CEO of Solapur City Development Corporation. She is also an ardent art lover with special interest in drawing and painting. We are fortunate, ma'am, to have you here with us. Thank you. I request Dr. TLN Praveen, former National Vice President IRIA and past President of IFUMB and immediate past President of SFM, to kindly felicitate Sheetal Teli ma'am. Here I would like to highlight that during her tenure as Commissioner of Textiles, she was instrumental in bringing 1,426 citizens from all walks of life together to weave a 98-feet-long fabric of unity on handloom. This attempt officially entered the Asia Book of Records and India Book of Records under the title of Maximum Length of Hand-Woven Cloth by Non-Weavers. Not only this, she has been felicitated by Honorable Chief Minister for search and rescue operations carried out during an unprecedented accident of collapse of bridge on Savitri River and Mahad in August 2016. During her tenure as Additional Commissioner at Pune Municipal Corporation, Pune emerged as the best city in terms of quality of urban governance with awards like Smart Infrastructure Innovation Award and the HUDCO Award for the best practices in improving the living environment. Ma'am, this token of our appreciation is offered to you with warmth, love and affection for having agreed to be our chief guest today. Thank you. Now I request Dr. Anirudh Kulkarni, President of SFM Marathwada chapter, to kindly felicitate our guest of honor today, Dr. Basavaraj Lohare. Passed out from Sion, Mumbai, Dr. Lohare has been working in Public Health Department on various clinical and administrative posts and is presently working in Solapur Municipal Corporation as Medical Officer of Health. Sir, our sincere wishes are presented to you here. We are also fortunate to have Amit Saz Dr. Bimal Sahani, National President of Society of Fetal Medicine, a student-friendly teacher, dynamic, vibrant and popular faculty. I request Dr. Anjali Jamma Ma'am, President of Solapur Obs and Gynae Society, and the person carefully executing every minute detail of this conference, to kindly felicitate Bimal Sahani sir. Sahani sir is Director of Sonu Scan Center of Aurangabad and is Academic Coordinator of Scholar MD Fetal Medicine Training Program. Now I request Dr. Anirudh Kulkarni, President of SFM Marathwada chapter, the one-man working army behind this conference, and academically known as for his innovative skill developing in ultrasound teaching, to kindly say a few words.
Good morning, warm welcome, and thank you for the kind words. I welcome Dr. Mrs. Sheetal Teli Ogile, IAS Municipal Corporation, Solapur Municipal Corporation. I also welcome Dr. Basavaraj Lohare. I think we shared dais last time for one of the nice events that Solapur conducted. And distinguished guests on the dais, Dr. TLN Praveen, the present dynamic president of SFM, Dr. Bimal Sahani, one of my close friends, and all the faculties who gathered here for bringing the updates as far as the fetal medicine is concerned. SFM chapter Marathwada encompasses most of the districts of Marathwada. But thank you Solapur city for opting us to join the SFM Marathwada rather than joining to the others parts, particularly Pune or others. So a big round of applause for all the enthusiastic crowd for allowing us to encompass with the SFM Marathwada. See, we started with first meeting in Aurangabad, which was in attendance where the 250 plus. We then decided to go to smaller tier 2, tier 3 cities, where there is a lot of eagerness as far as learning the new concept of Society of Fetal Medicine. Society of Fetal Medicine is meant for betterment of mother as well as the child. So eventual outcome of all these teaching courses that we conduct throughout the tier 2, tier 3 city is that the updated knowledge of ultrasound and fetal genetics and fetal medicine should reach to the grassroots population of rural part of Maharashtra and India, and under the able guidance and flagship of Dr. Bimal Sahani, who have been doing it very rigorously in entire Maharashtra as well as all over the India. So big round of applause for Dr. Bimal Sahani for taking it to rural part of India for that matter. So with those words, probably I welcome you all. Extended participation in terms of interactive workshop was very delightful discussions entirely throughout those workshops. So thank you very much for all the attended delegate yesterday for making it more fruitful. And once again, from Society of Fetal Medicine Marathwada, I welcome you all, and I really appreciate your presence in the hall during workshop and throughout this conference, throughout this Sunday. So highly appreciate. Thank you very much once again, and warm welcome to everybody on the dais and off the dais. Appreciate it. Thank you.
Thank you, sir. At the helm of affairs, Dr. Bimal Sahani, National President of SFM, coming all the way from Aurangabad, is now requested to give his presidential address.
A very good morning, and I think being the National President of SFM, I am the primary host of this program, so I welcome you all for this wonderful academic meeting which has been organized here. and respected chief guests and the guest of honor, Sheetal ma'am and Lohare sir, and the dignitaries on the dais, the person from whom I have taken over, Dr. Praveen sir, and dear all. There was a time 10, 12 years back where we had different societies. We had a society for gynec, OBGY society. We had a radiology society which was dealing with imaging. But suddenly our mentor emeritus, Dr. Ashok Khurana, he realized one day that things are not going right. In the sense, I read somewhere on a WhatsApp, it was a funny quote where a child says that my teacher asked me a question which I didn't understand. I gave her an answer which she didn't understand. So something like that. So there was no coordination, and we realized that if we want to give every fetus an optimal outcome, it was very, very essential that we bring people of different specialities together. Because everyone is involved in the process. You require the imaging people, you require the primary clinicians, you require fetal medicine specialists, you require geneticists. So we needed something of that kind where everybody could come together and we could learn from each other. Now, so Society of Fetal Medicine came up. Now we have the radiologists, the obstetricians, geneticists, we have pediatric cardiologists, the pediatric specialists, they are all members, and it's not multidisciplinary. Actually, we are all learning from each other. I think every event as an imaging person, if I give something and the primary treating clinician doesn't understand what I am talking about, the fetus is not going to gain, the mother is not going to gain. And that is why it was essential, and that is how this came up. And we always thought this is going to be a very, very niche society, maybe about 400, 500 members. But today we are reaching up to 5,000 members. We should be covering up very soon. Since the time, and the best part about Society of Fetal Medicine is it is not political. There is no, it's not a, you don't need to really, do a lot of campaigning or anything. Anybody, they say that I am the national president. Actually, every member is a president. If you, on that particular day, if you are doing something good for the fetus, you are the national president. So, and I think that is one reason why somebody like me from Aurangabad now, this is not something which I ever thought that I would be leading a society of this high magnitude in my life. But that I could do just because anyone who is ready to work, because the primary aim of Society of Fetal Medicine is to give every fetus an optimal outcome. That is the essence of that, and that comes through education. So SFM is all about education, education, and education. Since the time I took over, because I started my practice in Aurangabad. Aurangabad definitely was everybody thought good fetal medicine is a domain of the metro cities. Nobody thought that, in smaller towns we'll be able to practice. So when I started practice, I realized, because we didn't have specialists there, so we had to work not just as imaging people, we had to work also as geneticists, we also had to be the interventionists, we also had to be the counselors, because we can't send every patient to Mumbai to a particular specialist to explain or counsel the patient. So the buzzword which we started from the time that we've taken over was outreach. So it is not that a mother who's in a metro city only deserves the best. Every woman practicing even in the most remotest part of India deserves the best. Every fetus deserves the best, and the best way to do was to go and reach them, reach the people involved in that area. And that we said our buzzword is outreach. And that is the message we passed on to every chapter, and I'm really, really proud of the team of Marathwada chapter, not because I belong to that place, but they have used this, they have taken events in Ahmednagar, in Sholapur. Now, if this is the kind of crowd, I can't call this as an outreach program. An outreach program is supposed to be a small, short, about 20, 25 people. But that exactly is the need of the hour, and really appreciate everyone for this wonderful thing. And I promised you that we will keep doing more and more events. And I think that for Sholapur and its area, at the moment, I think it can progress much rapidly, because if your municipal commissioner has taken out time on a Sunday to come and spend some time for an event of this kind, so that means you'll definitely have people who, if you're going to keep doing good work, if you're going to keep doing good activities, you'll get a lot of support from everywhere. It just keeps coming. The support starts keep coming, the permissions start keep coming, because eventually everybody wants that, everybody wants to reduce the maternal morbidity, everybody wants that we have healthy babies. And so keeping that aim in mind, I thank everyone. I welcome our guests again, and we'll have a wonderful session. We have a good feast planned for you, and I look forward to coming again and again to Sholapur, not just for academics, but the lovely food that you get in Sholapur. It's been very, very tempting spending time since yesterday. The kind of warmth and the love and the affection of everyone here has really been mind-boggling. Thank you very much.
Thank you so much, sir. I take this opportunity to also thank our sponsors Mindray and LifeCell, and it's a pleasure to announce the launch of a new model of ultrasound machine by our co-sponsors Mindray. We shall be running the video launch during our lunch time. Mindray India at this conference at Sholapur announces the video launch of Consona series, enhancing precision imaging by the latest generation machine. So we shall be waiting for the video launch. A sincere compliment is one of the best ways to acknowledge one's efforts, especially when made in front of others, and that is exactly what we are going to do. I request Dr. Anirudh Kulkarni sir to formally announce the awards for poster competition, and I request Sheetal Teli ma'am to please give away the prizes to the deserving candidates. The posters were judged today morning and by Praveen sir, by Anirudh sir, and so please announce this. Okay. The first two posters that will be awarded today are by Kirti and Harshada. Both these are MD candidates from Solapur Rural Hospital and Research Center at Kumbhari. They are both second year students. Harshada Videkar and Kirti Vibhute, heartiest congratulations. And also take this opportunity to please to congratulate the other students who had given posters. Thank you.
You want me to announce
Yes.
the rest? You want me to announce nothing? Oh, thank you, I appreciate it.
I now request Chief Guest Ma'am to kindly say a few words.
आज येथे सोसायटी ऑफ फिटल मेडिसिनच्या माध्यमातून जे वर्कशॉप आयोजित केलेलं आहे त्याच्यासाठी उपस्थित आपण सर्व व्यासपीठावरचे सर्व मान्यवर, माझे सहकारी डॉक्टर लोहारे, आपले सर्व पदाधिकारी आणि आपण सर्व बंधू भगिनी, नमस्कार. खरं माझा पहिला प्रश्न होता की डॉक्टर्सच्या कॉन्फरन्समध्ये माझ्या नॉन मेडिकोचं काय काम आहे म्हणून, परंतु दे इन्सिस्टेड. आणि अपार्ट फ्रॉम बेईंग म्युनिसिपल कमिशनर ऑफ दिस सिटी आणि आम्ही आमच्या हेल्थ डिपार्टमेंटच्या माध्यमातून जे काही काम करतो, IMR कमी करणं असेल, MMR कमी करणं असेल, बाकीच्याही सगळ्या गोष्टी असतील त्या, आणि बाकी PCPNDTच्या माध्यमातून जे काही काम चालतं, तर या सगळ्यांचा संबंध तर म्युन्सिपल कमिशनर म्हणून या गोष्टींमध्ये येतो. परंतु अपार्ट फ्रॉम माय ऑफिशियल ड्युटी आय एम अ मदर ऑल्सो. आणि जे 9 वर्षांपूर्वी वेन आय वॉज प्रेग्नंट आणि या सगळ्या स्कॅन्ससाठी मी जेव्हा जायचे तेव्हा माझ्या डॉक्टरांना 3 प्रश्न होते. मला माहीत नाही त्याची उत्तरं तुम्हा लोकांना अजून सापडली आहेत का. मी विचारलं होतं की जे काही बाळ आहे, मुलगा मुलगी कोणी असेल, तर तुमच्याकडे अशी काही टेक्नॉलॉजी आहे का की तुम्ही मला सांगू शकता की त्याला दिसतं, तुम्ही मला हे सांगू शकता का की त्याला बोलता येईल, आणि हे सांगू शकता का की त्याला ऐकू येतं. आय डोंट नो त्याची उत्तरं आहेत का. ओके. तर मी तुम्हाला हे प्रातिनिधिक या स्वरूपासाठी सांगितलं, आपल्या सगळ्यांच्या दृष्टीनं सगळ्यात मोठी गोष्ट काय असेल, सगळ्यात म्हणजे काही वी कॅन कॉम्प्रोमाइज एनिथिंग, पण हे नाही कॉम्प्रोमाइज करू शकत. आपली पुढची पिढी, आपली संतती, मुलं मुली जे आहेत, दॅट इज आवर असेट. नाही म्हणता येणार, असेट्स आर लाईक मॉनिटाइज्ड आणि पैसे येतात जातात, परंतु आपली पुढची पिढी दॅट इज वन थिंग विच वी कांट कॉम्प्रोमाइज, दॅट इज नॉन निगोशिएबल. आणि कुठलीही आई, म्हणजे ती देशातल्या सर्वोच्च श्रीमंत उद्योगपतीची बायको असो किंवा कन्स्ट्रक्शन साईटवर काम करणारी किंवा ऊसतोड करणारी आई असो, तिला प्रत्येकीला वाटतं की माझं जे बालक आहे, बाळ जन्माला येणार आहे, तर ते हेल्दी पाहिजे आणि ते आरोग्यदायी पाहिजे, ते दीर्घायुषी असलं पाहिजे. या सगळ्या गोष्टींसाठी तुम्हा सगळ्यांचा रोल खूप महत्त्वाचा आहे. म्हणजे त्या बाळामध्ये काही प्रॉब्लेम्स आहेत का आणि आपण ते आधी काही ट्रीट करू शकतो का किंवा काही केअर घेऊ शकतो का, यासाठी तुम्ही लोक म्हणजे तुम्ही देवदूत आहात त्या प्रत्येक आईसाठी आणि पित्यासाठी पण. बट वॉट एव्हर आय एम सेईंग, लेडीज सिटिंग हिअर आर एबल टू कोरिलेट विथ इट मोर फ्लुएंटली रादर दॅन जेंट्स. त्यामुळे या सगळ्या भावना ह्या याच्यासाठी महत्त्वाच्या आहेत की आमच्या प्रत्येकीच्या मनामध्ये भीती असते कुठल्या प्रकारचं बाळ जन्माला येणार आहे आणि त्याला काही प्रॉब्लेम्स आहेत का. तर त्याच्यामध्ये तुम्ही सगळे लोक खूप पिवोटल रोल, जो सगळ्यात इम्पॉर्टंट रोल आहे तो तुम्ही बजावणार आहात. तुमचे रेडिओलॉजिस्ट आणि बाकी डॉक्टर्सपासून तर खाली तुमचे टेक्निशियन्स जर असतील, काही मशीन्स ऑपरेट करणारे तिथपर्यंत. आणि म्हणून मला ही कॉन्फरन्स खूप जास्त इम्पॉर्टंट वाटते. तुमची जी काही नवीन टेक्नॉलॉजी येते आहे, तर ती टेक्नॉलॉजी आमच्या समाजातल्या शेवटच्या बाळापर्यंत आणि ANC मदरपर्यंत जाणं आणि त्याचा फायदा त्यांना मिळणं हे खूप गरजेचं आहे. आपण सशक्त भारत, शक्तिमान भारत वगैरे जेव्हा बोलतो, तर तेव्हा तो भारत या सुदृढ बालकांशिवाय आणि सशक्त पुढच्या पिढीशिवाय जन्माला येणं शक्य नाही. आणि त्याच्यामध्ये तुमचा रोल हा खूप महत्त्वाचा आहे. त्यामुळे म्हणजे ह्या जबाबदारीची जाणीव तुम्हाला आहेच आहे, पण तुम्ही म्हणजे कुठल्याही एक्सपेक्टेड मदरसाठी किती इम्पॉर्टंट आहात हे मला जास्त आपल्याला सांगावंसं वाटलं, म्हणून मी काही बाबी आपल्याशी शेअर केल्या. तर आपल्या या आजच्या वर्कशॉपला आणि तुमचं जे काही इथे परिषद आहे त्याला मी खूप साऱ्या शुभेच्छा देते. आपल्या नवीन मशीन्स, ॲडव्हान्स मशीन्स, ॲडव्हान्स स्कॅन्स, ॲडव्हान्स ॲनमलीज स्कॅन जे काही करता येणं शक्य आहे तुम्हाला ते, आणि मशीन आणि डॉक्टर, म्हणजे मशीन तर देईल काहीतरी इमेजिंग, आणि पण त्याचा नीट अर्थ लावून ते तसं सांगणं हे पण तितकंच इम्पॉर्टंट आहे. तर असं जर आपण म्हणतो ना, म्हणजे डेटा तर येतो खूप, पण डेटाचं करायचं काय पुढे हे पण कळणारे सक्षम आणि तितकेच केपेबल डॉक्टर्स आपल्याकडे असणं गरजेचं आहे. तर या दोन्ही बाजूंनी आपल्याला खूप साऱ्या शुभेच्छा देते. आपण मला इथे बोलवलं त्याबद्दल आपले आभार व्यक्त करते. धन्यवाद.
Thank you, ma'am, for all your valuable words of wisdom and kindness. Let us all hope and pray that one day science will find answers to the questions like whether the child will see, speak, or hear. It's not easy to organize an event, and I'm sure there are many sources to recognize and thank for their direct and indirect contributions. Here's Dr. Sujit Konkar, Secretary of Society of Fetal Medicine, proposing the vote of thanks.
Good morning, my dear friends, colleagues, and seniors. I am very much delighted to propose vote of thanks on this occasion. First of all, I am very much thankful to Mrs. Sheetal Teli Ugle Ma'am, Commissioner, Municipal Corporation, for sparing her valuable time and to grace our fetal medicine conference. She asked one question, whether you can detect, baby can hear, baby can listen, baby can see. So, ma'am, fetal medicine is the first step towards it. What we are doing is the first step. So, we may go to that after a few years. So, I am equally thankful to Dr. Basavaraj Lohari sir, MOH Appropriate Authority for PCP and DT Solapur. Thank you, sir, for giving your precious time. This CME was impossible without the academic efforts of Dr. Bimal Sahani sir, Dr. TLN Praveen sir, Aniruddha Kulkarni sir, Dr. Shilpa Satarkar ma'am, and Veena Panat. They have enlightened us with their great knowledge. Thank you all office bearers and members of Solapur Society of OBGYN and Radiology for your efforts to make this event a huge success. My vote of thanks will be incomplete if I fail to appreciate the efforts of the delegates who have attended this in a huge number. Thank you, Mindray and Lifestyle Diagnostic, for your support to conduct this academic activity. Thank you, the staff of Balaji Sarovar, for helping us for this venue. Thank you, Lord.
I thank all the dignitaries. We now end the inauguration session, and we shall start purely with the academic section in a small time. Thank you so much. We shall begin with Sujit Konkar sir's lecture.
Dr. Sujit Konkar sir, welcome sir. Sir is one of the senior gynecologists in Aurangabad. He is Secretary of Society of Fetal Medicine, Marathwada chapter. He is Chairperson, Fetal Medicine Committee, AMOX. He is special interest in advanced fetal USG. Over to you sir. Thank you.
Hi. Easy, na? Good morning, dear friends, colleagues, and seniors. It is very difficult to bat and impress after a great partnership, opening partnership of Sehwag and Tendulkar. Still, I will try. At the outset, I would like to thank SFM, central body, for giving me this opportunity. My topic is dating in pregnancy, which is very important and basic talk, and somewhat neglected talk by all sonologists. Why dating and assignment of EDD is important? It is important for timing of appropriate obstetric care, for scheduling and interpretation of certain antepartum tests like dual marker and quadruple marker, which are done at specific points in gestational age, for determining appropriateness of fetal growth, and to diagnose various growth disorders like SGR babies, FGR babies, and macrosomia, designing interventions to prevent preterm births, postterm births, and related morbidities. With correct dating, you can avoid so many unnecessary inductions on falsely labeled postpartum pregnancies, which gives rise to high incidence of cesarean section rates. Here, some terms need to be understood. Gestational age is the length of pregnancy since last menstrual period. It is also called as menstrual age. But remember, in cases of irregular cycles, gestational age can be different. Two gestational age can be different than menstrual age. Embryonic age is the length of pregnancy after conception, that is post-conception age. This term is used by embryologists or dysmorphologists to describe the events in early pregnancy, but in clinical practice, we do not use this term, we use the term gestational age. Expected date of delivery is 280 days from onset of LMP or 260 days from the date of conception. And what is dating scan? Dating scan is an ultrasound scan done between 8 to 14 weeks of pregnancy to help estimate the due date. What tools do we have? We have menstrual history, clinical examination, and ultrasonography. Menstrual history is the indirect measure of conception, roughly 280 days. All of us follow Niggles rule in our clinical practice. Add 9 months and 7 days to EDD, it will give LMP and it will give the EDD. But it is not very sure. The reliability of Niggles rule or LMP menstrual history is very, very questionable, because many times the patient doesn't remember the LMP, there is history of irregular cycle, there is history of intermittent bleeding PV, history of taking OC pills and so on. So it can be accepted as a fruitful. There is old Prem's rule which used basal body temperature. Hiremat previously used lunar calendar to explain in terms of patient's language. But here, the pregnancies we are considered by ART. Dating done in these patients is very, very accurate, because the actual conception happens at a confirmed time outside body. So if fresh eggs are used, add 266 days. In 3-day-old frozen embryo, add 263 days. And in 5-day-old frozen embryo, add 261 days to embryo transfer date. Coming to clinical examination, it refers to symphysis of fundal height. By and large, symphysis of fundal height in centimeters corresponds to weeks of gestation, or clinically you can say uterus palpable, it is correspond to 12 weeks, between umbilicus and pubic symphysis 16 weeks, and at umbilicus 20 weeks, and so on. But this is highly subjective, and it is widely influenced by various factors like uterine anomalies, amount of flagor, or growth disorders. It is more useful in late gestation along with cervical findings to understand the initial, or to estimate the initiation of labor. The basic of dating is ultrasound. So in first trimester, use crown lump length, and in second trimester, use head circumference and or femur length. So early pregnancy scans, these are most accurate for dating, especially when the CRL is between 30 to 84 millimeter. And after 14 weeks, we go for head circumference and or femur length. So at the start, when patient comes to you, we take the history, all those things, and we enter the LMP in this machine, and it will give you information about the expected date of delivery and the gestational age at that point. You complete the examination, you take biometry, and at the end, the machine gives you average ultrasound age. On last page of report, you get something like this: GA by LMP, ED by LMP, GA by average ultrasound gestational age, and ED by average ultrasound age. So whenever gestational age matches ultrasound biometric age, we assign EDD as per LMP. And whenever gestational age mismatches ultrasound biometric age, then we assign EDD as per ultrasonography. So what is the criteria for this mismatch? And at what discrepancy we should reassign the due date? This is a very nice practice bulletin by American Institute of Ultrasound in Medicine, which gives us clear guidelines about dating in pregnancy. So this contains the gestational age range, method of measurement, and the discrepancy between ultrasound dating and LMP dating that supports redating. It is divided into two parts: pregnancy up to 13 weeks 6 days and pregnancy after 14 weeks. Obviously, depending on the method of measurements. Pregnancy up to 13 weeks 6 days again divided into pregnancy till 9 weeks and after 9 weeks. So up till 9 weeks, if the discrepancy is more than 5 days, you have to reassign the EDD according to the CRL. After 9 weeks to 13 weeks 6 days, if the discrepancy is more than 7 days, you have to correct the EDD by CRL. From 14 weeks to 16 weeks or 15 weeks 6 day, the discrepancy accepted is 7 days, and after 16 weeks to 22 weeks, it is 10 days. But remember, after 22 weeks, the dating is very, very inaccurate. You should not date the pregnancy very accurately after 22 weeks. Those pregnancies which cannot be labeled after 22 weeks, they are called as suboptimally dated pregnancies, and the management is totally different in these pregnancies. Again, here is rule of 8, which is an old rule, but it is still incorporated in various reporting softwares in even today. So it states that USG gestational age estimation is consistently accurate with 8% of margin of error, irrespective of gestational age. It is quoted by grades like Hadlock, Dowlett, and Type LA. Be any parameter like whether it is CRL or HCA or FL, the variability is plus to minus 8% of estimate. You have to convert weeks into days for calculation. Just have one example. If the pregnancy is 8 weeks, is equal to 56 days. 8% of 56 days is 5 days. So the discrepancy is 5 days. You have to correct the more than 5 days. You have to correct the ED by CRL. So this corresponds with the AIOM guidelines. But now there is again twist. Forget your LMP, forget your neglect rule, forget your clinical examination, forget PREMS rule, forget Hiramet, all those things. There are so many institutes, so many countries in the world, they follow only ultrasound. They follow only CRL. This is very nice guidelines, determination of gestational age by ultrasound by Journal of Obstetrics and Gynecology, Canada. It has clearly stated that ultrasound alone is made more accurate than a certain menstrual date for determination of gestational age in first and second trimester in spontaneous conception. And first trimester crown rump length is best parameter for determining gestational age. So you have assigned the delivery date, and if discrepancy less than variation expected, then you have to assign the EDD as per LMP. Remember this golden rule: once assigned, do not change EDD in subsequent reports. And if the variation is more than expected at the gestational age, then assign EDD as per USG. And once assigned, don't change the EDD in your subsequent scan. This is very, very important because we come across various reports in early pregnancy scan, the EDD given is different, at NT scan it is different, at 20 week scan is again different, and at 30 to 36 weeks again it is different in those scans. This should be avoided. You should stick to only one EDD which has been corrected. And what about mean sac diameter? Mean sac diameter should never be used for dating of pregnancy. Just have an example. Here, gestational age by LMP is 8 weeks, 3 days. And see, these machines they don't have brains. They work on artificial intelligence. Whatever you put into it, they will reflect by giving some result. So if you put mean sac diameter 2.9 centimeter, it corresponds to 8 weeks, 2 days. CRL is correspond to 7 weeks, 4 days. So the machine gives the average ultrasound age by mean sac diameter and CRL 8 weeks. So the GA by LMP 8 weeks, 3 days, average USG is 8 weeks, the discrepancy is just 3 days, which is not within the range of 5 days. So by our rule, you should stick to the EDD by LMP. But remember this golden rule, do not use mean sac diameter for dating, always go for CRL. So here CRL corresponds to 7 weeks, 4 days, and GA by LMP is 8 weeks, 3 days. So here discrepancy is more than 5 days. So in such cases, you have to stick to the EDD from CRL. So CRL is the crux when it comes to dating. So you must know the exact perfect criteria to measure CRL. These are the SOC guidelines. The fetus should be midline sagittal. The orientation should be horizontal. It should not be oblique or vertical. The ultrasound beam should be 90 degrees to the fetus. The magnification should be such that the whole screen is occupied, the baby. The position should be neutral. It should not be hyperflexed or hyperextended. There should be some fluid between chin and chest. And the end point should be clearly defined. That means your calculation is correct. This is the correct image. This is very small image, not magnified. This is not mid-sagittal, it is coronal. And here the baby is hyperflexed. So all these 3 images, these are incorrect images. So you should be very perfect in measuring the CRL. So what are the implications of incorrect caliper placement? See, as all of us know, NT is function of CRL. So if your CRL is wrong, your risk assessment of aneuploidy is wrong as shown in this example. See, there is difference between the adjusted risk in these 2 images. One is correct and another is incorrect. So after 14 weeks, what to do? Previously, we have been using this composite biometry, including biparietal diameter, head circumference, abdominal circumference, and femur length. But recent guidelines tells that use only head circumference and or femur length. The basis of this is, these are ISWAC practice guidelines, ultrasound assessment of fetal biometry and growth, which clearly states, once the CRL exceeds 84 millimeter, HC should be used for pregnancy dating. HC with or without FL can be used for estimation of gestational age. There is another article which tells head circumference being significantly better than BPD when it comes to dating. So, for dating this BPD, HC and BPD, they are important. BPD is important again for fetal size and fetal weight. So, you must be familiar, you must be perfect for taking correct anatomical plane. So, it is the cross section at the level of thalami or ventricles. Remember, you can use transthalamic plane or you can use transventricular plane. Any plane is accepted. The midline falx should be horizontal. The midline should be equidistant from upper and lower parietal bones. Cavum septum pellucidum bisects the midline falx in anterior 2/3 and posterior, anterior 1/3 and posterior 2/3. The shape of head should be rugby football shaped, which should be rounded at back and more pointed in front, and skull counter should be regular, like this. And there are various schools of thought, BPD, how to take BPD, outer to outer, outer to inner, and so many. But see the recent guidelines published in May 2020. Outer to outer placement of calipers is preferable when measuring BPD, but practically you should measure BPD as per your charts, which charts you are using. Now again, when you are dating by HC, the plane, anatomical plane is same, that is axial cross section of the head at level of thalami or ventricles. It can be measured by two ways. You can use ellipse around outer skull border or two diameters, biparietal diameter and occipitofrontal diameter. And this formula gives you the value of head circumference. Every machine is equipped with the software which gives you the value of head circumference and the related gestational age, and this table shows the percentile of gestational age according to head circumference. What about femur length? Correct anatomical of femur. Why femur is chosen? Because it is the largest bone, it is easily accessible, and it is least movable. So both ends of ossified metaphysis should be clearly visible. The longest axis should be measured. You should avoid distal femoral epiphysis or spur artifacts. For that, always measure the shaft in the middle as shown in this red line. And angle should be 0 to 15 degrees to horizontal. If the angle is more, there will be false low values of femur length. When you are dating by HC and FL, remember that both should agree. That means both should be close to 50th centile. That means if head circumference is 18 weeks 6 day and FL is 19 weeks 3 day, it is one and same. That means up to 10% it is accepted. But if it's going to more than 45% or even larger, then there are three possibilities. First is your sections are wrong. Second is your sections are correct but your caliper placement is wrong. Third possibility is your sections are right, caliper points are right, but there is some problem with this pregnancy. So what it could be? So when FL is small, below 5th centile, and head circumference is at 50th centile, think of skeletal dysplasia, Down syndrome, or you are catching early FGR. And when head circumference at 5th centile and FL is at 50th centile, it is microcephaly, or even you are looking at a spina bifida, because in more than 30% of cases of spina bifida, the head is small. About abdominal circumference, what is the correct anatomical plane? AC is not used for dating a pregnancy. AC is used to estimate the fetal size or estimated fetal weight. So it is the transverse axial section of the fetal abdomen. It should be as circular as possible. Short length of umbilical vein should be seen. Remember, your correct image is based on the length of umbilical. If it is short, it is correct. If the long length is not correct. Stomach should be visualized and kidney should not be there in your image. So measurement, again there are two ways to measure abdominal circumference. Use of ellipse, calipers are put at outer surface of skin, and two transverse diameters, anterior-posterior diameter and transverse abdominal diameter. which are 90 degrees to each other, and this formula gives the value of abdominal circumference. So these images show the correct and incorrect sections of abdomen. So this small length, short length is the correct image, and this long length is not correct. So you have corrected the EDD, but you have to tell the patient and explain all the things. Make the mother aware about difference and stress the importance of carrying previous reports for subsequent scans. Here are some examples of dating. So LMP is 22nd March, so gestational age by LMP is 7 weeks 5 days, and CRL corresponds to 7 weeks 2 days. So discrepancy is just 3 days. So what does our table tells us? Below 9 weeks, if the discrepancy is more than 5 days, you have to correct the EDD by CRL, but if this is less than 5 days, so we will have to go by LMP. EDD is assigned as per LMP. In next example, the gestational age by LMP is 7 weeks 5 days, and CRL corresponds to 6 weeks 6 days. Here discrepancy is 6 days. So if you go by our table, the discrepancy is more than 5 days, so we have to correct the EDD by CRL in these cases. What about twins? Fetus A, CRL corresponds with 7 weeks 5 days, EDD is 22nd March. Fetus B, CRL corresponds to 19 millimeter with EDD 29th March. Do you think that fetus A is going to deliver on 22nd March and fetus B is going to deliver on 29th March? It is obviously no. So in twins, always go for larger CRL when you are dating the pregnancy in twins. Now here is interesting example. Here gestational age by LMP is 11 weeks 6 days and CRL is 11 weeks. So discrepancy is just 6 days. So if you go by the table of AIUM, if discrepancy is more than 7 days, you have to correct the EDD. Here it is less than 6 days, less than 7 days. So by this table, you should stick to EDD as per LMP. But remember, recent guidelines tells, especially when the CRL is between 30 to 84, and provided you are perfect in taking CRL. If CRL is like this, fulfilling all ISO criteria, always stick to the CRL and the EDD derived from the CRL. So you have to go by CRL in these cases. So if the pregnancy is between 10 weeks to 13 weeks 6 days, or CRL is 30 weeks to 30 to 84 millimeter, always date the pregnancy at this stage. It is the correct way. What about follow-up scans? Look at the previous reports or first report when the patient comes in follow-up scans. And if discrepancy is there, look at the EDD given, see if it has been diagnosed or not. And enter the EDD in your machine and not LMP. Let's see this example. So here, LMP is 9th May with corresponding gestation age 11 weeks 1 day, and ED is 13 February. But when we are examining the baby, many parameters are low, baby chota vatta. Then again patient shows आधी केलेला आहे report आधी केलेला आहे. Patient never shows the report in the initial period. We have to ask the patient for report. नंतर ते हळूच काढून दाखवतात आपल्याला. So in previous report, see the EDD is 20th February, not 13th February. The discrepancy is 15 days. So in such cases, when you are examining for second time, do not enter LMP in your software. You enter direct EDD, and it will give the corresponding gestational age at that point. So this is just 9 weeks, and by EDD it should have been, it was 21 weeks 1 day. So you are comfortable while doing scan now. The impression should be, it is single live intrauterine gestation corresponding to gestational age of so many weeks and days. Gestational age assigned as per biometry, CRL dated on this and that, that is, it was done in first trimester. Your menstrual age is so and so, and your corrected ED is so and so. So what about dating in third trimester? It is useless. Don't assign EDD in third trimester. There are few indirect indicators like distal femoral epiphysis and proximal tibial epiphysis, which gives approximate gestational age. This is a very nice article about that. So distal femoral epiphysis are seen in 94% of feti at 34 weeks, and proximal tibial epiphysis are seen in 80% of feti at 37 weeks. That means if you are able to see DFE, the gestational age is certainly about 34 weeks, and if you are seeing proximal tibial epiphysis, it has crossed 36, 37 weeks. Next one is transcerebral diameter. It is somewhat neglected thing in dating pregnancy or estimation of gestation age. It corresponds to weeks of gestation. There are two important things about TCD. One, it is not changed even the baby is in FGR, because in FGR other parameters are changed but TCD never changes. And another thing, in third trimester, when there is excessive molding, there is abnormal shape of head like dolichocephaly or brachycephaly, you cannot measure head circumference or BPD in these cases. So in these cases, this TCD may be helpful. More research is required in this area. Follow-up scans in third trimester. Once the EDD has been assigned, fetal biometry is used to assess fetal growth velocity, fetal size and fetal weight. Measurements should never be used to reassign EDD. And time interval between scans should be at least 3 weeks. Always use growth charts. Now, components of estimated fetal weights. Campbell initially used abdominal circumference, but here are various formula: Hadlock 1, Hadlock 2, Hadlock 3, Campbell, Shepard, Merz, Intergrowth, which use variety of combinations of BPD, HC, SC and FL. But Hadlock 2 and Hadlock 3 are most reliable. You use any formula when the estimated fetal weight is more than 3 kg, the percent of error increases. This shows the result of incorrect caliper placement in estimation of expected fetal weight. See, the difference is more than 400 to 500. So proper caliper placement is very, very important. Coming to last slide, when you are dating the pregnancy, CRL is the crux. Only go for CRL in first trimester. Never use mean sac diameter for dating in pregnancy. After 14 weeks, use head circumference and or FL, which both should agree for that. Once assigned, do not change EDD. This is very, very important. Don't put various numerical values of EDD in your 3, 4, 5 scans. Don't give two different EDDs in report. EDD by LMP is this, EDD by USG is this. Fantastic report. This is wrong report. This is not good thing. Before starting follow-up scans, always ask for dating scans so you are comfortable in doing next scan. And biometry in third trimester is not used for dating. It is used to estimate the size of baby, expected fetal weight, and growth velocity. Thank you.
Next, I invite Dr. Bimal Sahani on stage for his lecture on basics of genetics. Bimal Sahani, sir, is National President of Society of Fetal Medicine and Director of Sonoscan Center, Aurangabad. He is also Academic Coordinator of the Scholar MD Fetal Medicine Training Program. Specially interested in fetal growth, echo, and Doppler, he is the co-author of second trimester guidelines of SFM, the principal author of the first trimester guidelines, and of SFM India oriented guidance statement for ultrasound establishments during COVID-19 pandemic. So thanks for all the guidelines in SFM.
Yeah.
Welcome, sir.
Thank you for those kind words of introduction, and so actually I'm not going to talk about basics of genetics. I'm going to talk about practical genetics in daily practice. How many of you love genetics? So whenever it comes to genetics, we want to circumvent it, right? Always that question mark comes. How many places in India have a geneticist? Very few. So now are you going to send all your patients, suppose you don't have a geneticist in Sholapur, are you going to send all your patients to a metro city for evaluation? You can't do that. So we always thought that, and we always had this, that we used to always call a geneticist to speak on genetics. But last time, the Marathwada chapter body people, they said, Sir, why don't you speak on what genetics you use in your daily practice? See, the field of genetics is increasing so much that there were so many things which we thought we never had a genetic association, but now we are realizing for practically every anomaly, every structural defect, there is a genetic mutation or something involved. Every few days you have some new mutation which is coming up, which is related to a particular thing. I foresee that maybe 10 years down the line, we may land up into a situation where a lady becomes pregnant, she'll first go to a geneticist, they will do some tests, and then they will come up with the mutation, they will call us and say that we have got the genotype, now you gave us the phenotype. So, it's essential that we need to have a working knowledge of genetics. We need to have, you can't practice fetal medicine without genetics. I say you can't even practice fetal imaging without genetics, because as a fetal imaging person also, once you have picked up something, if you've done a NT scan, you are actually then supposed to interpret and tell the patient what next. And for that, you need to have some clear concepts, basic stuff. So like Einstein said, if you can't explain it simply, you don't understand it well enough. So I'm going to try. At the end of that, you can say whether I've really understood it or not, only if I can simplify it. Okay? Now in daily practice, when it comes to genetics, what are the two things that come into our mind? One is screening and the second is diagnostic testing. The problem is, the word screening is misunderstood. What does screening means? Screening test identifies people at risk for a disorder in an unselected population. There was a time when only those mothers who were more than 35 years were sent for an NT scan. I think a lot of obstetricians here will agree. But then that is not screening, because she is already screen positive by maternal age. So a screening test is something which we use for an unselected population. So let us consider this is a population and the red ones are the ones with Down syndrome. I am taking the example of Down syndrome. So if I am going to use a screening test, what I am trying to do is, I am trying to use a screening test and find out the ones which are screen positive. So I get a subset. Because if I have to use a definitive test, can you do an amnio for all the pregnant mothers in Sholapur? You cannot do that. So you have to find a subset of fetuses who are at a higher risk, and for that we use a screening test. And so what we have done by using a screening test, we have found a subset of the ones which have come as screen positive. Now when I say screen positive, does not mean it is Down syndrome. So again, that is one misconception which you have to remove. त्याचा NT खूप हाय आला होता म्हणून आम्ही टर्मिनेट केलंय. One gynecologist came and said, "Kare, you had diagnosed one Down syndrome, but we sent the products of conception for karyotype and it turned out to be normal." I said, "Madam, in my whole life I have never diagnosed Down syndrome." No, you said that the NT was high. I said the NT was high. I said the risk was high. I never said that the baby has Down syndrome. So that basic concept goes wrong. Now if you see this example here, see in this population there were 7 fetuses with Downs. So we got one subset where we've got 10 of them, out of which we picked up 5, but at the same time we had 5 normal also which came as screen positive. And at the same time we had 2 which came as screen negative. So they were the ones which were not detected from that screening test. So what a good screening test would be, where you pick up the maximum number with very minimal false positive rate, in the sense that the number of amnios to pick up a large subset should be less. So if I would have used a screening test where I would have wanted one more of this also to be picked up, but then that one would have come here, but at the same time I would have had 4 or 5 more normal ones which would have come up. So the number of amnios would have gone to 15. So a good screening test is the one which has a high detection rate, but at the same time the false positive rate should be low. Now what do I do with this screen positive? Fetus is screen positive, so now what do I do? I need to speak to the patient and tell them, okay, you are screen positive. So now this subset that we have picked up, this is the subset which we are going to put them through a definitive testing and identify these 5 ones. Clear? Any questions so far? Okay. So the aim is to identify maximum number with minimum intervention and minimum false positive rate. Now, when we talk about screening, we always talk about Down syndrome only. Why? First of all, it is the commonest aneuploidy. There are quality of life issues. They have a long lifespan. 33% of Down syndrome would show you major abnormalities. The remaining don't show you any major abnormalities. Whereas trisomy 18, trisomy 13, triploidy, in 95 to 98% of those cases, you are going to find major structural abnormalities. Hence, when we talk about screening, generally we are always talking about Down syndrome. So what are the screening options that we have? We have first trimester. In the first trimester, we have the NT-NB-TR-DV, we have biochemical markers, the double marker, and then we add these two and do the combined screening. In the second trimester, we have soft markers on ultrasound, and then we have biochemical markers, the triple marker and the quadruple marker. Now, triple marker is historical. If you still have triple marker in your mind, please remove it. There is hardly any cost difference between a triple marker and a quadruple marker. The detection rate of quadruple marker is far higher than triple marker. I don't know why the labs still do a triple marker. They should remove it from their menu card altogether. They should not have triple marker at all. So, second message here is, second trimester, quadruple markers, not triple marker. And then we have the NIPS, the non-invasive prenatal test or the non-invasive prenatal screening. So these are the things that we have for screening. First trimester markers to be done between 11 to 13 weeks, 6 days, CRL 45 to 84. So there, more than the gestational age 11 weeks to 13 weeks, 6 days, what is more important is that it has to be done with a CRL from 45 to 84 millimeter. And 13 weeks, 6 days, it should not be that 13 weeks, 6 days and 12 hours, ratri 8 vasta, sir, ती उद्या 14 weeks होणार आहे, आज काही करून NT करून द्या. That is not the way that we need to do that. Very common scenario. It's not uncommon in practice. And I'll tell you, the NT scan takes more time than an anomaly scan. We don't give appointments for NT after 12 because NT can take the whole day. Because if you do it well. Suppose in Sholapur, if you don't do screening at all, there is no problem. But if you do screening, if you don't do it well, you will unnecessarily put so many people through unnecessarily invasive procedure. And then, right in the beginning, I said that it should be used for an unselected population. When I am talking about unselected population, everybody has to do it well. Suppose you have only one person here who is doing good NT, and all others don't do a good NT, then that screening process, the whole process of screening has gone for a toss. Because that person may do 5, 6, 7 a day, only 7 of them are actually getting a true NT and all others are getting. And amongst all these, NT is the most sensitive. NT is the most important of that all. You do good ductus venosus and good TR, and if you don't do your NT well, that whole thing has, it's a stronger marker. So you always have to do the stronger marker better. It's painful because the criteria is rigid. You need to get that kind of an image. You need to magnify. At the same time, what Sujit talked about CRL, if you do good NT and if you don't take a good CRL, even that goes for a toss. NT is a function of the CRL. And if you give a report, you give the NT and you don't give the CRL, and I see some reports, BPD, HC, FL, AC at 12 weeks, even sometimes humerus also, but no CRL. Again, that report has to be thrown away. And with the way the labs are coming up, I don't know how they can incorporate that NT if that person has not given the CRL. So what is the efficacy of the first trimester? If you use only maternal age, the sensitivity is only 30 to 50%. If you use maternal age plus biochemistry, 60 to 63%. Maternal age plus NT, yes, 70-74%. But if you do a combined test, NT plus PAPA plus free beta HCG, it will go to 86 to 90%. And if you add the NB DVTR, 93 to 95 they claim, but definitely more than 90%. That would be this. And the cell-free DNA, that is the NIPS, goes to 99%. So combined screening, we use age, the NT, and the double marker. How many? What's the trend here? You do combine for all, or maybe restrict the biochemistry wherever you feel that the NT is coming borderline, or is it combined for all? It should be. See, or if you're doing only NT, there's no problem. Whatever screening method you want to use, you use. But you need to inform that patient that the detection rate with this particular, there are institutional models. In some institution, they say, okay, yes, our screening is, we do NT for all. There's nothing wrong in it. But they have accepted that, yes, we are happy with the detection rate of 74 to 75. We have limited resources. We cannot do biochemistry for all. But that should be an accepted norm. And definitely when the detection rate for any test is low, then you're going to miss some. Now, you all do screening. You all send patients for an NT scan. But there is some very mandatory information that is required. Obstetric history. Now, method of conception is very important. ART pregnancies have a different algorithm. Now, my biggest problem with screening these days is that if patients coming from clinics, IVF clinics and all, quite a few of them have a donor oocyte. Nobody provides you with the age of the donor. What am I doing by screening? Whatever I am doing, I am saying this NT is so and so. How am I calculating the risk? I am actually modifying the age-related risk by adding one marker. The mother is 40 years of age. If I use her age, then however normal my NT is, that it is going to come screen positive. But the donor is maybe 20, 21. Nobody provides you with that information. Patient also doesn't tell. People feel stigma about call. But we understand immediately. We ask them, donor, some mothers will say yes, but most of them will look at their husband, then we know. She's looking at her husband means she's actually looking at him and asking whether should we tell or not. You call the clinician, they'll say, hey, donor was young. But what is young? I'm 58, I call myself young. That's a very relative word. So it's important that we need to provide the donor's age. Then, is there a history of Down syndrome in the siblings? History of neural tube defects, you need to ask. The maternal weight is important. All these information that you need to provide. Now, what is the suggested protocol in the... I'm not getting into the depth of all these methods because I have to speak in general. The current suggested protocol is, like you do a combined screening for all, and if you find that the risk is greater than 1 in 100, you go for an invasive testing. 1 in 100 to 1 in 1000 is intermediate risk, do NIPT, and low risk is less than 1 in 1000, no further action needs to be done. But this 1 in 100 is a word, this keeps changing. And this starts from FMF. Today Nicolaides feels, no, it should be 1 in 50, we have to start following 1 in 50. Now they have actually come to 1 in 10. They say now 1 in 10 is high risk and more than, less than 1 in 10 is you do NIPT rather than going for an invasive testing. But I think because for that everything needs to be very, very standardized. The NT needs to be very, very standardized. The biochemistry needs to be very, very standardized. So for all practical purposes, let us use 1 in 100 as the cutoff. 1 in 100 to 1 in 1000 is intermediate risk. Because previously we used to say 1 in 250 is the cutoff, anything less than 1 in 250 is low risk. But we've realized that this segment is intermediate risk and we need to put them through an NIPT. Low risk is less than 1000, no further action is to be taken. How many patients who come to you for a screening test or an NT actually know why they have come for? At least in my center, 99% do not know what they have come for. Some of them will say ki baal matimand aahe ki nahi te bagayaसाठी आलो. तसं नाही आहे तो. I think that pre-test counseling is a very important thing. And that has to be done at the level of the primary obstetrician. If they have not done it, then you do it. As a fetal medicine person or as an imaging person, you inform the patient beforehand, ki yes, we are doing this test. Patient awareness is important. Pre-test counseling you need to do. Tell them that this test is being done to see the risk of Down syndrome. Second trimester markers, we have established likelihood ratios for all these markers. And just I will say what you do, you take the a priori risk. A priori risk is the baseline risk. So that could be the maternal age risk. But if you have done a first trimester screening, that risk which has come in the first trimester will become the a priori risk in the second trimester. So when you are using multiple screening methods, you can't have individual risks. Double marker risk this much, quadruple marker risk this much. And that is what we are doing. Once a screening has been done, you got a risk. After that, any screening method that you are going to use the previously calculated risk as the baseline risk and modify that. So if you have done first trimester screening and you are doing quadruple marker, then you need to integrate it. You need to integrate that, and integration in the sense they are going to use the first trimester calculated risk as the baseline risk and then modify it. So then we will calculate the LR for these markers and then we will apply the LR, modify the risk, and LR is likelihood ratio, and then identify patients for an invasive testing. In India, in the second trimester, we generally use the cutoff 1 in 250 to call it as high risk. Now this statement which came in 2021 from the Society of Maternal Fetal Medicine, they have said that if an NIPS has been done, then for these markers like EICF, echogenic bowel, pelviactasis, you don't need to modify the risk with the second trimester markers. If an NIPS is screen negative, don't modify it with the second trimester markers. If previous first trimester screening has also been done and that is low risk, Then, at least for EICF and echogenic bowel and pelviectasis and short femur, short humerus, you don't do nothing, but for thickened nuchal fold and hyperplastic nasal bone, you counsel them as regards testing, no testing, invasive, give them all the information and let the patient decide what they want to do. Anossified nasal bone, yes, I would still say that yes, that is one thing where, because recent evidence has said it is not just about trisomy 21. If you do a chromosomal microarray, 6% of them have copy number variants. Some of them are of known significance, some of them are of unknown significance, and hence we need to, you may offer an invasive testing there. Now, if FTS has not been done, so if there is no first trimester screening that has been done, then you do a risk assessment by a combination of quadruple marker and ultrasound markers. That is something that you need to offer to the patient, because there are quite a few times patients have come directly in the 4th month. They have not undergone an NT or anything. That is the time you use a combination of quadruple marker plus ultrasound. So when do we advise quadruple marker? 16 to 21 weeks, that is the time, 21 weeks, 6 days. Don't do a quadruple marker at 23 weeks. FTS is missed or not done, yes, I spoke about it. In combination with second trimester genetic sonogram, you can use it and use it for integrated screening. Triple marker, a big no. NIPS, cell-free DNA. Now this can be done anytime after 10 weeks. Now what I have put it in red is that NIPT or NIPS is a screening test. Do not use it as a surrogate for invasive testing. If you see NIPT report, it doesn't tell you Down syndrome. It will tell you screen positive or screen negative. It is not a definitive test. That is something which, yes, it is a test with a very, very high sensitivity, very high detection rate, but it is not a diagnostic test. If a fetus turns out to be, if the NIPT comes screen positive, you have to do an amnio and do a definitive test to confirm that. Fetal fraction, there is something called fetal fraction, where you need a fetal fraction of greater than 4%. If the fetal fraction is less, it is called as no call. And when you get a no call, either sometimes you repeat an NIPT or then you may have to go for, because this no call is also a very important. In fact, they found that there are a lot of trisomy 18 and 13 which fall into this no call category. So, but NIPS will pick up the common aneuploidies, trisomy 21, 18, 13, and for sex chromosomal abnormalities. Now they have come up with that extended NIPS where you can look for certain micro deletions of, for this thing. But what we talk about, NIPT has a sensitivity of 99.5% or 99.9% is only for trisomy 21. It is for trisomy 18 and 13, the sensitivity is less. But good thing about NIPT is that its false positive rate is very low. But it is expensive. It's an expensive test, but the cost of NIPT is coming down. We get now NIPT, I think in some time you will start getting NIPT done at about 7,000 to 8,000 rupees, and that would be wonderful. We will be offering a better screening test to our patients. So when do we advise NIPS? Either you can use it as a primary screening tool. In the US, in Australia, every patient goes through an NIPS at 10 weeks. They still do the 11 to 14 week scan, but that is done to rule out structural anomalies, what Shilpa spoke about today morning, that the pyramid has shifted, we start looking, but they use NIPS as the primary screening, but there the state pays for it, here the patient has to pay for it, and that is the reason we don't use it as a primary. But you can use it for elderly, like somebody is 38, 39, you can always suggest NIPS as a primary screening tool, or for affording patients. I tell all my relatives who are pregnant and they call me up and say that, I am pregnant, I am 9 weeks, I say, okay, 10 weeks, get an NIPS done. I know they can pay for it, they should get the best that is available, and that is why, that is all pre-test counseling is all about. We need to use a cafeteria approach. Dr. Khurana always says use a cafeteria approach. Give the option to the patient, tell them these are all the things which are available, let them choose. Who are we to dictate that you do a test of 70% sensitivity and not a test of 99% sensitivity? Tomorrow patient will say, you should have told me, I would have got it done. And today you can't rely that you just speak something, by the time the patient comes back to talk to you, they have already done a Google search. Initially there used to be one Google patient in a day. Now the patient doesn't even know her age properly, but she's got a smartphone and they also Google search. Then if there is an intermediate risk in FTS, isolated markers in second trimester with low likelihood ratio, you can offer an NIPS, or at times if you find that it is coming as screen positive, patient is not willing for an invasive procedure, then the second option can be an NIPS. Screening result, normal, abnormal. Is this the right way of calling a screening test? No. It should be either screen negative and screen positive, or low risk and high risk. So never call it as norm. And start using these words when you are counseling. Don't, after you have done a scan, don't say this has come normal. Always use the word this has come low risk. Because if you say normal, there are a lot of patients, they say in the second trimester, oh, ते Down syndrome साठी ते झालं आहे, डाऊन सिंड्रोम नाही आहे. म्हटलं काय ॲम्निओसेंटेसिस केलं का? नाही सर, ते आपलं एनटी स्कॅन केलं होतं ना, तो नॉर्मल आला आहे. एनटी स्कॅन नॉर्मल मीन्स लो रिस्क. इट डझंट से दॅट इट इज नॉट डाऊन सिंड्रोम. स्क्रीन पॉझिटिव्ह आलाय पेशंट तुमच्याकडे, what are you going to counsel them? You tell them that this test has come screen positive. That means that there is an increased risk for certain aneuploidy. Screen positive does not mean say downs आहे. फक्त तुमचा फिटसचा रिस्क जे आहे तो हाय आहे, आणि वी आर प्लेइंग विथ फिगर्स. 1 in 49 is high risk, but yet 48 of them are going to be normal. There is a 1 chance of an aneuploid fetus. I cannot pinpoint that which one is that, and for that I need to do a definitive testing which will tell me, and that I need to do it as soon as possible. That is how you are going to explain in a post-screening counseling. Informed choice and perception of risk. Very important thing. Counseling means you have to, give the choice to the patient. You are giving them information, they will choose. 1 in 400 may be intermediate risk, and somebody may say, okay, 1 in 400, 399 will be normal, this is low risk for me. But 1 in 800, I may see, okay, there is still 1 in 800 is high risk. So perception of risk, what is your perception risk and what is my perception of risk is going to be different. And hence, we need to give this autonomy to the patient to take a call. And for that, we need to really, really nicely talk to them. आणि ते आमच्याकडे पेशंटला काय कळतच नाही, ते पेशंट असं म्हणजे आम्हालाच सांगावं लागतं, असं नाही आहे ते. दोज डेज आर गॉन. यू स्पीक टू देम. आता कळत नाही, पण टुमॉरो इफ द बेबी इज बॉर्न विथ डाऊन्स, त्यांना सगळं कळतं मग नंतर. तुम्ही का बोलले नाही, आम्ही केलं असतं. हु आर वी टू डिसाइड वेदर दिस पेशंट कॅनॉट अफोर्ड 20,000 रुपीज फॉर एन ॲम्निओसेंटेसिस? आपणच आपल्या मनात घेतो की हे काय करणार, हे करू शकणार नाही. करतात. Now you have something, then you go into definite testing. So what are the tests that are available? We have a lot of tests: FISH, QFPCR, conventional karyotype, chromosomal microarray, Sanger sequencing, clinical exome, whole exome. Are they all giving the same information? Do they give the same information? Arey, somebody tell me. तो जेनेटिक्स के टॉक में ना, यू हैव टू बी इंटरेक्टिव सो दैट एटलीस्ट आई नो वेदर यू आर अंडरस्टैंडिंग इट और नॉट. Because every time in a conference a few years back, there used to be a talk on genetics. Everybody used to go out for a cup of tea. इतने आज बैठे हैं, that is a big thing. That means we have moved on. We have moved on to something good. So these are all the tests which are available. But then every test has its own, there are indications for every test. Every test will provide you some information. Every test has its advantages, it has got their disadvantages, and that is what we need to decide on. Now, who is going to decide that? Every patient who comes screen positive, are you going to send them to Bombay and say, go and meet a geneticist and let her decide that? How many of you do procedures here, amniocentesis? 1, 2, 3, 4, 5. There's so many of them. So what test to order depends upon the indication for that test. Now this is a complete, I put everything on one slide where, so what are the important things that you need to know for the test is, first of all, what is the turnaround time of each test? What is the nature of the test? Whether it's a targeted test, what is it talking about? And what are the conditions that need to be identified? I'll quickly take you through some of the advantages and disadvantages of all those things. Well, you know, there used to be only talk about karyotype. Karyotype came normal. Karyotype came normal. Does normal karyotype rule out all genetic associations? No. So let's take, you know, we will see all this. You keep in your mind that there is a library with 23 pairs of books. And we will see how these things change again and again. Now this FISH and QFPCR, you know, they give information of only 5 chromosomes. Typically this is inadequate for any malformation that is identified, but what is the advantage is, it gives you quick fire results. Now, its value has come down a bit, but till the time this 24 weeks termination was not allowed, we had a lot of significance for that. Because 19 weeks, 3 days I have picked up something, and then we need to know at least grossly the answer before 20 weeks, because after 20 weeks, whether Down's positive or not, the termination was not allowed. So, quick fire results, we have FISH and QFPCR. Karyotype, conventional karyotype talks about abnormalities of number and structure which are greater than 20 MB. So what, in that library, what is the karyotype telling me? I said there are 23 pairs of books. It is telling me whether in one segment there is 3 pairs, you know, there are 3 books of the same kind. So whether the number of books have got altered here and there, that is what the karyotype is telling you. That's all. It's not telling me anything about inside the book. But genetics is all about the complete book. Every page is important, every word is important, every sentence is important, every alphabet is also important in that. So, chromosomal microarray, it detects copy number variants. What is copy number variants? It's basically talking about microdeletions and duplications at a higher resolution than karyotype. 50 to 100 kb you can get the kind of resolution there. So it identifies all abnormalities that are detected by karyotype, except this low level mosaicism and balanced translocation. I'll talk to you about that. But it will tell you more about the pages inside. And see, this is a gross example that I'm giving you. You know, don't try to see, nahi sir, usme to aapne wo bola tha, aisa nahi hai. But roughly, for basic understanding, I'm telling you, it will tell me also about the number of books, but it will also tell me about the pages inside and copy number variant. Chromosomal microarray interpretation is the toughest job to do. You may get so many copy number variants which are not abnormal. Or at least today we don't know that they are abnormal. Maybe there were some copy number variants which we thought were, you know, probably normal, but now we know that they were actually abnormal. So that is what is happening on a day-to-day basis. We are getting more and more evidence. So there is something called, you know, of unknown significance, where we don't know what is the significance of those things. What is the advantage? As I said, it will identify most abnormalities detected on karyotype and additional chromosomal imbalances. It gives you quicker results. It is useful in IUD and stillbirth. when you are sending a product of conception, if there is an IUD stillbirth, because this does not require actively dividing cells, and you can use any tissue for chromosomal microarray. The disadvantage is, or the limitation is, triploidy, you can have limitations. Balanced structural malformations and low-level mosaicism, you will have difficulties. But then, as I said, you will get lot of variants of unknown significance. And this comes in the report. Counseling becomes so difficult because there is something which is detected and they have written it is a variant of unknown significance. The patient will tell you, now tell me what. But what do you feel, doctor? See, but तुम्हाला तुमच्या एक्सपिरियन्स मधून काय वाटतो, काय सिग्निफिकन्स असेल? अरे त्यांना जेनेटिस्टला कळत नाही, मला कुठून कळणार आहे? It is difficult situation that you land up with. That is one of the limitation of microarray. So best thing, you tell the geneticist to counsel them. And these days you don't need to send them, you can, the same lab who has already charged the patient for the microarray, tell them they will arrange an online counseling with the geneticist or a telephonic conversation with the geneticist who can tell them that. So that is one responsibility we shirk off. So anything which becomes a headache, you start shirking off. That is a human tendency. This occurs in 1% of pregnancies, this VUS, effect of the variation identified is not clear, challenge of limited phenotype. Again, this VUS also, how much of phenotype you are providing them is also very important. If I provide the lab with one finding, they may say, okay, this doesn't relate to that. But if I give them 5 findings, hence that primary scan that you have done is important. You have to provide, you really need to look for everything, and there are sometimes incidental findings which are benign or pathogenic, and we don't know what to do with that. So then we have this common single gene disorders for prenatal diagnosis, autosomal recessive, thalassemia, spinal muscular dystrophy, autosomal dominant conditions like achondroplasia, tuberous sclerosis, X-linked disorders, mental retardation, and there comes the role of next generation sequencing. बड़ा fancy लगता ना next generation sequencing, and then things like exome, but वो word से ही डर लगता था हमको. No, what is that doing? It is then reading the alphabets. And isme there are 2 things that are important. There is something called whole exome, where all the 20,000 genes will be studied, but we don't need to put them everyone through an whole exome. You can use a panel. Panel means whatever are the known gene mutations for that particular phenotype, all those genes they will study. So the cost comes down. So the panel cost comes down, the whole exome becomes too expensive. So when do we start thinking about diagnostic testing in our practice? 2 things. One comes from history, or then we have findings on ultrasound. History is usually not provided. Nobody takes a history. I'm surprised even the clinicians don't take too much of an history these days. There are so many times the history is taken after we have done a scan, we have found something, and then we start asking them. Then she'll say, yes, first baby had this, and nobody till then knows about it. So rarely informed by patient also. They will also not inform you. Sometimes everything you've done the test, you have given the report, सब देने के बाद घर से कभी-कभी फोन आते, सर पण ते तसं तर नाही ना, काय नाही आहे, ते पहिले बाळाला होता ना प्रॉब्लेम माझ्या, अरे बाई कधी सांगणार मला? So you have to ask history. So you need to have a short questionnaire for yourself. You ask them advanced maternal age, previous child with aneuploidy, all those things we need to ask. Findings on ultrasound, in the first trimester you can have markers, structural abnormalities, second trimester soft markers or structural abnormalities, or if you have an early onset FGR, which is symmetric, asymmetric we don't use, but generally with a symmetric pattern, normal Doppler or FGR with polyamnios, you need to think of genetic associations and you need to ask for a definitive testing. And there are 2 more. One is an increased risk for perinatal infections that you would do a diagnostic testing, or on maternal request. I will speak on this. And so increased risk for chromosomal anomalies, I have already covered that, yes, all these things are the ones which actually give you a increased risk, and that is why we do a definitive testing there. And most common among that is the screen positive FTS. So screen positive FTS becomes one of the most common indication for doing a diagnostic procedure, or the previous baby has had a problem and the previous baby, the index child, has been investigated. Very important thing. The problem is, if I say some abnormality, they go for termination. Next pregnancy, they come back. Now, because that first child was not investigated, you start from square zero. Because patient is right in there saying ki ha बार तर गेलाय आता कशाला 20-25 रुपये खर्च करायचं. I think they have a right to think on those lines. Sometimes I tell them ki it's better that if we come to know the cause, मग they say ki sir पण ते cause कळाला तर तुम्ही काय गोळ्या देणार का पुढच्या वेळी होणार नाही म्हणून. No, I can't give you anything. So only thing I can do is next pregnancy, at 12 weeks I will do a CVS and get you an answer early. Especially cases like you have Leeson-Kifeli and all, which we are not picking up early, we'll pick them up much later. But if I know the gene mutation that was involved, I will do it early. Then we have structural abnormalities. Some abnormalities we know are commonly seen in certain aneuploidies, which you will go for, or there are some anomalies which have a genetic predisposition. Now, every structural anomaly has some genetic association, that I will tell you. We were so happy, we used to say heterotaxy, no genetic predisposition. Now we are finding this it is there. Hypoplastic left heart syndrome, no, okay, nothing. But now there is, genes involved with that also. So every structural abnormality has it. Now, if there are multiple anomalies, which we know are lethal, now the question comes whether to offer invasive and all. Offer invasive to everyone. But in practice, there is a slight trick, One thing is informing them, and the other thing is insisting on it. And you do it practically daily, every time we do it. जब हमको मन में बहुत definitely लगता है कि नहीं ये निकल सकता है, हम उस वक्त हमारा टोन अलग होता है, हम insist करते हैं. और कई बार when we feel कि नहीं, this is more not likely to be associated with this thing, we just inform them that yes, there can be an association. If you want, we can do the test there. So structural anomalies, typically you may have, like for trisomy 18, anything fits into trisomy 18. So there is no point in giving a list. हर चीज trisomy 18 में हो सकती है. लेकिन then generally an FGR, polyamnios, micrognathia, the clenched fist, choroid plexus cyst, all these things can happen. Trisomy 13, yes, a holoprosencephaly sequence, cleft lip facial abnormalities. You can have polydactyly, microcephaly, that all can come into holoprosencephaly. Down syndrome, generally we rely on markers, but then duodenal atresia and AVSD are definitely significant or strong markers for Down syndrome. All these conotruncal abnormalities and abnormalities, the aortic arch, yes, you have to think in terms of microdeletion 22q11. Of course, they can be associated with other aneuploidies also. Now, there are some anomalies like ventriculomegaly, Leeson-Kifeli, microcephaly, which can have a significant number of them can have genetic predisposition, and hence these are the ones definitely we would like to do an invasive test. Or then there is a known genetic or biochemical disease in the family. You have a known mutation for a biochemical change. You have a male fetus and carrier status of pregnant woman for a disease with X chromosomal inheritance. I don't want to get into these fancy words to complicate you. Otherwise, you think I'm speaking like a geneticist. So I will not. I'm just putting this to make a complete talk here. But beta thalassemia I do want to talk about, because in India the overall prevalence is very high, 15 to 17% in different states, and that is the reason we need to screen the parents for beta thalassemia. We need to screen the parents for beta thalassemia. Fortunately in India there are 5 common mutations which can have, and hence a complete workup needs to be done. You can't just directly do for beta thalassemia. You need to see whether both the parents are carriers for that, and then, or if they have a first child with beta thalassemia, then definitely you need to go further with invasive testing. So it's not just about looking at the complete blood count, but you need to do the HPLC, HbA2 with complete blood count this would be a talk on its own, but that is all we need to. We need to increase the screening for beta thalassemia because we have a pretty high prevalence in India. And then you can get a CVS done and find, like in this case, there was a mutant allele which was present, and hence the fetus is more likely to have beta thalassemia. Now you can have DMD, osteogenesis imperfecta, cystic fibrosis. If the previous child has it, you will do that. Maternal transmittal, if you have a seropositivity or you find changes of infection, like even ventriculomegaly, we say we do an amnio to rule out Down syndrome, but you can do a PCR for ruling out infection in those cases. Maternal requests, sometimes patients come and say that they want to get an invasive test because they want to have a definitive this thing. Generally, it is not a standalone criteria, but in exceptional circumstances where there is an acute parental anxiety, yes, after extensive counseling, you can advise that, no problem with that. And another indication for all those who are doing invasive testing, there is an indication because it has been referred for an invasive test. Somebody has referred for an invasive test. Somebody has got, I just want to tell these people that respect everyone, no problem. Respect everyone's opinion, respect everyone's decision, but believe in no one. The patient has come to you for an invasive test just because, yes, somebody has said there is this problem and that is why you need to go ahead and get an amniocentesis done. Don't put in a needle. You confirm those findings because you are the one who is putting in the needle. You need to be very sure of that. You believe, you respect that person's report. No problem. He has said this, but let me confirm it. There are times you will find that, yes, you may find that those findings are not present and unnecessarily you're going to put in a needle just because somebody has said that go and get a procedure done. So make your own decision and counsel. Accordingly, suggested amniocentesis. This is the worst thing I'll find in reports. Suggested amniocentesis. This is like a physician writing suggested blood test. Blood test is what? Now, what? Suggested amniocentesis. But that's again a method of taking out something, like doing a blood test. So you have to tell what test. Because if I suggest blood test, then I'll write down for hemogram, for CBC. So it's important that you suggest the test that is required. And if you're not very good with that, then you suggest a geneticist consultation or you consult a geneticist. Everybody is available on phone these days. Or let the patient pay for that consultation. No problem about that. But just suggest amniocentesis is not the right thing. Follow the basic principles of counseling. The most important basic principle of counseling is both the parents should be present for counseling. This unfortunately is not happening, that is why I have brought it here. Husband, mother-in-law, father-in-law, mama, mami, neighbor, uncle, auntie, सगळे येऊन बसतात आणि बिचारी आईला तिकडे बाहेर बसवलेला असतो. नाही तिला बोलू नका, ती घाबरेल. मी म्हणतो उठा. If she is not going to come in, I am not going to counsel. She is the only one who has the right to decide whether she wants to continue with this pregnancy or not. The husband also does not have the right. आणि father-in-law, mother-in-law तर सोडून द्या. Husbandला पण हक्क नाहीये. Mother is the primary person who, tomorrow if the mother says, I don't mind continuing with a child with Down syndrome, no problem about it. We support that decision. But for her to take that call, she needs to be informed. हे लोक बाहेर जाऊन तिला काय बोलणार? It's going to be fabricated on what they think is right. आणि हे आपल्याला, and we are the best people to talk. So mother should always be there. Counseling should be non-directed. Don't do directed counseling. I always give this example. जो सीनियर लोग यहाँ बैठे हैं मेरे एज ग्रुप के, दे वुड नो, दूरदर्शन पे न्यूज देने के लिए वो सलमा आती थी. ब्लैंक फेस से शी यूज्ड टू रीड द न्यूज, हैप्पी न्यूज, बैड न्यूज, एवरीथिंग. देयर यूज्ड टू बी नो, भारत ने आज वेस्ट इंडीज को हरा दिया है, यू नो, बट देयर इज नो, नॉट द काइंड ऑफ एंकर्स वी हैव टुडे. भारत ने आज ये किया, वो किया. दैट इज नॉट काउंसलिंग. काउंसलिंग इज सलमा. You are not you are just going to go for Arnav Goswami is directed counseling. We want to do indirected counseling. Audio visual recording of counseling, if you can do, very good. It will help you medico-legally. Written format with signature of both parents. Provision of adequate information to allow patient decision making. Respect for patient values and autonomy in making a choice. They make the freedom to make a choice is always with the parents. So tell them about the complications of the procedure. Let them know about the complications of the procedure and tell them, I'm not telling you to scare this. It is important that you should know this because the law tells me to inform you this. That is why I am informing you. लोक म्हणतात सगळं जर तिला आता कॉम्प्लिकेशन सांगितलं ना तर मग ते ॲग्रीच करत नाही टेस्टसाठी. नाही केलं ठीक आहे. पण the law says that you should give them that kind of information. Explain in short exactly what is going to be done. Then tell them the fetal loss rates. Inform them about the fetal loss rates. कि भाई CVS में कितना fetal loss rate हो सकता है, amniocentesis में कितना. You can also tell them about the national loss rates or the loss rate in your own center. That nobody tells. Everybody says माझ्याकडे कधीच काही problem झालेला नाही आहे. What test and time that will be required for the report, that also needs to be informed. The cost involved, very important thing, you need to inform them what would be the cost of these tests. Then what is the accuracy of CVS, what is the accuracy of amnio. Based on that, they can think whether they want to wait for 4 weeks and then do an amnio rather than doing a CVS. Now, then if it turns out to be positive, then or it turns out to be an abnormal result, the timing and type of termination. Can a termination be performed in an abnormal result? That also you need to speak to them. The need of a geneticist consultation after the report, yes, you need to speak to them about that. Yes, okay. Whatever, finally, genetics is a vast subject. I know from my practical experience these things, but this would require a more expert person to speak to you and give you information. So I would suggest that you need to consult a specialist on that, and that is a geneticist. And then need for NTD after the procedure, that also you need to think. Answer all their questions. Don't do standing counseling. उभं आपलं जा तुम्ही मी तुमच्या मॅडमशी बोलून घेतो. अरे counsel the parents, not the clinician. You have to counsel the parents. So let them sit peacefully and answer all their questions. Charge separately for counseling, no problem about that. But give them that kind of a time. It is such a difficult decision to make. आपण म्हणतो की we leave the choice on them. But just imagine as doctors, आपल्याला किती, suppose if I am into that situation, how difficult it is going to be to take a decision. So at least if they have questions, answer them. पण after सगळं केल्यानंतर they will ask you, doctor, what decision would you have taken? That is the tricky part. Okay, I've gone through, I've given all kind of answers in my life so far. I have said, okay, I'm not in your shoes at the moment. When I'm in that position, maybe I will think. But now I have found a very nice way, and I tell them, मी तुम्हाला सांगू शकतो, पण देवानी हा हक्क फक्त तुम्हाला दोघांनाच दिलेला आहे. मला तो हक्क नाहीये. मी तो हक्क तुमच्याकडून मला घ्यायचं नाहीये. म्हणून मी तुम्हाला सगळं इन्फॉर्मेशन देतो, पण तुम्ही शेवटी कसं आहे, हा तुमचा हक्क आहे. तुम्ही दोघं बसा, त्याच्यावर विचार करा आणि मग आपण हे करू. ऐसा प्यार से you have to push them out of that. So right information and exercising rights, educated and aware patient, and that leads to a good committed relationship. And that committed relationship will eventually help them in their future pregnancy also, because they have started believing in you. They know that yes, next pregnancy I have to come to them. This doctor is definitely going to help me out. Maybe sometime to have a normal baby. And have a written format of the counseling in both languages. PCP&DT requirements, you need to do it. I'll quickly take you to 3-4 cases. Maternal age 31 years, 6 CRL, NT 2.2, which was at the 91st centile. NBDV were normal, no TR, no structural anomalies. Combined screening was 1 in 367. What do? NIPT. So, but we counsel them. We tell them, okay, 1 in 367, protocol says we can go for an NIPT, but if you want a definitive answer, you can do this. Patient opted for NIPT, which was low risk. Second trimester ultrasound was normal. Everything went normal. 21-year primary, CRL 68 millimeter, NT was 4.8 millimeter. What do we do? Combine. No, sorry? Yeah, everything else normal. She says invasive. He says combined screening. Somebody says NIPT. 3.5 and above. Whatever combined you do, it's always going to come high risk. An NT of 4.8 is very high. You can directly ask them for an invasive test, and this turned out to be positive for trisomy 21. 27 years patient at 19 weeks 4 days, unossified nasal bone, EICF, mild bilateral pelviectasis, no structural abnormalities. 3 markers. FTS was done. That is what I wanted. You should first look whether any previous screening has been done or not. First trimester screening was 1 in 297. Of course, reported as low risk because they were not using the intermediate risk. But nasal bone that time was reported as normal, which could have been a mistake there. Options discussed, both invasive and IPT. Patient opted for invasive. She has a right. Now anyway, if the FTS was 297, now with these 3 markers, the modified risk is always going to be very high. So definitely it was, that is where thoda sa directed counseling ho jata hai aapse. Where you, in spite of that, you keep saying ki nahi, but then this is definitely on a higher risk. Patient opted for this, QF-PCR with CAMA was done. It turned out to be trisomy 21, termination of pregnancy was this thing. 19 weeks, 3 days, no earlier scans done. FGR, mild polyamnios, CP cyst, diaphragmatic hernia, microcnethia, talipus, clenched fist. Invasive? Yes, we discussed that with them. This is going more likely to be trisomy 18. We need invasive testing, and we told them about the cost involved. Very poor patient. They opted for termination of pregnancy, not willing for invasive. No problems about that. Fine. We advise them in next pregnancy 12 to 13 weeks. See, always support. आता मी सांगितलं तुम्ही आता करत नाहीये, मग जाऊ दे आता पुढच्या वेळी माझ्याकडे येऊच नका. What have we said so far? That the decision is with the parents. They have decided that we don't want to. No problem. We support their decision. And so, but we still advise them, okay, but next pregnancy, don't come directly in the second trimester. Get a good structural anatomy evaluation and NT at 12 to 13 weeks. Case 5, kidneys. What do you feel with this kidneys? Slightly more ecogenic. We've used high frequency transducers, and there you can see 2 small cysts. Not very scary as such. Not very scary. Liquor is normal, bladder is normal. The kidneys, mother's kidneys are normal. Always evaluate. But we told them, you see, I saw the father also, I saw both the previous children also, they were also normal. But we discussed with them, yes, this can be like this now, but maybe later in pregnancy you may find that they may become bulky. We've had another case where I found at 19 weeks absolutely normal. 23, 24 weeks, the gynecologist called up and said ki Vimal Likers nahi hai tachatata. I was out of station, the patient went to Shilpa, and it was classical ARPKD in this thing. So we did that, and they said ki okay, no, we already have 2 children, we don't want to take that chance anyway. If you are suspecting, let us go and do it. And this turned out to be pathogenic for a polycystic kidney disease. This case was reported by a radiologist as mild ventriculomegaly, then went to a Swayam Ghoshit fetal medicine specialist who said ki no, this is around 9.6, 9.8, FTS is normal. Low risk FTS, fine, doctor couple. Then they thought, ki let's take one more opinion. They came here. Yes, it was ventriculomegaly. There was like around 11 millimeter. This all happened over a period of 3 to 4 days. But there was a membranous VSD. There was ARSA. See, this whole discussion was going on since 4 days. But all along, if somebody would have concentrated on the phenotype, things would have been different. Now this is where, whether you want to do a fish with chromosomal microarray or a fish with karyotype. Manoj? Sorry? Microarray, okay. No, that's right. Everybody, see, we thought the other way around. Let's do a fish. I said they will pay for the karyotype. And if the fish turns out to be trisomy 21, we go ahead with the karyotype. If it doesn't turn out to be trisomy 21, we will go ahead with the microarray. Because here I am suspecting trisomy 21 more, and then I don't want to lose out on the balanced one, because the counts, see, all Down syndromes do not have recurrence. Majority of them do not have. It is only that subset which can where the history of a previous child with Down syndrome is important, and we did that. So with what test and when is the most important information that you need to provide. All possible options need to be discussed with the patient. Innocent fetal lives should not be lost by terminating the pregnancy without having a proper genetic diagnosis. Invasive procedures are much safer than what we fear them. Invasive fetal procedures have a much greater role beyond aneuploidy detection. Genetics is not just aneuploidy. There is much more to that. Suggest the test that is required. Seek a geneticist consultation. That's a very important message I don't give. Don't feel ashamed of taking an expert evidence. Opinion, it's always helpful. Talk to them. Always keep one geneticist very friendly with you. अभी गंभीर सर यहाँ आए हैं तो मैं 1 घंटा उनसे जरूर गप्पे मारूंगा, क्योंकि I want to keep myself in good books. Because every time I need to discuss, I should feel free to call him. Okay? And if patient is not willing for any test, an option of DNA storage needs to be. That is again, I want an appeal that I make to the obstetricians also. So many times the patients are not willing. They don't want to get it done. You're terminating the pregnancy. Please speak to them about DNA storage. Because they may not be willing to spend now. You have a DNA which is stored later on when they have been counseled well and all that. Okay, at least we have something about the index case which is available and we can use that. So take home message is no genotype without phenotype. At this moment, the phenotype is very important. So all my imaging friends, let me tell you that fetal imaging is the cornerstone of fetal medicine. Hence, first you should really improve your fetal imaging, and then everything else will follow. Thank you very much.
Hello. Thank you so much, sir. It was indeed an eye-opener, and so many practical points, so many points that we can take home from this lecture. Thank you so much.
Thank you very much.
Genetics can be so exhaustive and so very important to know about. The next lecture is by Dr. T.L.N. Praveen, sir. He has already talked about the fetal heart, and now he will be talking about the fetal CNS, all that we need to know about it. Thank you, sir. Welcome, sir. There are some changes in the program, and after the talk by T.L.N. Praveen, sir, Dr. Gambhire will be giving a small lecture on genetics. After that, we have a lunch break, and then the next session.
I am holding. I know. Yeah. उसको दे देना. Vimal? Charger. Oh, okay, okay. Good afternoon. I think you are all exhausted. Now, how many did you understand about the phenotype? Come on, please tell. I mean, Vimal is waiting there. No, it was a wonderful lecture. I mean, at least I learned a lot from that lecture, and I actually asked him to give me a copy also, because that's how the approach is. I mean, today, if we are trying to do some work on fetus, it has to be incorporated with genetics. Without genetics, I think we are nowhere. And that is one good step that we are going to take, because once you know the genetic mutation, the future pregnancies can be counseled very properly. And not only that, this DNA storage is one of the most important things, because you have an index case, and that will really help you to further evaluate the present fetus. And based on the information that is available, you can take the samples from the present fetus and compare it with the previous DNA, that is the index case. That gives you a lot of information, a lot of confidence level, wherein you can counsel the parents in a proper way. So I think all of us, I think we have to start moving towards the genetics, and then only we can progress as well as do some justice to fetal medicine. Now let me get back to today's topic of mine, that is the neuroanatomy. Particularly, I think most of the anatomy has been shown to you yesterday, but I'll just briefly take you through. Most important thing that we all know that the fetal brain is an evolving structure. And we know that it evolves from 3 vesicles in the early stages of pregnancy to a very complex structure. And it is essential that we need to understand the normal brain development as well as at various stages of pregnancy, because the normal variations and normal developmental process are the ones which are going to decide about the various abnormalities that we can identify or detect during the pregnancy. Now, ultrasound will definitely help us in evaluating the morphology of the brain, migrational abnormalities, maturation as well as myelination. All these things can be identified by doing a proper neuroanatomy or neuroanatomy evaluation by ultrasound. And CNS abnormalities are one of the most common abnormalities. If you take the abnormalities in your day-to-day practice, the most commonest abnormalities are the cardiovascular abnormalities. Second most commonest abnormalities are the CNS abnormalities. So we need to understand the neuroanatomy before we start diagnosing the abnormalities of the central nervous system. That is the reason why today's topic is CNS, what to look for. So that's what I'm going to take you through. Now, how am I going to take you through, in the sense that what is the approach that I am going to follow in evaluating the central nervous system? First and foremost thing is the transabdominal route, that I would like to evaluate the fetal head transabdominally, and wherever it is possible, I will not hesitate to do a transvaginal examination. Remember, whenever the fetus is in the cephalic position, whichever the slightest doubt which you have on a transabdominal examination, please do a transvaginal. Don't hesitate, because transvaginal gives you a vastly better image quality, as well as manipulation becomes much more easier, particularly when you want to do advanced neurosonography without a transvaginal examination. Getting the coronal sections as well as the sagittal sections becomes very, very difficult. So that is the reason why we would definitely advise that we need to do a transvaginal examination. There are some people who are very aggressive in the sense, suppose if I do a scan and I find that there is a central nervous system abnormalities which I am suspecting, and unfortunately the fetus is in a breech position, there are people who do an external version to get the fetus head down so that they can do a transvaginal evaluation of the fetal head. So that is the level of importance that we have by doing a transvaginal examination to evaluate neuroanatomy. Next is of course, wherever it is possible, you can acquire the volumes of the fetal head and then manipulate it in such a way that you can get the coronal as well as reconstruct the coronal as well as the sagittal sections. And always MRI is a complementary investigation. Remember, MRI has been at one time overplayed, in the sense they say that there are certain articles that have been published that saying that MRI is the ultimate imaging method in evaluating fetal central nervous system. But no, it has been proved beyond doubt that the the incidence of or identification of central nervous system abnormalities by a proper transvaginal high resolution evaluation is as good or even far better than an MRI. So, but then I would definitely ask for an MRI wherever there is a equivocal findings, where I am not very, very sure about what I am dealing with. Definitely I would like to have a supporting imaging modality. Not only that, I would like to have one more of my colleague who is going to be responsible for the factors which I have seen. I mean, it's like taking some support, isn't it? So that's the reason why we definitely do ask for an MRI. There are certain guidelines that have been laid down. We will definitely follow the guidelines. The one is the American guideline, the other one is the ICIOG guidelines. Now, let us go through stepwise. What are the things that I am going to look for and when I am doing 11 to 14 week scan? And what are the things that I am going to look for as far as the fetal central nervous system is concerned between 18 to 22 weeks of scan. Now, in 11 to 14 weeks, most important thing, basic examination of the fetal brain is going to be transventricular and mid-sagittal sections. These are the two sections that we are going to take, and most of us are always going to do this, particularly the mid-sagittal section, because first trimester screening is very important. When you do a first trimester screening, if you are focusing properly, you can identify most of the intracranial structures. So that is the reason why we need to do that particular one. Now, next is the 18 to 22. Basic examination is axial views or the transverse views. There are three transverse views or the three axial views which we focus upon. One is the transventricular, transthalamic and transcerebellar, right? So let me take you through each one of them. Now, for example, when we do a 11 to 14 transventricular plane, you can observe it that I have done one section on transabdominal, the other one is a transvaginal. Would you appreciate and say which is far better and far appealing to you, that information that is obtained is much more by doing this? Don't you think that this is much superior to the one which we have done by transabdominal route? But still, transabdominal does give us information, particularly first and foremost thing that the cranial outline is very clearly delineated. First and foremost thing, I know that there is a good cranial vault which is normally seen, the shape of the head is normal, and also I can see the interhemispheric fissure which is very, very important to demonstrate, and then the choroid plexus, and the choroid plexus are filling the whole of the lateral ventricles except for a small portion of the frontal horns which are filled with CSF. So basically where we are here looking at is what is called as the butterfly sign, where you have the interhemispheric fissure as well as the choroid plexus filling the ventricles. So these are the two most important things that you are going to evaluate as far as the transventricular plane is concerned. So when you say it is a transventricular plane, you basically intend to say that the ventricles are being evaluated. So in the first trimester, particularly 11 to 14 weeks of scan, you need to identify that the whole of the lateral ventricles are filled with the choroid plexus except a small portion of the frontal horns. So this is an important statement. If suppose there is an alteration in this sort of a ratio between the choroid plexus and the lateral ventricle, definitely it prompts you to think in terms of a possible ventriculomegaly which you need to evaluate. Remember, ventriculomegaly is only an ultrasound feature, it is not a diagnosis. Once you say there is a ventriculomegaly, you need to further evaluate the cause for the ventriculomegaly. So that is how you are going to approach. Next is the other thing is, remember at this stage of pregnancy, you are not going to see the CSP, that is the cavum septum pellucidum. Okay, so these are the things that you have to name. And whenever you have this butterfly sign, if there is any obliteration of the butterfly sign and the interhemispheric fissure is not seen in the anterior part, then you know that you are dealing with a lobar holoprosencephaly or a cleavage abnormality of the fetal brain. So these are the various things that you can identify by just doing one transventricular plane at 11 to 14 weeks of gestation, which Dr. Silpa has also shown us. And then this is another wonderful section which I really, really adore in the sense because the information which is obtained by this particular mid-sat section is extremely important, because you can see that the calvarium is seen normally. You can also see that the nasal bone is seen, palate is seen, you can see the omer, you can see the mandible. Okay, not only that, can you see this one, this echogenic area looking like a curtain? It is nothing but the falx cerebri. So this is the falx cerebri which is seen because you are taking at the mid-sag, that means you are cutting through the interhemispheric fissure. This is the falx cerebri which appears like a curtain. That is one important thing. Then just below that curtain, you have a rounded hypoechoic area which is nothing but the thalamus, which develops or progresses into the brain stem. In the brain stem, this is the brain stem. Just below the brain stem, you just try to imagine in a 3D fashion in a coronal section where this fourth ventricle, is a fluid filled structure which is just below the brainstem is nothing but the fourth ventricle, which is in this sagittal section is known as the IT or intracranial translucency. Just below it is the CSF, it's the cisterna magna, and then the occipital bone. So basically when you see this one, these are the structures that you are going to see, in which we have what do you call it as 3 lucencies, which Silpa has been telling us since yesterday. So 3 lucencies and 4 echogenic lines. Now, another important parameter which we have to understand very clearly is the size of the brainstem and the size of the brainstem to occipital bone. So these are the 2 most important things that will help you, really help you in identifying Arnold-Chiari malformation, type 2 malformation, where there is a traction of the central nervous system, particularly the posterior fossa component, because there is a open spinal defect. So in these things what happens is, this brainstem, as you know, whenever there is an open spinal defect, there is leak of CSF, so there is a collapse of intracranial translucency. Not only that there is a collapse of intracranial translucency, because of the traction, there will be obliteration of cisterna magna. This is an extremely important one. So obliteration of cisterna magna. So what happens is, brainstem appears bigger and then the brainstem to occipital bone. So whenever the brainstem becomes bigger, the brainstem to brainstem occipital bone ratio is altered. It becomes higher, isn't it? Because the brainstem is normally, when you take the normal brain, where there is a brainstem, the measurement of brainstem will be smaller than the measurement of brainstem to occipital bone. Whereas whenever there is a leak, the brainstem becomes bigger, brainstem to brainstem occipital bone becomes lesser, so naturally the ratio becomes higher. So whenever the ratio is higher, you know that you are dealing with an open neural tube defect. The other way around, whenever there is a alteration in which the brainstem diameter is reduced, why will it be reduced? Only when the fourth ventricle, that is the intracranial translucency, becomes bigger. When will the intracranial translucency become bigger? Whenever there is an aneuploidy. That is one of the features of aneuploidy is large fourth ventricle, which is more than 19 millimeters. If it is more than 19 millimeters, you have to think in terms of a large intracranial translucency, and that causes compression of the brainstem and results in a small brainstem, large intracranial translucency. Then you need to think in terms of aneuploid. So this brainstem to brainstem occipital bone ratio is an extremely important parameter, as well as as far as the 11 to 14 weeks mid-SAT scan is concerned. Am I clear till now? Yes? Right. Now, coming to the extended neurosurgery. Okay, these are the transventricular and sagittal sections, which are the commonly taken sections as far as the first trimester scan is concerned. When you try to evaluate further, or when you want to have more information, you would like to do what is called as the peduncular plane, in which if you slightly rotate your transducer caudally, in which you can, in which you can find the anteriorly, you can find, so you can find this one here, okay. These are the thalami. Can you make out? Can you appreciate? Yes. There is a slit-like structure here. You agree with me? Yes, that is the third ventricle. Just posterior to it, this is all the interhemispheric fissure. Just posterior to it, what you have is that you have the, what is this? Fantastic, aqueduct of Sylvius, and you know the distance between the occipital bone and the aqueduct of Sylvius. If it is closer, you call as the crash sign positive. That means it indirectly tells there is a traction. That means there is indirectly tells you that there is a CSF leak. Am I clear? So this is how you are going to make use of this particular section, which gives you this sort of information. Now, am I sure? I mean, you are sure about what you are going to look for in the 11 to 14 week scan? Yes? Shout. Ah, fantastic. Great. Right. There is one more section that I would like to do is the transcerebellar plane. In this, again, in the posterior fossa, this is basically intended to evaluate the structures in the coronal plane. I told you, no, in the sagittal plane, that's what you have seen, that is the brainstem, IT, cavum, the cisterna magna and the occipital bone. The same things can be seen in the coronal section. This is the video and this is the static image where you can see this hypoechoic brainstem. You find the echogenic fourth ventricle, you find the cisterna magna. Now, I'll just freeze this one and I show you this communication. This is a very important. Can you see this communication? That is the fourth ventricle to cisterna magna. This is what is called as the Blake's pouch. Now, remember, the fourth ventricle, that is the IT, is always in communication with the cisterna magna through a Blake's pouch. This is a finger-like invagination of the fourth ventricle. This normally perforates by about 12 weeks of gestation. When it perforates, it forms the foramen of Magendie and that allows the CSF from the fourth ventricle to trickle into the cisterna magna. Whereas whenever it persists or whenever there is no perforation of the cisterna, the fourth ventricular finger-like invagination, it results in what is called as the Blake's pouch cyst. But then the flow of CSF from the central nervous system, that is particularly the fourth ventricle, do continue by foramina luschka. So that's the reason why you still don't find hydrocephalus or ventriculomegaly. Am I clear? So this is the anatomy that you need to understand, and these are all the things that you can get by doing this transcerebellar plane. Now, the second important thing is, now let us get to the other, that is the mid-trimester central nervous system evaluation. In the mid-trimester central nervous system evaluation, quite often you do 2D, but wherever it is required, I would never hesitate to do a transvaginal examination because you have seen the image quality that and the resolution and the amount of information you can get by doing a transvaginal examination. Now, basically, the mid-trimester central nervous system evaluation is done by 3 axial planes, that is the transthalamic, transventricular and transcerebellar. You know what is transthalamic, isn't it? What is transthalamic plane? What is it used? Fantastic. So these are the things, and then in these things we are going to use or get information regarding this skull vault, interhemispheric fissure, cerebral hemispheres, midline structures, lateral ventricles. Whereas if you go into the posterior fossa, then you would like to see the cerebellar hemispheres, vermis, cisterna magna, sylvian fissure and parieto-occipital sulcus or the sulcus. So these are the things that now remember, one most important thing is when you call a system that is ventriculomegaly, which is more than 10 millimeters at the parieto-occipital segment, you basically measure the posterior horn or the body of the body of the lateral ventricle, because that is the largest part of the lateral ventricle, and that is measured at the parieto-occipital sulcus. Now, identifying a ventriculomegaly on one side is not sufficient. Whenever you want to call it as a ventriculomegaly, you need to define whether it is a unilateral ventriculomegaly or is it a ventriculomegaly which is there on the opposite side also. So, it is essential that you need to identify the near ventricle. Quite often, we all know that whenever we try to evaluate the ventricle, the far ventricle is the one which we try to measure, isn't it? That is where you can see it quite clearly. Why is it so? It is basically because the near cerebral hemisphere is hazy because of reverberation artifacts. As there are reverberation artifacts, quite often you really cannot make out the normal anatomy of the near cerebral hemispheres. That is the reason why you need to struggle a little bit. Angulate your transducer for about 30 degrees from the midline so that you can get the opposite or the near lateral ventricle also measured. So, when you are saying ventriculomegaly, you need to specify whether it is unilateral or it is bilateral. You need to specify the near ventricle measurement and the far ventricle lateral ventricle measurement. Am I clear? Because this is an extremely important step which we quite often avoid. Okay. The next is the axial views. When you take the axial views, as I said, this is the transventricular, transthalamic, transcerebellar. Remember, all these 3 axial views should include the demonstration of cavum septum pellucidum. This is an extremely important statement. If you are not going to demonstrate the cavum septum pellucidum in all these three views, you know that your section is not appropriate, and that is the reason why you need to demonstrate them. Okay, what are the things that you are going to look for as far as these sections are concerned? First and foremost thing is when you take the transventricular plane, you know that it is basically intended to evaluate the ventricular size. Am I correct? So in that, you basically look for the cavum septum pellucidum because, as I said, all axial views should definitely have a cavum septum pellucidum. This is the cavum septum pellucidum, which is a box-like or a rectangular structure. Sometimes it can be even triangular. Remember, the AP diameter is more than the lateral to lateral diameter. This is an extremely important statement again. Then we have the frontal horns, which are comma-shaped, which are skirting the cavum septum pellucidum. Then we would like to go to the posterior horns, where you can see the posterior horns, you can see the choroid plexus, you can see the parieto-occipital sulcus. That is the point where you are going to take the measurement. So this is how you are going to take the measurement, where you identify the parieto-occipital sulcus, medial wall, lateral wall. Quite often you cut through the choroid plexus, which is actually the glomus of the choroid plexus, and this is which gives you exact size of the lateral ventricle. This is how you are going to evaluate the lateral ventricular size. Remember, if you are not able to demonstrate the lateral wall appropriately, you may mistake this wall, that is the cortical lining, as the wall, and if you call this as a ventriculomegaly, you will be in trouble. So that is the reason why you have to very clearly demonstrate the lateral wall, medial wall, and the parieto-occipital sulcus before you take a measurement. Okay, so this is one thing. Then next is in the transventricular plane. These are all the things which I have already told you. The upper limit of normal is 10 millimeters, and CSP is triangular or rectangular, which I have already discussed, and it is flanked by the anterior horns. So this is what you are going to look for as far as the transventricular plane is concerned. Now coming to the transventricular plane, particularly the CSP. This is an extremely important structure. As I said, every axial view should have a CSP. Why should we have a CSP? Because if you take it into consideration, if you take this cavum septum pellucidum, it is an important structure because any alteration in the size, in the shape and location or disposition of the cavum septum pellucidum indicates that there is an abnormality in the corpus callosum. So that is an important indication to tell you about the abnormalities in the midline. So when you take the cavum septum pellucidum, basically you need to understand that you have to, the posterior extension of the cavum septum pellucidum is called as cavum vergi. Still further extension up to the splenium is called as the cavum villi interpositum. These are all normal structures. There is nothing abnormal in that. Okay, so that is one important. Now, what do you call it as an anterior complex and what is posterior complex? So that is again an important factor because you know that there are certain abnormalities which are specific for anterior complex, there are certain abnormalities which are specific for posterior complex. So you need to identify which are the anterior complex and which are the posterior complex. So when you take the anterior complex, the structures that are actually, I'll show you this one and then you will apply. Now here you can see this is the interhemispheric fissure. Can you see an echogenic line here? Yes, no. That is the callosal sulcus. Just below it there is a hypoechoic area, which is the superior margin of the cavum septum pellucidum. It is nothing but the genu of the corpus callosum. The lateral margin, that is the frontal horns on either sides, cavum septum pellucidum, all these things put together are the anterior complex. Am I clear now? So this is when you say, if I give you a report saying that there is an anterior complex abnormality, these are all the structures that I mean to say that the anterior complex, one of these structures can be abnormal. Now coming to the posterior complex, you have the posterior complex, that is the posterior part of the interhemispheric fissure, parieto-occipital sulcus, posterior horns of the lateral ventricle, particularly the medial wall, and then the posterior extension of the interhemispheric fissure is all put together is the posterior complex. Am I clear up to now? So this is how you are going to evaluate the fetal brain as far as the transventricular plane is concerned and this CSP is concerned. Now coming to the transthalamic, which is actually all of us know that it is a biparietal diameter, the section which is used for biparietal diameter or the head circumference, in which again you will see the frontal interhemispheric fissure, you can see the interhemispheric fissure, you see the callosal sulcus, and then the genu of the corpus callosum, cavum septum pellucidum, frontal horns, Third ventricle is seen very nicely because you are taking the section at the thalamus, right? The previous section was a caudal section, that is the cranial section, where it was above the transthalamic section, that is the transventricular. Next section is the transthalamic, in which between the two thalami you find the slit-like structure, which is actually the third ventricle, and then the choroid plexus of the fourth ventricle. Third ventricle, lateral ventricles are also seen. Hippocampus gyrus, this is the hippocampus gyrus, and then we take the measurements of, and then you can see in the Sylvian fissure very nicely here. Okay, so these are all the things that you are going to look for as far as the transthalamic plane is concerned. Now coming to the transthalamic plane with a caudal tilt, you are going to see what is called as the cerebellar peduncles, which is extremely important because whenever you want to diagnose certain posterior fossa lesions, particularly in the form of a Joubert syndrome, you need to identify this particular structure. This is actually the cerebellar. These are the cerebellar peduncles, which you can see. In the first trimester, Silpa has shown us how the cerebellar peduncles converge laterally, posteriorly. Similarly, here also, these are the cerebellar peduncles. You can see an echogenic area all around it. This is actually the anteriorly is the interpeduncular cistern. Laterally on either side is the cisterna ambiens. Posteriorly is the quadrigeminal cistern. When I am saying cistern is a fluid-filled structure, but then it is appearing echogenic. Why? Because of pial reflection. Pia is always outlining it. That is the reason why it is echogenic. Remember that. Okay. So this is the way you can identify the cerebellar peduncles and the interpeduncular fossa or the cistern. Now coming to the transcerebellar, the most important thing is, again here also we would definitely like to see the cisterna cavum septum pellucidum, frontal horns. This is the interhemispheric fissure. You have the dumbbell shaped or figure of 8 shaped cerebellar hemispheres. The transcerebellar distance is equivalent in millimeters to the gestational age up to 26 weeks of gestation. But beyond that, whenever there is a transcerebellar distance which falls below the nomogram chart for that gestational age, you know that you are dealing with a cerebellar hypoplasia. Not only that, if you see in between connecting these two hypoechoic areas is an echogenic rectangular structure. This rectangular structure is the vermis. Fantastic. Now, when I want to see the vermis in total, this actually, when you take this particular section, the vermis which you are seeing is only the upper 1/3 of the vermis. Now, when we want to see the lower 1/3 of this, lower 2/3 of the vermis, what we need to do is what is called as the modified occipitobregmatic view, wherein you are going to tilt your transducer in such a way that you are cutting through the occipital region to the bregma, that is, you are taking an oblique section so that you can see the lower 2/3 of the vermis also. And can you see this fluid filled structure here? What is this? Fantastic, fourth ventricle, great, very good. And then here also we are going to assess the depth of the cisterna magna, which should not be more than 10 millimeters. So whenever you have a Blake spout cyst, how do you identify that? Not only that there will be a communication with the fourth ventricle, most important thing is the fluid in the axial view, the fluid in the Blake spout cyst is clear, whereas the fluid in the cisterna magna is corpusculated. What do you mean by corpusculated? Corpusculated is nothing but the dural tags which are there in the cisterna magna, whereas there is no dural tag within the Blake spout cyst. So that is how you are going to differentiate one from the other as far as the axial view is concerned, because once you have a suspicion of a Blake spout cyst, you definitely would do a sagittal section to confirm that, right? Okay. Then comes whenever you have an abnormality, we are definitely going to go in for an advanced neurosonography, wherein the most important thing is the coronal as well as the sagittal sections. And whenever it is not possible to get a transvaginal evaluation of neurosonography, you can acquire the volumes and manipulate the volumes in such a way that you can get the coronal sections as well as the sagittal sections. You have 4 coronal sections and 3 sagittal sections. The 4 coronal sections are the transfrontal, transcaudate, transthalamic and transcerebellar. And the sagittal sections are 2 parasagittal sections and mid-sag section is 1. So these are the things that we are going to have, and the approach is usually transvaginal, wherein you can use the frontanelle, that is either the posterior frontanelle or the anterior frontanelle as the windows, because they can allow you as an acoustic windows to see the intracranial structures, Or you can use the sutures. You can use the sutures such as the metopic suture, coronal suture, sagittal suture, as well as the lambdoid. And you can see one more suture, I don't know whether you have heard about this, is the infundibular suture. So these are all the sutures that you can make use of as windows to see the intracranial structures. And transvaginally, this is possible. Transvaginally, transabdominally, it is definitely difficult to evaluate all these things. Now, when it comes to coronal, these are the 4 sections. As I said, this is the they were starting with the transfrontal. In transfrontal, we can have the continuity of the interhemispheric fissure. Not only that, you have got the anterior horns on either sides of the midline. These are the structures that you are going to look for as far as the transfrontal coronal plane is concerned. Next comes the transcaudate plane. In the transcaudate plane, again you have the interhemispheric fissure. You have the cavum septum pellucidum, frontal horns which are comma-like. You have the callosal circles. You have the genu of the corpus callosum, caudate nucleus, and then the lentiform nucleus will be just at the angles of the frontal horns with the cavum septum pellucidum. So, why am I specifically showing you this? The reason is that whenever there is an intracranial hemorrhage, the commonest site is the lenticular nuclei. So, that is the reason why you need to identify the lenticular nuclei, particularly at the angles of the frontal horn with the cavum septum pellucidum. That is the place where you get the lenticular nuclei, which is the commonest site for intracranial hemorrhages. Next comes the transcaudate, this is the same thing which I have already told you. And then we have the transthalamic plane, wherein you will again find the interhemispheric fissure, callosal sulcus, genu of the corpus callosum, cavum septum pellucidum, lateral horns on either sides. Not only that, if you see this one, this is the beautifully demonstrated cingulate gyrus. This is extremely important when you are trying to evaluate the gyral abnormality or cortical neuronal disorders. When you want to see the sulci, I will show you how you have to identify the sulci as I take you through the talk. Then comes the transcerebellar. Again, transcerebellar is the posterior structures where the posterior horns are seen as the owl's eye on either sides. This is the posterior interhemispheric fissure. You have the hypoechoic cerebellar hemispheres. You have echogenic the vermis also in it. And not only that, here you can see 2 sulci again. Can you see these 2 sulci? You have to look for these sulci. These are the parieto-occipital sulci as well as the calcarine sulcus. So these are the things that you have to identify whenever you are doing a transcerebellar coronal section is concerned. Then comes the sagittal. You have the parasag as well as the right and left parasag, and then the mid-sagittal sections. In the parasagittal sections, actually you call it as a tri-horn view. In the tri-horn view, why is it called as tri-horn view? Because this is the section, or this is the plane where you can see the frontal horn, you can see the occipital horn, you can see the temporal horn. That is the reason why it is called as tri-horn section, and in which you can see the choroid plexus nicely. And this particular view is basically intended to evaluate the ventricular margins, particularly when you have a cortical neuronal disorders, where you can get what is called as the periventricular neuronal heterotopia, where you can see an internal bulges. Not only that, periventricular leukomalacia can be seen very clearly, and then the other one is the cerebral parenchyma, and the cortical surface is very clearly delineated in these particular sections. So these are the things that you are going to look for as far as the parasag, right and left parasag sections are concerned. Now coming to the mid-sag sections are concerned, you have the corpus callosum. This is the cavum septum pellucidum, corpus callosum. Now remember, this is actually a transvaginal examination of taking the sagittal section of the midbrain, whereas this is the section which has been obtained by acquiring the volume. Can you find the difference between the corpus callosum here and the corpus callosum here? Yes, no. The corpus callosum, when it is taken by transvaginal examination without reconstruction, is usually hypoechoic, whereas the one which is taken by the volume data is usually hyperechoic. And this hyperechogenicity is basically because of the pia. Because we all know that this is the cavum septum pellucidum, and this cavum septum pellucidum is always indented or outlined by the pia mater, so that is the reason why it becomes very echogenic. And in this section, we also put the color Doppler on to see what is called as the pericallosal artery, or the marginal artery which is skirting the corpus callosum, which tells us whether the corpus callosum is normal or abnormal. Now the other thing is corpus callosum, basically we have 4 things to look for. One is the rostrum, then is the genu, body and splenium. And splenium overhangs the tectum. This is the tectum, okay? So this is how you are, and the size of the corpus callosum can also be measured from the rostrocaudal, and at the same time the thickness can also be assessed. There are various nomogram charts that are available which can tell us for that particular gestational age, is this the size of the corpus callosum normal, increased or decreased. Either way it is abnormal. It either increased also is abnormal, if it is decreased also is abnormal. Then comes the vermis, and now in the mid-sagittal section, normally you don't see the third ventricle, isn't it? Because you are cutting through the section, right, through the third ventricle. But then you can identify the foramen of Monro, which is very, very important, because that is the place where, suppose whenever you have a ventriculomegaly, you do a sagittal section, you want to demonstrate that there is an obstructive ventriculomegaly. In that situation, you need to identify the foramen of Monro. So how do you identify the foramen of Monro? As we all know, the roof of the third ventricle is formed by the tela choroidae, right? The tela choroidae anteriorly is thick and is comma shaped, and the junction where it stops, that is the point where it stops, if you draw a line, that is the point where the foramen Monro is there. That is one. Second thing is, posteriorly this tela choroidae, which is the roof of the third ventricle, ends into the tectum where it is thick and comma shaped. So these are the things that you have to understand. Similarly, you need to understand about the vermis, and not only that, this mid-sagittal section clearly gives you the see, you have seen in the coronal section the cingulate gyrus, callosal sulcus, and then the calcarine sulcus and the parieto-occipital sulcus, isn't it? Now you have to identify them even in the sagittal section. You can see that this is the cingulate sulcus. If you know where it is located, then you can easily identify it. First and foremost thing, remember, this cingulate sulcus is parallel to the choroid plexus, corpus callosum. So that is one thing which you have to know. And we all know that the corpus callosum is encased by the callosal sulcus. So this is callosal sulcus, this is cingulate gyrus, and then we have the parieto-occipital sulcus in the posterior fossa, and then the calcarine sulcus here. So these are the things that you have to look for as far as the mid-sag section is concerned. Along with it, in the mid-sag section, we also will look for the midbrain, that is, when you take the thalamus, extension of it is the brainstem, where you have the pons and the medulla oblongata, and along with it you can also assess the size of the vermis, wherein you can see that it is a multiple, these are the things, and you need to identify the primary fissure which corresponds to the fastigium, apex of the fastigium, and above that is the 1/3 of the vermis, below that is the 2/3 of the vermis. And can you see the just beautifully demonstrated what do you call it as the tentorium cerebri, and this is the cisterna magna. So this is vermis with folia very echogenic, and the primary fissure, fastigium, that is the fourth ventricle, cisterna magna. So these are the things, and you can take measurements of the cervix, vermis, wherein you can take the cranial, the superior, inferior, anterior, posterior, and the area of the vermis, as well as the location of the vermis can be demonstrated by taking the angles, that is the what do you call it as the brainstem vermian angle, which tells us whether the vermis is rotated or not. So these are all the things that you have to do as far as the sagittal sections are concerned. Now coming to the sulcations and gyration, I will just take you through, because there is no, I will show you the images so that it is much more important. Remember, that has a calendar to be followed. First and foremost thing, if you want to see the callosal sulcus, you can see that from 18 weeks onwards, hippocampal sulcus by 18 weeks, parieto-occipital sulcus by 20 weeks, calcarine 22, cingulate 24. So if you take them into consideration, most of them are appearing after 22 weeks of gestation. So that is very, very important that you should know. So if you do a scan and evaluate at 26 weeks, you don't find the calcarine sulcus or the parieto-occipital sulcus, you know that you are dealing with a cortical malformation. So that is how it is going to help us. So these are all the sulcus. This is the callosal sulcus. You can see this is the coronal section. That is the callosal sulcus, agreed? And the same callosal sulcus can be seen engulfing the corpus callosum. And here also you can see it in the callosal sulcus is seen here as the echogenic line. So in coronal, axial, sagittal sections, you can see callosal sulcus. So I am just showing you various sections where you can see these sulci and gyri. Now comes to the cingulate gyrus. Cingulate gyrus is beautifully seen in the coronal section where you have the interhemispheric fissure. These are the cingulate gyrus, and you can see this parallel line coming right across, as you can see here, all from the frontal region to the posterior aspect, which is actually the cingulate gyrus. Okay. Now tomorrow you can go and start looking at them, then you will understand that this is very easy to make out, because just because we are not exposed to it, we are not able to identify it. But once you know where to look for, you know that these are the things that can be easily identified. Parieto-occipital sulcus, anyway you are going to look for it because you want to measure the ventricular size. So in the axial section, this is the parieto-occipital sulcus. In the coronal section, the one which is above is the parieto-occipital section, and then the one which is below is the calcarine. So here you can see the parieto-occipital, and that is the calcarine sulcus in the sagittal section. Now coming to the calcarine sections, as I said, this is the calcarine section, sulcus, and this is the calcarine sulcus in the sagittal section. So these are all the various things that you can see, and convexity sulci can also be seen. This is the central convexity sulci, and anterior to it is pre-central sulci and post-central sulci. I mean, that is not really very important to make out. And then the Sylvian fissure is one thing which you have to definitely, and very easy to make out. In the axial section, you can see this one. This is the section, and the development of these Sylvian fissure or these sulci and gyri has to be followed up, because they start as a dot, they become linear, then they become confiscated, then they become what you call it as shelving structures, and in the parasagittal section you can see the Sylvian fissure very nicely. So absence of all those things will help us in. So in nutshell, what we have to do is, first and foremost thing is that we need to understand the various sections that have to be taken in order to identify the fetal brain. And in each section, what are all the various structures that we are going to identify, and their clinical implication is what is important. So thank you very much for having a patient on, and let me thank the organizers once again for giving me this opportunity, and I really congratulate the whole team, that is SFM team as well as the SOX team and the MSB IRIA team, for organizing such a wonderful event and having so many delegates with us, and it's pleasure to be with you all. Thank you very much.
Thank you, sir. The pleasure is entirely ours to have you here. And it's been a wonderful morning and afternoon session with you today. Next, we have Dr. Prakash Gambhire, a pediatrician and geneticist with 35 years of experience, trained in medical genetics in Germany. He is presently Chief Medical Scientist, Life Cell, and Fetomedical Director, Birthright Genetics Clinic, Pune. He is the Secretary of Genetics Chapter, Indian Academy of Pediatrics. He is himself a reviewer of many popular journals and has more than 40 publications in various national and international journals, with special interest in newborn screening, fetal dysmorphology, lysosomal storage disorders, genetic education, prenatal screening. Sir, indeed fortunate to have you here. Sir will be talking on why NIPT is NIPS and not NIPD. Welcome, sir.
Thank you for the introduction, and thank you for having me, all SFM, Marathwada chapter, as well as the SOGS and MSBRIA. And I got very little to say today, because it is said that in Mahabharata, when it was written, that people said that Vyasochistam Samagra Jagatam, which means that whenever Vyasa has written Mahabharata, there is little left to be said or little left untouched by him. So similarly is my situation here, because before me, Dr. Bimal Sahni has given us such a beautiful lecture on basics of genetic practice. So I'm going to talk on the same topic. So you judge for yourself whether I got a little something to say. But I feel that I have some more things to add to what he has said, so that you will understand how at the research level or at the lab level, why we have come to such false positive rates or such recommendations, and what is the basic paper on which all this NIPT and all these guidelines are based. So this will make you understand, and maybe it will help you to practice, choose your test in a little better manner, and that will also help the fetus in general. Okay, so talk for today is why NIPT is NIPS and not NIPD. Now, when I gave this lecture at ISPAT, that is Indian Society of Prenatal Diagnosis and Therapy at Ahmedabad, the world was switching over from triple test to first trimester markers combined screening. 10 years later, when at the similar venue in Ahmedabad, I gave a lecture again, then it was first trimester screening that was being shifted to NIPT, and everybody thought that NIPT maybe now replace the first trimester and combined screening. But it has not happened, because every investigation, as Sahani sir has told you, has got its place in practice, it has got limitations and advantages. But now I bring to you something new, and these are guidelines by American College of Medical Genetics, which are followed all over the world like a Bible. And these guidelines have been published online in December 22 and in print in January 2023. And what does this guidelines say? That ACMG, American College of Medical Geneticists, now strongly recommends NIPS, I'm again stressing here, NIPS, over traditional screening methods for all women. So initially it was selection of women, now it is for all women, and that is how world has now come to. So again, 10-year leap is there when NIPS can be sort of prescribed without any doubt for all women, and that is what the recommendation is. Now, there is always a doubt whether this test, whenever it is widely available, is it going to be used rationally? So this concern was there even in 2014. So when the NIPT was introduced in 2011, it became a little cheaper and it became there in practice. So that time also, you can see here the news item, it is an investigative news item in New England paper. So what it says is that oversold prenatal tests per some to choose abortions unnecessarily. So that was the investigative report. Similarly, now what has happened is that NIPT cost has come down from 35,000 initially to almost less than 10,000. So it is there in everybody's reach. So there is always a temptation to use it in place of invasive method for testing, because it is widely available, the sample can be sent to any place. So is it right to do that? Is non-invasive prenatal testing really a NIPS, a screening test or a diagnostic test? So that is a topic for me. So for the gynecologist, fetal medicine expert to choose the test rationally, there have always been guidelines. So initially, as Dr. Sahani sir had said, there were guidelines where that this test should be used for selected set of women. So women who were over 35, or women who had a Robertson translocation, or who were having his prior history of aneuploidy, the NIPT used to be used for that. Now this was guideline way back in 2016. In 2019, what they said was that NIPT can be offered along with maternal serum screening as well as individual diagnosis. You offer them at the first antenatal visit, discuss with the woman and let her choose the test. So after a good pre-test counseling, what has been explained very nicely, the woman should make her own choice. So that was this thing, and this was all these societies that had agreed upon and all these things. So now what is the situation is that now it is to be prescribed to all women, because over a period of years, now that the data is available, what it says is that it should be recommended to all women, antenatal women, And not only that, even in twin pregnancies, the performance of NIPT is much better than the traditional screening. So that is why NIPT has got a very good value. We'll come to see why that is so. So today what I'm going to talk about why NIPT is non-invasive prenatal screening and not diagnosis. And I will talk in terms of aneuploidies. I'll also touch upon a little bit upon the microdeletion syndromes. And what I'm going to talk about, whether it can be a substitute for CVS or amniocentesis, can it really be taking their place? How NIPT is compared to combined marker screenings, what is the performance and why it is chosen now over the traditional screening methods, and how NIPT should be used judiciously now that the January 23 ACMG guidelines are there. So this has already been discussed with you. Test that diagnose chromosomal disorders prenatally. So the short durations or the short TAT tests are the QA-PCR tests and the FISH test where a director diagnosis is there for aneuploidies. So you can have a report ready within say 24 to 48 hours once the sample reaches the lab. Or a detailed diagnostic techniques where you can see all the chromosomes. So the traditional way to go about it was the karyotype, and now much more detailed view can be obtained, especially for say imbalanced cytogenetic picture is by the microarray. So those are diagnostic tests. So little bit about karyotyping, this has already been discussed. Just to stress upon it, that this has got a little longer TAT because the cells need to divide. Only in the metaphase stage of the cell division we can arrest the cell, and then at that stage the chromosomes are at the shortest. So then you can separate the chromosomes, you can picture them, you can stain them, you can differentially band them. But this banding has got a limitation, is that the resolution is just 5 megabytes. So it is just 5 megabytes and it requires dividing cells, so the TAT is longer. Now compare this with the cytogenetic or chromosome microarray. So microarray has got a resolution of 50 kb. So it is 1000 times more resolution than a conventional microarray. So that is why even small microdeletions or microduplications. So why they are called microdeletion, microduplications? Because they cannot be seen through a microscope. These imbalances can be made out better with a microarray. So that is why microarray scores over the karyotype when we want to have identify the imbalances. And this imbalance identifications is especially important in case of a prenatal situation. So where we are going to document whether the fetus really has a chromosomal imbalance which may give rise to a serious conditions which is a cognitive or mental retardation later on, or the fetus that is you are having with a structural defect, whether the structural defect is going to be treatable with pediatric surgery or something like that, or it has got a really microdeletion duplications which is clinically significant. So studies have proved that for imbalanced karyotype, the microarray has much more detection yield than the karyotype. So it detects what the karyotype detects in case of an imbalanced karyotype, but it takes more. So that is why whenever you see a situation, please don't use karyotype in these situations, in prenatal situations. I'm not talking about identifying the translocation in say balance structural malformations in case of a parent, so husband or wife, but I'm talking about the prenatal situations. So please use microarray whenever such a situation is there in place of karyotype nowadays. So CMA should replace karyotype in prenatal settings. So that is the message that I want to give. So why this test are diagnostic test is because whenever I say do a karyotype or a microarray of any child or any fetus and it gives me a karyotype of say Down syndrome, then there is no false positive. So it is always a diagnosis is there. So when a Down syndrome is diagnosed, it is Down syndrome, it is nothing else. So that is why there is no false positives are there are no false negatives. So that is why it is a diagnostic test. So this is the concept of the diagnostic test. But in the screening test with the beautiful pictures has been explained to you is that screening test identifies a class of individuals which have got a higher possibility of diagnosing having that condition. So it does not diagnose, but it identifies along with some normal individuals, some individuals who are likely to have a higher possibility of having that particular diagnosis. And NIPT. So NIPT basically is going to detect the fetal DNA, it is going to detect the aneuploidies as well as microdeletions or the imbalances, or even in future it may be able to diagnose single gene disorders also, but presently it is being validated just for aneuploidies. And what ACMG has now introduced is the 22q deletion syndrome, which can now be identified through this NIPT, so it can be used for that also. So basically it is algorithm, and it can be used in situations because it identifies the fetal fraction. So fetal fraction is there, so fetal DNA is there. Obviously, it is maternal blood, so a lot of the cell-free DNA, which is outside the cell's nucleus, is bound to be of the maternal origin. So whenever it is of maternal origin, it is of no use to us. We have to identify the fetal original DNA, and whenever the percentage is more than say 4%, then it can give a good result regarding the aneuploidies. If it is less than 4%, the results are not reliable, so that is why the fetal fraction is extremely important. And these are nothing but the cells of the trophoblastic layer of the placenta, which are there in contact with maternal blood, which come into the maternal circulation, and that is the origin for this cell-free fetal DNA. So you know that the first cell of the zygote gives rise to both trophoblastic cells as well as the fetal cells. So they represent the fetal cells almost to the trueness, except for the cases where we can say that placental mosaicism can be there. Now, certain terms we must understand, because these have been talked by the experts, as Sahani sir had said, in a manner, in a very fast manner. So what are these terms? So everybody talks about the sensitivity of the test or detection rate of Down syndrome. So what is detection rate of the Down syndrome sensitivity test means? Supposing there are 100 cases of Down syndrome in a particular population, if I identify the 70% of cases through my test, then it is the detection rate is 70%. So that is what is the detection rate is there. But along with, as we have seen in the screening test, what happens is that some normal individuals are also affected. So it does not mean that everybody you identify as screen positive is having that particular condition. So what is important in case of a screening test is actually the positive predictive rate. So what is positive predictive rate? Supposing I identify say 100 individuals as a screen positive, and out of them just 3 or 4 turns out to be say Down syndrome, then my screen positive predictive rate becomes just 3 to 5%, and that is the case with combined screening, as we'll see with the study, large study later on. But in case of NIPT, it is much good. The positive predictive rate of NIPT is much better than a simple combined test. So this is the thing that you must look for, that is the positive predictive rate. Out of positive cases, out of screen positive cases, how many are really true positives? And the FPR, or the false positive rate, at which your screening test is functioning. So what is false positive rate? We'll see better with the help of this figure. You know, everybody is working at 3 to 5% false positive rates. So whenever you say something that's combined screening has got a detection rate of 85%, they always add at 5% false positive rate. So what does this 5% false positive rate means? That you have a cutoff here. So usually this cutoff is, traditionally it was being taken as 1 in 250. Now it is, for some programs it is being taken as 1 in 100. So this cutoff can be manipulated. Now this is the curve that you can see here, that is the normal pregnancies, that the fetus do not have the pregnancy, do not have the Down syndrome, and this is the cutoff for the this is the curve for the Down syndrome pregnancies. You manipulate your cutoff in such a way that you want to reduce the number of false positives or the positive cases, but at the same time you don't want to. This is the shaded area, which is the detected cases. That is that you are going to detect as the screen positives. You don't want to compromise on the detection rate. So the population at 5% false positive rate, 5% of all the women that you are screening are going to be having the screen positive result. So whenever you are using say combined screening, you will find that lot of screen positives that you are sending the amniocentesis for may have a normal microarray picture or a karyotype picture or fish or QFPCR. And that is because it is working at a 5%. So if you are screening 100 women, so 100 of them are screen positive, then a very few percent of them will be having this Down syndrome condition. So that is why you may not miss lot of Down syndrome cases, you will just miss 20% of Down syndrome cases, but at the same time you have to have an invasive procedure for lot of Down syndrome cases. So this is not a good test, especially when we compare that the detection rate as well as the false positive rate of a you will see here the NIPT. Now this is the large study on which all these NIPT recommendations are made, and this was published in New England Journal of Medicine. you will see that the cohort of the patient was almost 16,000. This first column here, you can see my arrow moving there. It is showing the total cases of 38 to be there. Of these 38 cases, combined screening could pick up 30 cases. So which means that the sensitivity of the test was just 80%. So it missed 8 cases out of the 38 cases amongst these 16,000 women. Now on these 16,000 women, almost 850 of them were having screen positivity. So for all these 854 women, amniocentesis of CVS was done, and out of them, just 30 of them were detected with true positives. So that is why the positive predictive value, we have talked about positive predictive value, for combined screening is just 3.4%. So that is why it has got a poor positive predictive value as compared to NIPT that we'll see later on. Negative predictive value is good. So that is why it is still holding true in practice, because negative predictive is almost 99.9%. Here you will see the cell-free fetal DNA testing, our NIPS. So you'll see all patients, when we take all patients, it could detect all 38 cases. So it had almost 100% detection rate was there. So 100% detection rate was there. At the same time, how many were screen positives with NIPT? There are 47 cases which showed high risk result with NIPT. So out of these 47 cases, just 38% were true positives. So that is why the positive predictive value is not 100%. Detection rate may be 100%, nearing 99%, but the positive predictive value is 80%. So that is why all of your screen positives with NIPT may not have Down syndrome. And that is why the recommendation comes that you must confirm your positive screening rates, positive NIPT with a amniocentesis or a CVS if it is done early. So it is not a diagnostic test, it's a screening test just. Now let us see the performance whenever it is this is a combined performance. So when we take a low risk performance, where we exclude all the cases which were below say 35 years of age, or which were not having combined screening result as positive, here you will see that there were 8 cases like this. And NIPT could identify all these 8 cases. But at the same time, the screen high risk cases result was there for 16 cases. So which means in low risk cases, the positive predictive value of NIPT is 50%, because out of 16, true positives were just 8 cases. So positive predictive value for NIPT was 50. So that is why it is always better to confirm your NIPT high risk result. So supposing whenever I am prescribing something to a mother who has not done any say double marker test or has got a normal NT, then it's or a normal screen result, and I am doing NIPT, then in that case I must remember a high risk result may not always be Down syndrome. So that is why I should not base my termination choices on this particular test alone, but confirm it with amniocentesis. That is why the recommendation is there. So significantly better positive predictive value for NIPT is there across spectrum, less in low risk positive predictive value is there. So that is why it is not a diagnostic test. Now similar performance, I will not go into details because I am holding you from the lunch, is there in case of trisomy 8 and trisomy 13 also. So we can also have this aneuploidies now, and even in case of sex chromosomal aneuploidies, as the performance has shown. I will not go into details of this. So now NIPS performance was much better than traditional screening in these situations also. Now, cell-free fetal DNA testing positive predictive value is not 100%, as we had agreed upon now. So it cannot be a diagnostic test. Positive, it should be followed up by the amniocentesis. It's an excellent screening test, but because there are 2 things about it. One thing is that the sensitivity is nearing the 100% rate for most of these aneuploidies, and second thing is that the negative predictive value. So if one gets a negative or a low risk NIPT, then the chance of her having a Down syndrome fetus is almost nil. While in case of, we have seen in case of combined screening, the chance that the Down syndrome case may be there in a low risk case may be 20%. So that comes now, can we identify these 20% of cases by some other strategy, by just moving our cutoff? And that is where your intermediate risk comes in. Because out of those 38 cases that you remember from the first slide, 30 could be identified combined screening, maybe out of those 8 cases, we can identify 7 cases if we have this intermediate risk spectrum, say from between 250 to 1000 or 100 per 1000 according to the program. So that is the idea for intermediate risk. Now, remember that NIPT is not perfect, or NIPS is not perfect. There can be negative NIPT also in spite of the fetus having Down syndrome. And this can result from, first is maybe the fetal fraction is low, or there is, it's a obese woman is that the negative call, that is the negative call. And similarly, there can be mosaicism which is confined to fetus. So the fetus may be having Down syndrome, but the placenta may have normal cells. So this is confined placental mosaicism, in which case you will get a normal NIPT result. False positive NIPT is also possible. One thing again is placental mosaicism, it can be vanishing twin. So we'll see the incidence of vanishing twin later on. So these are all the confounding situations, especially in case of say sex chromosomal aneuploidy where high risk result may be there. This particular origin can be, maybe mother has a triple X, or a complex chromosome aneuploidy picture can be there, which may be there because of a cancerous condition in the mothers. So these results have been seen. So we have to, again, whenever we get a result, false positive result can be there, and we should confirm it. So mosaicism, as you can understand, this is the fetus that you can see in the top left corner. So this fetus has got identical cells for both for placenta and mother. But in case of a confined placental mosaicism, you can see that only the placental cells are having the abnormal result, where the fetus is normal. In which case we'll get a false positive case. False positive NIPT result, fetus may be normal, and this is likely in 1 to 2% of cases where you get high risk result on NIPT. Now, vanishing twin. Now, twins is not a rare instance, so almost 3 to 4%, you know better than me, 3% of pregnancies are twins. And out of these twin pregnancies, they may result in 15 to 20% of cases in vanishing twins. So whenever these vanishing twins cases are there may be some placenta still underlying, some trophoblast from this vanished twin may be still there, and they may be, this cell-free retained DNA may be coming into circulation, and this can give rise to your false positive or false negative NIPT. So that is why this is again a diamela. It is always advised that whenever twin or you carry out some termination, say after 6 to 8 weeks, then NIPT should be opted for, and not before that, where there may be some cell-free retained DNA still circulating in the blood because of in that situation. So vanishing twin again can be a confounding factor. So mom matters, we said, sex chromosome aneuploidy is a triple X syndrome or something like that in mother, or it can be, as I said, cancerous condition, matter malignancy can be there. So this can give rise to, again, aberrant result in NIPT. So let us discuss these ACMG recommendations on NIPT. So one thing has been agreed upon based on the strong evidence, where they have had a meta-analysis of so many studies now. So almost 30,000 to 1 lakh pregnancies were, and the NIPT results were studied, and they have recommended now that it should be offered to all women over and above the traditional method of screening. And this is January 23 recommendation. So this is, say, oven fresh recommendation, you can say, call it. Another recommendation is that, and you will agree with me, that in a situation of twins, again NIPT stands a better state than the combined screening result alone. Obviously, combined screening has got a better understanding regarding which twin is having that, because you can have an abnormal NT or abnormal morphology, abnormal sonographic findings in the fetus. So which sac is more likely to have Down syndrome fetus is always better told on the sonography. In case of trisomy 13, trisomy 18, and sex chromosomal abnormalities, again, NIPT should be offered to all women because it has got a better performance over traditional screening. And as I said, even in case of this particular microdeletion, which is quite common. So 22q microdeletion has got a population incidence something like, say, 1 in 1,000 to 1 in 3,000. So it is not an uncommon condition, as common you can say as Down syndrome, especially supposing you get some congenital heart defect and if your NIPT is also showing 22q minus, then obviously it is more likely to have a CHD baby. What it says, it has got limitations presently. So it is being very cautious, just like our Reserve Bank of India in making this statement that NIPT presently does not have sufficient ground to say that it can work in other microdeletions. But maybe in future it can be moving in other way. Similarly, rats. So rat is nothing but what you say, the meaning is different. Rat for them is rare autosomal trisomy. And what are these rare autosomal trisomy? Something like say trisomy 16 or trisomy 22 that you can see more commonly in abortuses. So because it is there, usually they are lost during pregnancy and let's see the mosaic form of something. So that is why these rats, again, it is not there presently recommended for detection of these rats. So that is rare autosomal trisomies. So now the question must be there in front of everybody, and as a lab person also it is in front of me, whether I should also say give up all my biochemical screening, or you may think whether you should give your sonography screening. It is not like that. Every test has got its limitations or benefits. So markers also have a certain value still, and for example preeclampsia screening. So you can carry out with the help of your markers, your Doppler flows as well as your history for preeclampsia screening, and it can give you advance warning regarding the early preeclampsias. Or open neuropathy defects, again NIPT will never tell you regarding the open neuropathy defects. Fetal growth retardation. Supposing I get say PAP which is less than say 0.3 or something, I get an advance warning. It may be something which may be producing to placenta dysfunction of fetal growth retardation. Or even rare syndromes. I have seen that abnormal markers with a normal first trimester say sonography and landing up with the very rare syndromes later. So I'm really worried whenever this thing is there, and then we at my lab, we advise the clinicians regarding these marker levels and be more watchful, monitor these pregnancies more closely if the markers are abnormal. So that is why markers are not replaceable, they should still be in practice. Now, this is the guideline that was little older, say 5 years old. So that time this SFOG has actually recommended that 1 in 50 cutoff should be used. So Dr. Vimal Sahni has also said that this cutoff is being reduced, and maybe 1 in 10 also in some days in good hands. So presently, I still recommend that we should not have a cutoff below 1 in 250 because the ultrasound quality care is different at different places. That is what I feel, and our internal data shows that even for a cutoff with 250, we may get some chromosomal abnormalities more which are little different than the Down syndrome and the aneuploidies. So that is why we should have a cutoff which is actually 250 in our country. Now what does NIPT do in say high risk situations or in case of say intermediate risk? So you can see here, this is the combined screen result, and this is the NIPT result. So as has been said, then even for 1 in 10, we should have NIPT first if patient does not want for amniocentesis. So you can see here, if the low risk result, high risk result is there, then it is 29 into 1 chance. So this 1 in 10 chance has become 29, you can say 290 times more likely that the baby may have Down syndrome. So high risk situation, NIPT high risk result, again, the pregnancy is likely to have Down syndrome. If low risk is there, then this 1 in 10 risk will become 1 in 10,000. So this is in high risk, but you can see here 1 in 270. Now what we call as our intermediate risk or beyond that. So if the high risk result is there, then there is quite a high possibility. So you have a risk group which is between say 250 to 1000. If you are NIPT high risk result, then that baby may be having Down syndrome in spite other things being normal and the curve result being also within low risk. And if it is normal, then negative predictive accuracy of NIPT that we have said, it is 100%. So then this risk result from 270 will become 1 in 30,000. So that is how NIPT can differentiate further your combined screen result into whether it is more likely to have Down syndrome or less likely to have Down syndrome. So it demarcates, it differentiates further. Now has been beautifully explained, pre-test counsel for NIPT is must. So we must explain the advantages as well as limitations of NIPT testing. False positive results can be there. Most important thing that you must explain to the patient is two. One thing is that the patient may think that it's an expensive test, so I have covered all the genetic disorders. It's never like that. One test cannot tell you regarding all the genetic disorders. So that is why NIPT will tell you, and it is validated for certain conditions. That must be clearly explained to the patient. That is one thing. Second thing is that if NIPT is showing a high risk result, then better we should confirm it with the amniocentesis or invasive procedure. That again must be told to the patient. And third important thing is that NIPT will never replace the sonographic monitoring that is going on later in the pregnancy. So that is why we must explain all these three patients. Then your post-test counseling will, pre-test counseling will be complete. And then comes the post-test counseling. That again is important. So in conclusion, I'll just say that when we compare all these things, so first trimester combined screen should be offered to all pregnancies. Maybe now in affluent class, or as Dr. Vimal Sani has said, to our relatives, we may offer them the NIPT also along with combined screening, because I don't see that combined screening will replace sonography or markers in near future. Risk result 1 in 250 should always, or lesser than that, should always have invasive fetal cytogenetic diagnosis and rapid testing. Maybe QFPC or FISH you can use along with microarray. So remember to use your QFPCR testing not with karyotype but with microarray, because it has got a more delineation power. So that is why you must use microarray in case of karyotype. Intermediate risk between 250 or 100, whatever yours cutoff, and 1000. Those 8 cases that were missed in that last trial, you may be able to detect with NIPT. So you have a NIPT and maybe later an invasive procedure later on. All positive NIPS should be confirmed with invasive cytogenetic diagnosis. Gold standard is still invasive testing and not NIPT. All mothers should be offered, that is what I said just now. And this is NIPC first, these are the older these things, recommendations. So if NIPT is done in case of maternal genome screening, it should be clearly explained that it does not replace sonographic monitoring. So that is the message that I want to give. And really thank you for patient hearing and remaining in this hall in spite of such a long and prolonged session and listening to my lecture. Thank you so much.
Thank you so much, sir. Indeed, this is an important part of fetal medicine, and that is why it was so important to have you here. I request Dr. Baldava sir to kindly felicitate Dr. Gambhire. Now we shall all break for lunch, and I request everyone to be back after 15 minutes. We shall begin with Veena Panath Madam's lecture after the lunch. Marathwada chapter, ex-president of Aurangabad OBGY Society, member of FOXY, Perinatology Committee, and FMF accredited consultant for NT and fetal abnormality scan, and board member of National Quality of Care Network. With special interest in high-risk pregnancy and fetal growth retardation, she has given many talks on the radio and has been a part of panel discussions on television as well. She is on the editorial board of International Medical Research, was awarded Sakshma Award on Women's Day by the NGO Rananubandh, and declared as Women Icon at the Tender Care Home Education Society. Welcome, ma'am, for this lecture.
Thank you.
Yes.
Thank you. And a wonderful team event today by the Solapur Society. And welcome to the Marathwada chapter of Society of Fetal Medicine. Now, fetus is like the earth, and earth is like the fetus. So if we have to have a good earth 1,000 years from now, we have to take care of our earth. Similarly, if we want to have a very good future for our generations, we need to take care of the fetus now. So fetal environment, it is all about the placenta, seeing the position of the placenta, the morphology, the location and the edges, the size and the relation of the placental edge with the cervix, and whether it is belonging to the placenta accreta syndrome. Cord, the vessels, the origin from the placenta and insertion to the fetal abdominal wall, the cord morphology. In the LICA, we need to see the volume, that is by the AFI or the single deepest pocket. We need to have a look at the cervix, and we need to have a look at the uterine artery Doppler, because only if the fetal environment is good, the fetus inside is going to be good. Now, very interesting for the younger generation who may be thinking of branching out into the biogenetics of it. The evolution of the placenta is very, very interesting. Basically, like the coronavirus, there was once upon a time in the prehistory, there was this virus which invaded living beings, and that is how the placenta forms. And we all need to know that it is not the presence of the uterus, but it is the presence of the placenta, which is the most important factor in maternal fetal physiology. Very interesting. When I was preparing for a lecture at Nagar, so I read all of this. And it is the placenta which differentiates us from the oviparous animals, or otherwise we would still have been born like Anthony Gonsalves in an egg. Thank God for the placenta. Thank you. Now, in the first trimester, the placenta appears as a small hyperechoic area, sorry, not a hypoechoic, hyperechoic area near the fetal pole. This is the nascent or the incipient placenta. Then later, this looks like this hyperechoic rim is seen, which is always a sign of good implantation, the blood flow across the choriodecidual space. And always if we see a poor decidual reaction, we all know that this is a sign of poor implantation and this pregnancy is going to fail. Now, once we are evaluating the placenta, the appearance of the placenta, it progressively changes during different stages of pregnancy. Now, earlier we have seen how it is a small hyperechoic area near the fetal pole. In the late first trimester, size of the placenta in comparison to the uterine cavity is such that it seems to cover half of the longitudinal axis. So, majority of the uterine wall will be seen to be covered by the placenta, which gives us an impression of a low-lying placenta, which is erroneous. So, we should not and never label the position of placenta in the first trimester. We should only specifically mention if there is something significant. Otherwise, we should not mention about the placenta in the first trimester. Something significant, as I said in the earlier slide, something like the molar pregnancy is seen. We are not seeing it. The molar pregnancy can be, as we all know, the complete or the incomplete. Only then we should mention, otherwise there should be no mention in the first trimester. Now in the second trimester, basically, we have to trace the placenta. So, along the uterine wall, we have to trace the placenta and the origin of the umbilical cord, which we will come to later. And in this second trimester report, we should always mention about the placenta. It should not be a footnote. We should begin with a overall look at the fetus, as Shilpa and Dr. Aniruddha Kulkarni had shown you in the live workshop yesterday. We should always have a basic look at the placenta, the liquor, the cervix, the fetal environment, then focusing on the fetus obviously. And we should always mention the location of the placenta, whether it is anterior or posteriorly placed, the size of the placenta, what is the morphology of the placenta, is it looking normal, is it looking healthy, or is it looking something abnormal, and the cord insertion, from where it originates in the placenta and where the umbilical cord inserts in the fetal abdomen, we should always mention that. Now the morphology of the placenta, we all know that there is always the distinct hypoechoic basal layer which indicates a normal interface in the myometrium. Its absence, now this is the hypoechoic basal layer, and this is where the placenta shears off. We as obstetricians know this is the layer at which it shears off and comes out in the third stage of labor. We should always also measure the thickness of the placenta. And when do we say that this is a thick placenta? When the size or the thickness of the placenta is around 50 mm, that is 5 centimeter. Now we can think that it is almost 1 millimeter per week of pregnancy. So if the pregnancy is of 40 weeks, that is 280 days, the ideal placenta size should be 40 mm. So if it is crossing 40 mm, going to around 50 mm, definitely this is a big placenta, it's a hyperinflated placenta. Now when we are seeing the morphology, we will discuss later, we always have to see whether there are any placental lakes, dropout areas, and vascular connections across the maternal fetal chorial space, which is always a sign of a placenta accreta syndrome. Now this is the chorioangioma. As I said, The thickness of the placenta, if it is more than 5 centimeter, definitely our antenna should be up. Is it a metabolic problem of the mother? Is she having diabetes? We should always rule out such factors. And then sometimes if this is a grossly big placenta, we can see the size at the lower end, that is almost 11 by 8 by 7 centimeter. This is basically, this patient had perivolus fibrinoid degeneration. And this is the placenta, and the baby had severe early growth retardation. At around 18 weeks only, that growth retardation has started. We referred her for amniocentesis. Amniocentesis she underwent. She came back with bleeding. That can be a complication. It was a good thing because the patient aborted, and then the fetus was found to have trisomy 21 also. Sometimes we can see this hematoma in the placental area. Sometimes vasculopathy can also be seen. Now this patient was very interesting, and as an obstetrician I was just worrying when I was doing scan, is she going to bleed later? Because we can see these blood vessels growing into this hyperdynamic circulation across the villi. Now when, we will come to it later, when we see that this is hyperdynamic circulation, this hyperdynamic circulation is going to lead to damage of the villi. And this fetus later turned out to be, I'll show the photo later, having severe growth retardation. Now location and the edges and the relation with the cervix, very, very important. Dr. Aniruddha Kulkarni sir, if time permits, he will be covering what the cervix and across the pregnancy. Now the location, it can be anterior, posterior, lateral wall, and the edge always should be defined with respect to the internal edge of the cervix. Now this is the distance from the cervix, something between 2 and 3 centimeter from the cervix, then obviously it is low-lying placenta, placenta previa. We will be paying attention to it, and as radiologist friend or imaging specialist friend, we should always warn our obstetrician friends also. Now always, it should never be commented upon in the first trimester. Look at the placenta, look at the bladder. Bladder also should not be very, very full, it shouldn't be empty also. Then we have to see. And if at all we have doubt on a transabdominal sonography, ideally a transvaginal sonography has to be done. And even if the patient comes back with bleeding PV, after the sonography, we should tell her that this is not because of transvaginal sonography we have done. The bleeding has happened because of the low-lying placenta she has. Specifically, if the placenta is anteriorly placed and low-lying, definitely we should go in for a transvaginal sonography also. Now placenta previa, this is a low-lying placenta. We can see the cervix here, the bladder is seen. But the difference between this and this is, in this is a hypoechoic layer is seen. There is a thin difference. And here, we will see later also, we cannot see any hypoechoic basal layer, and we can see the angry vessels crossing over. Now, this is very important as clinicians, as obstetricians who have to deal with such patients. It doesn't matter if the adherent placenta is seen or if it is low-lying. But definitely a low-lying placenta can be managed in a small nursing home, keeping blood ready and everything ready. But an adherent placenta, we always should make it a point that we operate upon her in a tertiary care center with an ICU backup. And if we are going to take these patients for a cesarean section, ideal would be to go in for uterine artery catheterization before we do the cesarean section, so that if at all she is going to bleed, we can go in for embolization, so that we are able to prevent maternal morbidity and mortality also potentially which can happen. Now this is the basically classification, placenta previa with no ultrasound sign of invasion, the placenta accreta syndrome 1 spectrum, presence of at least 2 ultrasound signs along with lakes or lacuna. This is the mothball appearance. Then the spectrum 2 is 1 with utrovesical hypervascularity. So we are seeing all this crossover of the vascular tree. And spectrum 3 is evidence of increased vascularity potentially extending into the parametrial region. So we should always look for low-lying placenta, the location, the distance from the cervix, and signs of adherence. So this is what a normal placenta looks like. And if anything is different, definitely we should be more attentive. Whether the very thick placenta is there, hyperinflated placenta is there, whether we are seeing the placenta accreta spectrum, whether there is some kind of a hematoma or thrombosis is seen, whether this is the fibrinoid degeneration. Now the fibrinoid degeneration, not the degeneration, the damage to the villi which is happening here. Now this is a baby which we can see is just 655 gram at 8 months complete. The baby was alive, so we shifted the baby to GMCH, but obviously after 10 days the baby could not survive. So this is basically damage to the villus tree. So if the placenta is very big, if the placenta is very small, definitely something is wrong. But apart from the placental anatomy, how to measure the function of the placenta, whether it's functioning fine, and what is the function? It is basically to provide all the blood, oxygen, nourishment to the growing fetus. So basically this is a mathematical equation. I just written it down because we have done our maths. Function of the placenta, where x is equal to placenta, is basically placenta and placenta itself. So how do we do that? We do the uterine artery PI in all trimesters. Remember, we have to do it in the first trimester at the time of NT scan, the fetal abnormality scan, and later also growth scans. Each and every time we have to do it. In the first trimester, the cutoff for uterine artery PI is 2.3. In the second and third trimester, it is 1.4. So if at all the uterine artery PI is at or more than 95th percentile, we should definitely start her for low-dose aspirin, and we should counsel her that this pregnancy may land up with preeclampsia or growth retardation. Placental problems may happen. Now then we come to the umbilical cord morphology. We know that the free movement of umbilical cord is very important for optimum psychomotor development of the fetus. Normal configuration, we all know, it is the 2 arteries and 1 vein. The 2 vessel cord, we all know. If it is only one single umbilical artery, rarely 4 or 5 vessel cords can also be seen. Now we have to trace the umbilical cord from where it originates in the placenta and the insertion to the fetal abdominal wall, and whether there is what we call as the persistent right umbilical vein. I think the video is not working for some reason. Anyway, this is from where it is originating from the placenta. We should always make a sweep, and why it is important, because even though we know that the majority of the placenta origin is almost 80 to 90 is central, it is originating basically from the center of the placenta. If it is marginal, if it is towards the end from where the placenta is ending, then or with filamentous origin, then these may be associated with poor fetal and neonatal outcome. Now cord insertion into the anterior abdominal wall, this is basically where it inserts. This is always a view very important, because we are going to rule out the anterior abdominal wall defects like omphalocele, etc. But also we see the 2 vessels crossing over. This is a single umbilical artery. We see only on this side, not this one. And this is basically a figure of 8. And for the young friends, always also remember that anytime you see magnify, 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 and always keeps your record very, very promptly. The same day, try to put it in a hard disk. Because of what I have seen, you cannot see the image properly, because that time I have not magnified it. And later when I have done for single umbilical artery, I have not preserved those images. For the young friends, please remember that also. Now single umbilical artery, normal variation is seen. We all know, but once we see that, we just have to ensure that there is no other associated abnormality, which can happen in almost 25 to 30%. We all know that bacterial group and T18 is associated with single umbilical artery. It is also associated with small for gestational age, and hence warrant serial growth follow-up also. And I was talking to Dr. Sonali Deshpande, professor at GMC. She was saying that many times they have come across unknown IUDs, there is no cause, and then when a fetal autopsy was done, many of them were found to have a single umbilical artery. So we should always remember all such things. And when all the above have been sorted out, the parent should be assured that the majority babies will have a normal outcome. Now this is the algorithm from the Fetal Medicine Insights for clinicians by Chinmay Ratha and Dr. Ashok Khurana sir. So how to go about if we see that there is a single umbilical artery, we do a complete TIFA scan whether it is abnormal. If it is normal, then we do a fetal echo, karyotype and counsel, and as Gambhir sir said, do we do a NIPS or we directly do advisor karyotyping, then we do a serial growth chart whether it is normal or abnormal. And if everything is fine, then we manage as per the Doppler imaging and deliver at term as per the obstetric indication. Now, something different, anything which is different, that is the persistent right uterine vein. You have seen this. Otherwise, we all know that there is a hockey stick appearance and the curve is, the convexity is towards the stomach. So, if at all the concavity and not the convexity is towards the fetal abdomen, then definitely this is PRUV, and sometimes, most of the times if it is intrahepatic, extrahepatic, intrahepatic will be having more association with bleak outcome, or whether there is particulate matter which is seen in the LICA. Then we always have to see for the knuckle cord, and we should just mention it, whether mention it or we don't mention it, because if we mention it, we know what the patient's worry will start. Cowling of the cord, basically lot of research has been done about it, but even if there are multiple loops of or coiling is there is no significance to it. Similarly, what placental cotyledons, when we were doing residency, if the placenta is hyperechoic, if there is multiple cotyledons, then is it grading of placenta, is it leading to placenta aging faster? But now we all know that there is no significance of that also. Amniotic fluid, like in the amniotic cavity which provides space, buoyancy and mechanical cushioning. In early pregnancy, most of the amniotic fluid we all know is formed by the placenta. Later, after 16 weeks, is the fetal urine which is the major contributor. In the first trimester, always a subjective assessment. And then in the second, we do a quantitative assessment by the single deepest pocket or the deepest vertical pocket or AFI. And at extremes of oligoamnios or polyamnios contributes to perinatal morbidity and mortality. So we always have to measure it. So if it is single deepest pocket, then the LICA, it correlates better with oligoamnios. Any single pocket which is less than equal to 2, it is oligoamnios. Normal is between 2 to 8, and in more than 8, definitely the LICA is on the higher side. This also video is not running for some reason. Basically, this is severe oligoamnios, but this baby had multiple renal anomalies. Now AFI, we all know that we divide the abdomen in 4 quadrants and then we do the serial assessment, and normal is between 5 to 24 and less than 5 severe oligohydramnios, more than 24, that is 25 and above, is severe polyamnios. Now once we come to the cervix, we always have to measure the cervix, the cervical length, and we should always do a whenever we are doing the trans-abdominal scan, we always have to study it, measure it, and always mention it in the reports also. Sometimes we do it, we forget to mention it, but remember, this has to be mentioned always in your report, otherwise it will mean that we have not screened the cervical length. Now the types of cervix, whether it is U-type, W-type, that will be covered by Dr. Aniruddha Kulkarni sir in detail, so I am not covering it in my lecture. Now we all know that for a healthy environment, the fetus needs to be healthy, and if the environment has to be friendly, it is to be green, then the fetus presently has to be good. Because the fetus which will be born now, they are going to take care of the environment later. So we have to pay attention for the fetal environment. The placental evaluation is a must. The placenta position, and always look for the placenta accreta spectrum. Study the cord variations, whether they are there, Then amniotic fluid assessment has to be perfect. We should not just do eyeballing and say it is normal. Sometimes I have a habit, I will agree in front of you, that I do it, I just do a subjective assessment and then I put the value as 12. That is also wrong. We should actually always measure it. And then the cervical length has to be measured by transabdominal and ideally by transvaginal sonography, and if the transvaginal sonography shows that the cervical length is 2.5 or less, then definitely this is a case of she will end up in preterm labor. And I come to the end of my lecture. Thank you Solapur, not just for inviting me for this lecture, but for having hosted such a beautiful conference today. Thanks to the Solapur Obstetrics and Gynec Society, the Solapur branch of the Radiological Society, and all the officials who had come today and all the delegates. Thank you. Thank you very much.
Thank you, ma'am. It was an exhaustive talk. I now welcome Dr. Sumit Chamaria for his case presentation. He is a fetal medicine consultant practicing in Solapur since the last 2 years, and he is a certified member of FMF London.
Good afternoon, everyone. At the outset, I would like to thank the SFM Marathwada and SOGS Solapur for giving me an opportunity to present my cases here. So, today we are going to have a look at the late onset polyhydramnios. So, first of all, why this presentation has been made. We all do growth scans between 28 to 38 weeks of gestation. We all do encounter the polyhydramnios, common thing, but we do limit our investigations to GDM. We check the maternal blood sugar levels, and if that's normal, we prime the patient about the possibility of postnatal tracheoesophageal fistula or of the intestinal obstruction, that is the upper GI tract anomaly or the lower GI tract anomaly. So, in these next 3 cases, we are going to see the different presentations of polyhydramnios and how polyhydramnios is not just about being GDM or the GI tract anomaly. So, first case, Mrs. ABC, 23-year-old, married for 2 years, a non-consanguineous couple, primi gravida, Rh positive blood group, low BMI patient, had no significant medical, surgical or family history in the past. She was referred to us in view of polyhydramnios at 33 weeks. So, we went by her previous scans. NT scan was done at 12 weeks, CRL was 55, for which the NT was good, the nasal bone was very much there. She had not undergone the aneuploidy screening test. At anomaly scan 20 weeks, the Liker was normal, the Dopplers were good, and even her biometry was corresponding to 20 weeks of gestation. So far all good. At growth scan, the interval growth assessment scan, which was done at 32 weeks gestation, there was increased Liker, and the stomach bubble was seen, there was no cleft lip was mentioned on the report. So she was sent to us. On scan, we saw that the single deepest pocket was of 13.6 centimeter. 2 to 8 is the cutoff we keep. 2 to 8 is what we consider as the normal Liker. So 13.6 was very much indeed the increased Liker polyhydramnios. So we started ruling out the maternal causes for polyhydramnios. First, the GDM we have to rule out. The patient had undergone GTT. At 26 weeks, her fastings were normal. After 2 hours, the blood test was 124 milligram per deciliter. That was normal. So GDM was out of question. We ruled out Rh isoimmunization. She was Rh positive blood group. Other histories, the maternal medications, drug history, no history of steroid or other medicine usage was there. So after ruling out the maternal causes for polyhydramnios, we were moving for the fetal causes of polyhydramnios. First and foremost, the structural anomalies in the fetus. There was no obvious cleft lip, a common thing which we see. There was stomach. The stomach was very much present. The stomach size was good, and there was nothing in the intestine, there was no dilated bowel loops, so even the common structural anomalies for the polyhydramnios were not there. So after the structural anomalies, we went ahead ruling out the neuromuscular anomalies. Now, neuromuscular anomalies per se are rare anomalies, but when it comes to polyhydramnios, they are significant because neuromuscular disorders like arthrogryposis, fetal akinesia can cause polyhydramnios. Baby cannot open the mouth, cannot swallow, so there is polyhydramnios in neuromuscular cases. So it's important that we rule out polyhydramnios in neuromuscular disorders in cases of polyhydramnios. But in this case, there was good fetal movements perceived by the patient, good fetal movements which were noted on the scan. There were nothing suggestive of contractures or club feet and all. So after the structural anomalies, we had ruled out even the neuromuscular anomalies in these fetus. So the hunt for the cause continues. We have not found anything till yet which causes severe polyhydramnios in this case. So we started looking or searching for the occult anomalies like the cleft palate and all. So here we can see the maxilla is very much well seen. But if you see this profile image well, what catches eye here is not the maxilla presence, which is good, it is the small chin. At 33 weeks, we do not expect chin to be so very small. On 3D rendering, because of the polyhydramnios, we could get good image. We see that the nose is well seen, the lips are well seen, but there is a very small chin. So finally, we had found the culprit. It was a severe micrognathia, which was causing such a huge amount of polyhydramnios. So why there is polyhydramnios in micrognathia? There is a small jawbone, there is no mouth opening, there is impaired fluid deglutition as a result of that, and that leads ultimately to polyhydramnios. What happened to the fetus? There was severe micrognathia at birth, then there was neonatal demise on day 3. The pediatrician suspected Peary-Robbins syndrome, which was confirmed by the geneticist. So our first case, we have seen that a rare structural anomaly causing polyhydramnios. Moving to case 2, 23-year-old, married for 1 year, second degree consanguineous couple, again a primi gravida with Rh positive blood group, no significant family history or medical history, was referred to us in view of increased risk for trisomy 21 on a quadruple marker test at 17 weeks. As a protocol, at 17 weeks, a scan was done wherein we saw an echogenic bowel also. So we had a screening test which said increased risk for trisomy 21. We had a soft marker for trisomy 21. So maybe there was something in store for us. So I just put in a needle, did an amniocentesis for the patient, sent it for FISH 21 and karyotype. Fortunately, it came out to be normal. Both FISH 21 and karyotype were normal for this patient. Patient went back to the referring gynecologist. Further course, she had an anomaly scan done at 21 weeks at her native place where no obvious anomalies were found. But she came back to us at 34 weeks with polyhydramnios, and this time even the cause was mentioned that the polyhydramnios is due to intestinal obstruction, unlike the previous case where we had to hunt for the cause. So we did a scan, we saw that there is polyhydramnios. Indeed, we see the Likert is around 9.5, the single vertical pocket, so there is polyhydramnios. There were no structural anomalies, but when we see the intestine, there are dilated loops. But if we see closely, these are not these are prominent loops of the intestine, but this doesn't look like the bowel, which typically we see in the cases of intestinal obstruction. In intestinal obstruction or the prominent dilated loops, we see a linear structure with a diameter of more than 15 millimeter, or we see something like this in cases of dilated obstructed bowel loops, wherein we have the echogenic walls, we have the dilated loop of bowel with the internal contents. So this case what we see here is a typical honeycomb appearance of the bowel, which is seen in the secretory or the congenital chloride diarrhea, which is a rare condition. rare conditions are rare, so we just had this diagnosis, a working diagnosis at the back of our mind. We we just spoke to the referring gynecologist, told them about this, our working diagnosis, and baby was delivered at 37 weeks. It was a male child which was born limp, shifted to NICU, had severe diarrhea, there was electrolyte imbalance, baby succumbed on day 2. Now we had a working diagnosis of congenital diarrhea. The fetus the neonate postnatally had severe diarrhea. So a clinical exome sequencing test was done, wherein we can see the report that the pathogenic variant of the congenital secretory chloride diarrhea was found. So in this case, pattern recognition helped us to reach the diagnosis. About the congenital diarrhea, in short, it's an autosomal recessive condition, causes persistent secretory chloride losing diarrhea, postnatally dehydration, hypoelectrolytemia, abdominal distension, and failure to thrive are the signs and symptoms seen. And as it's an autosomal recessive condition, there are 25% risk of recurrence in each subsequent pregnancy. Moving on to our last case. A 27-year-old married for 3 years, third degree consanguineous couple, gravid 2 abortion, 1 Rh positive blood group, otherwise normal, was referred to us in view of polyhydramnios at 32 weeks. NT scan was fine, anomaly scan was fine. A scan was done at 27 weeks, wherein the liquor was more. The single deepest pocket was 10 centimeter. This scan was done outside, where again the grossly anatomy was said to be normal. The gynecologist had started the patient on endomethacin sustained release 75 mg OD, and patient continued to take this medicine for 5 weeks till 32 weeks till she came to us. So on scan we can see that the single pocket was of 14 centimeters. So from 10 centimeter the liquor had increased to a single pocket of 14 centimeter, and endomethacin was very much not working in this case. Even the stomach, the intestine, the bladder, everything looked very much normal. We could not find any other structural anomaly. Endomethacin was stopped due to its risk of fetal complication, especially in the 3rd trimester. We know it can cause the premature closure of the ductus arteriosus. So patient came up again, was asked to follow up after 2 weeks, and now the liquor had increased from 14 single pocket to 19 deepest pocket. AFI was around 40, she was breathless. So amnio reduction was done at 34 weeks. We gave IM progesterone, risk of PPRM was explained, around 3 liters of amniotic fluid was removed, and we stopped the procedure when we reached the single vertical pocket of around 10.5 centimeter. So an amniocentesis to prolong the pregnancy. We didn't want her to end up in PPRM and deliver at 34 weeks, so an amnio reduction was done. Further, she needed another amnio reduction at 36 weeks, delivered at 38 weeks. Neonate had frequent urination at birth, there was electrolyte imbalance, geneticist came into picture, and further tests were carried out. Blood was sent for genetic mutation analysis, wherein a pathogenic variant for Bartter syndrome in the baby was diagnosed. So, what do we get to learn from these cases? Let's learn it the English way. First case tells us that our eyes don't see what our mind doesn't know. So, from yesterday's workshop and from today's lectures, we should learn how to do a good anomaly scan. We should learn about the anomalies fetus can have, the varied presentation, and this case of micrognathia teaches that well. The second case, again the English way, all that glitters is not gold. So similarly, all that's dilated in bowel is not obstructed. The pattern recognition, this typical honeycomb appearance tells us about that. And the third case, delivering the baby is not the end of the story. We gynecologists deliver the baby, hand it over to the pediatrician, and we think that our work is over. But no, picture abhi baki hai dosto. We have to keep the pediatrician and the geneticist in the loop so that we can complete the diagnosis. So the take-home message, we started with polyhydramnios, and my first slide said that let's beware of the rare condition. But my last slide, I want to convey that let's not be frightened, let's not be afraid of polyhydramnios, let's not be beware. Rather, I want all of us to be aware of this rare condition. Thank you very much.
Thank you, Dr. Sumit. It was indeed an eye-opening presentation. Before moving forward, I would request Umbarji Madam and Bhagwat Sir to please felicitate Dr. Veena Bhagwat Madam. Vinat Panat, sorry sir. Bhagwat Sir and Umbarji Madam. Thank you. Thank you, ma'am. We now move forward with the next lecture by Dr. We now move forward with the next lecture by none other than Dr. Bimal Sahani, sir. The lecture is on evolving anomalies. I am sure this will keep us awake in the post.
Yeah, a very good afternoon, and actually Sumit has just set the tone for evolving anomalies. So this talk actually is going to take you through not just the GI but the other ones, but I think he has really brought it out with his 3 cases that yes, the 20-week scan is not the final which most of us think of. This is actually a truth in practice that NT scan at 11 to 13 weeks, 6 days, and anomaly scan at 18 to 20 weeks, we know is an integral part of our obstetric scan. The problem is that not just the patients but the clinicians also, they want a conclusive answer that the fetus is normal or abnormal by the anomaly scan. And that is the reason that, if there is anything which is found in the 3rd trimester, the first question that is always asked is, anomaly scan nahi kiya tha kya? And that is where we are all going wrong. We know that 2nd trimester is a good time. See, we've been talking about screening since morning. What is the 20-week scan that you do? Is it a diagnostic test? No, it's again a screening test. You're screening for anomalies. Yes, you will pick up most of them, but at the same time, you're going to miss some. Miss some is not the right word, but there would be some which would eventually happen later, because we know pregnancy is a dynamic event. A lot of times when people say कि लेकिन पहले भाई अगर सब कुछ पहले ही हो जाता तो baby भी 20 weeks पे deliver होता था ना, why should the mother go through all the way to 40 weeks? The baby has still got to grow. We know that the brain at 20 weeks and a brain at 30 weeks and a brain at 37 weeks is different. So in spite of all the best of the knowledge that you have and the best of the efforts that you have put in, there would still be some surprises which you get in the 3rd trimester, and that comes in the form of evolving anomalies. And most of the time they come at the time when you have done a growth scan, because certain anomalies are progressive. There are certain anomalies which are true late onset, and some are not just apparent at the 2nd trimester scan. Remember one thing, that you cannot hasten embryology. Embryology is going to take its own course of time. If the corpus callosum is going to be fully formed at 22 weeks, it is going to form at 22 weeks. 19 weeks I cannot and whether you get an MRI done or you get anything done. If embryologically, if it is 22 weeks, then even MRI is going to help you only after that. Now, in this one study where they've said, is a routine ultrasound in the third trimester justified, and they found out that they did an ultrasound at 11 to 14 weeks, 20 to 24 weeks, and 28 to 32 weeks. And they found out that they could pick up 40% of the anomalies at 11 to 14 weeks, and of the remaining 35% were picked up in the second trimester, but a large number, 15% of them were picked up in the third trimester, and 10% were picked up even postpartum. Now, this study is coming from a very good institute. It's coming from a very good institute. What I'm going to take you through today are all cases which I have only done at the 19 to 20 weeks period. And I'm good. I'm not trying to boast on anything. I have a very rigid protocol. I put in a lot of time. I put in efforts. And so, the message that I want to give you is that the 20-week scan is not the final thing. Now, there are a lot of studies where they found out that yes, like in this study which is quite recent, and they found out 24.8% of them were picked up for the first time in the third trimester, 7.4% postnatally. And I always felt we need to make the patients aware about it, but now I realize that no, we need to make the clinicians aware about it first. And we need to make the pediatricians aware about it. A lot of time the loose comment actually comes from a pediatrician. They may not do it intentionally, but pehla scan nahi kiya tha kya, ye nahi hua tha kya. That puts up a question in the patient's mind that it was missed, it should have been picked up kind of a thing. So I think if we all know about it, then there is, once 3 people say the same thing, yeah, if I have done the 20-week scan and at 34 weeks I pick up or a baby is born with an anomaly, if I am saying something, nobody is going to believe me because I am the culprit. But when 2 other people also say the same thing, no, this is not something which would have been appreciated at that time. This must have evolved over a period of time. Yes, 8 to 10% of them we are going to see later on. This can happen. Then the patient, and in today's era with compensations going to 1.5 crores and 3 crores and all, we don't know what we are going to do. And I think the only way out of that is to make everybody realize that yes, what are the evolving anomalies, what are the things which can happen later. And every time that you see an anomaly in the third trimester or an anomaly after birth is not necessarily a missed anomaly. Everybody puts in their heart and soul into something. Now, the knowledge has increased drastically. Most of the scans are being done in most of the places in a good way. But there are some things which is always going to happen. Because till recently, for the world, second trimester was always 12 to 24 weeks. But for India, it was 20 weeks. Okay, now this has stopped. And this is the biggest advantage of shifting this MTP to 24 weeks is about evolving anomalies. Like Dr. Praveen took us through sulcation and garage, everybody talks about, what are the 2 things that you're going to look for in the night, when it comes to sulcation. Commonly, you look at the parieto-occipital sulcus and you look at the Sylvian fissure. At time 19 weeks when you're doing a scan, you're not going to see the parieto-occipital sulcus. You're not even the Sylvian fissure is actually a very, very, very shallow thing. So sulcation disorders, you're always going to pick up later. So evolving anomalies, when we talk about, there could be either evolving and progressing, they could be true late onset, or there could be sometimes anomalies that were not apparent at the earlier scans, and sometimes they are missed anomalies. I'm not saying they are not missed, there are times when they are missed anomalies, or sometimes the patient has missed the 18 to 20 weeks scan, they have not done it, and that is the reason we get them in the third trimester. So common systems is urinary tract, GIT, CNS, cardiac, musculoskeletal, miscellaneous. I'll take you through some of them. So as I said, there could be progressive anomalies. They may have very subtle or borderline findings at the 19 to 20 week scan. But they have a natural history. They may progress into significant anomalies. You may have very mild pelviectasis. It may progress into a full-blown PUJ obstruction later. Now, every time that you see a mild pelviectasis, are you going to think, we know that 80% of them are physiological, but some of them are going to progress. These are progressive anomalies. Then there are some anomalies which become apparent in the late second or third trimester because of an embryological timetable. Structures are not fully formed. The physiology prevents their early presentation. Like Sumit showed those cases of the physiology prevents those bowel dilatation to be seen in the second trimester. The polyhydramnios does not occur in the second trimester. And so these are the ones which we are going to face, and there are anomalies which are true late onset. They develop later in pregnancy. You can have tumors, they are going to occur later in pregnancy. You can have the renal vein thrombosis can occur. Then all those anomalies which occur because of a clastic event, like infection or hemorrhage, these are the ones which actually will always develop later. And so vascular insult, we are going to find those things only later in pregnancy. Like renal anomalies, we all know has a natural history. They can resolve, they can remain static, or they can progress. I'm talking about urinary tract dilatation. Mild may move to moderate or severe. Just hydronephrosis in the second trimester may become a hydronephrosis with hydroureter or with uretroceles. You may find just unilateral, but they can become bilateral. Bilateral hydronephrosis, you feel that, okay, this looks to be only pelviectasis, there is no hydroureter. Later on in pregnancy, you find that no, there is hydroureter and the bladder has become distended and you are dealing with a lower urinary tract obstruction. Hydronephrosis seen in the second trimester may at times go into cystic dysplasia, and that kidney may become dysplastic, or you may have a urinoma developing. Let's see this. This is like, on one side, this is 5.7, 3.6, old image of mine. But then, am I worried at 20 weeks with this kind of an appearance? I'm not. But this patient comes directly for a growth scan at 37 weeks, and this is a full-blown POJ obstruction. This has evolved. Why I couldn't tell it that time? I cannot. I'm a student of science. I'm not Baba. Only the Babas can do that. So at 20 weeks time, when I say everything is normal, but I can't say, ja Simran, ja jile, kuch nahi hai, I can't do that. I have to talk within the limitations of science and embryology. Now here you can see this case, 20 weeks, yes, you have a mild hydronephrosis. 24 weeks, there is an hydroureter developing. 28 weeks, when this patient comes, yes, gross hydroureter, and I can also make out a uretrocele. So this has progressed. This is 19 weeks, 4 days. Yes, we have pelviectasis, we have peripheral calectasis. This is A23. The parenchyma appears okay. 26 weeks. Now, retrospectively, I can say that, okay, this looks a little bit more echogenic than normal. 26 weeks, I'm able to see some cysts which are developing in the cortex. 30 weeks, there is a large cyst, and there are multiple cysts, and the kidney has become echogenic, large, and this is the postnatal picture, and this has gone into a cystic dysplasia. So this is something which has evolved. This is 26 weeks. The scan was done earlier at 18 weeks somewhere else, but then fine, they had said that there was a bilateral pelviectasis, and with central calectasis at that time. The patient came to me at 26, 27 weeks, and there not just significant hydronephrosis, a urinoma has developed, and I know the cause here because there you can see bilateral echogenic kidneys, there is urinoma, and I can see the keyhole appearance that I'm dealing with a lower urinary tract obstruction. Other GUT anomalies like ARPKD, ADPKD, we always felt that ADPKD, yes, is going to be a postnatal, but ARPKD, we will always find oligohydramnios and large bulky kidneys, but no. At 19 weeks, you may find them looking normal. The bladder is there, the liquor is good, but later on, as I spoke today morning in one of my own cases, I had everything looking normal at 19 weeks, and at 23, 24 weeks, because there was oligohydramnios, then Shilpa scanned and she called me up and said, Kisa, this is now gone into an ARPKD. Ovarian cysts. So remember one thing, whenever you see a pelvic cyst, which was not present in the second trimester, always, though we are not supposed to disclose the gender, but we at this is time when you look for it, and because this is more likely to be a ovarian cyst. But do we call them as ovarian cysts? No. We call them as pelvic cysts, or we call them as gonadal cysts. So that is the way you talk about. Then hydrohematometrocolpus can occur later, or then renal tumors. All tumors mostly would occur later. You can have that. You can have adrenal hemorrhage, adrenal masses. You can have renal vein thrombosis can occur later. These are some of the renal tumors. I'm just basically trying to introduce you to that these are the things which can happen later. There you can see an adrenal, it appears like an adrenal cyst, but you will be able to see that, okay, there are some echoes and this is adrenal hemorrhage there. And renal vein thrombosis. How many of you have seen a renal vein thrombosis in your life? I have also not seen one. This is thanks to Dr. Alpana Joshi. She's got 3 cases. I keep waiting for my first case. I don't want for the patient, but then yes. But we need to know about this entity. So in the third trimester, you may find that there is a renal enlargement, and the classical finding is that you have these intrarenal linear branching calcifications. Here you can see that this is an enlarged kidney. You can see intrarenal branching calcification. You can see a thrombus in the IVC also, which is giving you a filling defect when you put in color. So that is something which will occur later. Cardiac anomalies. Yes, there are some cardiac anomalies which are progressive, like major vessel stenosis. The post-valvular dilatation and the aliasing and all may not be apparent at the 19 weeks scan. Coarctation can evolve. Even tetralogy of Fallot at times. You may just find that there is a subtle override, and there is a VSD with subtle override. Pulmonary artery is looking normal. You see later on in the third trimester, you have all the changes of a classic tetralogy of Fallot. HLHS. Even in hypoplastic left heart syndrome, you may have mild aortic stenosis becomes critical aortic stenosis. Late in the third trimester, it goes into an HLHS. VSDs, small VSDs, 2 millimeter or less, you may not see them, but third trimester, especially in the apical VSDs near the apex, you find them in the third trimester there. Now look at this case, 19 weeks. Fine, look at the LVOT. Does it really look that bad? The left ventricular outflow tract. Really doesn't look that bad. Yes, with 27 years of experience, I felt that there is a slight post-valvular dilatation, which more than what I normally see there. And of course, there was no aliasing which was seen. Now this we call the patient again at 23 weeks, and 23 weeks we can see that yes, there is an aliasing, and that time the velocities across the aortic valve was 197.5 with 197 centimeters per second. So definitely now there is an aortic stenosis which has developed, and the shape of the Doppler envelope, if you don't know, then this is something you should also look at the shape of the Doppler envelope, and you will find that there is a slow acceleration to peak, and that acceleration to peak always comes in the midline if there is a stenosis. And this is 28 weeks, 2 days, and yes, now you can see that there is a post-valvular, the turbulence you are able to make out, but the chambers still look normal, but then I know this is gradually increasing in this thing, and now the velocity has gone to 309. So we had something which started with a subtle finding, and gradually it's going into a critical aortic stenosis there. 18 weeks, 6 days, 4-chamber view normal. Now tell me about these outflow tracts. Do you feel they are abnormal? The 3VT view? Yes, there is one abnormal finding there, and that is an LSVC. But otherwise, they look absolutely normal. The LSVC confirmed. Now, So we asked for a 32, we actually asked for a echo at 24 weeks, and then we will, because every time you see an LSVC, always put them onto a follow-up. And there, now 32 weeks, you start having a little bit doubt, and there you can see when you look at, now can you see that there is, and you will find that there is some amount of abnormal flow which is taking place, and you can see the shelf sign here. You will be able to make out the shelf there. This is the shelf that you're seeing. So this coarctation has evolved over a period of time. But was it helpful to pick this up in the third trimester? Yes, because these are ductal dependent lesions. All ductal dependent lesions, even if you pick them up at 38 weeks, you are going to do some benefit to the fetus, because you will prevent them from going and delivering in a secondary center, because these are the ones who need to deliver in a tertiary center where there are facilities for pediatric cardiologists, because we want to give prostaglandin after births to prevent the ductal closure. Now, tumors, rhabdomyomas, aneurysms, these are the ones, hypertrophic cardiomyopathy, these are things which you will see later on in pregnancy. Third trimesters, as far as GIT is concerned, Sumit has already shown us one wonderful case there. But then esophageal atresia, see, most of these atresias you are going to find after 20 weeks. Most of these atresias you are going to find. Higher the level of obstruction, the earlier you may find some changes, because the polyhydramnios occurs early. For esophageal atresia, it will occur early. For duodenal, it will occur later. For intestinal, you may not get polyhydramnios at all at time, till very late. And then, of course, anal atresia and all, you may not get. So generally, the first clue that even Sumit has shown, because he started looking more because he saw polyhydramnios there. So polyhydramnios was the starting point. And now that is not something that you may get at 19 to 20 weeks. Diaphragmatic hernias. Yes, diaphragmatic hernias can evolve. The herniation has to be there. I'm not saying the defect was not there. But are we going about looking at the defect in the diaphragm? No. We start thinking of diaphragmatic hernia only when we see dextroposition of the heart. Dextroposition is going to occur only when something is herniated out. Maybe at 19 weeks it may not be there, and later on it has herniated, and that is the time when you are seeing that. And that is why they say, if this would not have been there, that is why they say that one of the poor prognosticator is early diagnosis of diaphragmatic hernia, because that prevents lungs to mature properly. So all these things can happen there, and this is like 19 weeks, Liker normal, everything okay. This is the kind of stomach I'm seeing. This is fine with me at 19 weeks. Very obese patient. I felt everything is fine there. Now this patient came for a growth scan at 33 weeks, 5 days, and that is the time. Now I'm feeling that, okay, a very, very tiny stomach. There is polyhydramnios. I'm seeing the proximal esophageal pouch, and of course, you can see this proximal esophageal pouch which is here. And so esophageal atresia has occurred later. So prenatal diagnosis of, this is one paper you should always keep with you. This is a meta-analysis which is from Asma Khalil group. And they have concluded that prenatal diagnosis of esophageal atresia remains challenging, ranging from 24 to 32%. Ultrasound is a poor diagnostic tool, because esophageal atresia is the one which will always give you problem, because that is the one after birth it has been picked up and they will call why it was none. So you need to, all such articles which are protective, you should always have them handy. You should also read them, because हम घबरा जाते हैं एकदम. We feel we are at fault. So you should read these articles and always keep them with you. 19 weeks, 5 days, stomach fine, rest of the abdomen, everything, I'm not seeing anything abnormal, no dilatation, nothing. This patient comes at 32 weeks and there is a bowel obstruction that you can see, the grossly dilated bowel loops, hyperperistalsis that I am seeing. There is reverse peristalsis dealing with an obstruction. Forget what kind of an obstruction this is, whether ileal, jejunal, and all, but then the interstitial obstruction has occurred later. CNS, ventriculomegaly. Has anyone seen lateral ventricles appearing normal at 19 weeks and then having a significant ventriculomegaly in the third trimester? Yes. That is something which can happen. Microcephaly. Microcephaly in most of the cases is a third trimester diagnosis. Unless the patient is coming with a first child with microcephaly, then yes, otherwise, because there is a range of normality. When Sujit was talking about biometry today morning, and there is a range of normality, anything between the 5th centile to 95th centile for that gestational age is normal. Then corpus callosum abnormalities, Vermean hypoplasia, lesioncephaly, destructive cerebral lesions like porencephaly, seasoncephaly, 18 weeks, 26 years primary, no significant family history. This is 18 weeks, 1 day. Yes, the BPDHC are a little less, but they are within the normal range. What should I do? Head perimeter is at the 15th centile. Should I put in as a mark of caution? Maybe not. Now this patient comes at 28 weeks, and that is the time when I find that, okay, sloping forehead, and the head circumference has gone actually less than -3, -4 standard deviation there. At least maybe total agenesis, complete agenesis of corpus callosum you will pick up, but never make a diagnosis of partial agenesis of corpus callosum at the 19 weeks. Give embryology its time. Let the corpus callosum develop. Yes, complete agenesis, yes, you would be able to make up even Vermean problems, even Vermean hypoplasia, and when we talk about, Vermean, a frank dandy walker is not a problem, but when you say that the worm is appearing little smaller, and yes, it is falling at the 9th centile or this less than the 5th centile, no, give some time for the worm is to develop fully. Intracranial hemorrhages, you will occur later. Infections, signs of infections like CAME phytopathy, you may not find at the 19 weeks because it all depends upon when the infection has occurred, and then you will find those changes. And lesioncephaly, Dr. Praveen took you through. Destructive lesions like porencephaly. Hydranencephaly, yes, you may see before. Seasoncephaly, you may find later. Vein of Gallen malformation. Again, something which may not be present or not be seen at the 19-20 weeks, but you will see it later. Neck masses like dermoids, teratomas, even thyroid goiters, you're going to see later. No, this was another case which eventually turned out to be an hemangioma. Actually, this was not the scan which I had done at 19-20 weeks, but the first thing I saw the images that time. In fact, the radiologist who had done it was so scared because she said, "Sir, I have all the images." I said, "I know, don't worry. This is not something which was present then." And wonderfully taken images, and I saw there was nothing that was made out that time. But this is something which can happen later. But that is what I could explain to the patient. Musculoskeletal achondroplasia, you can have later. Arthrogryphosis, at times you will find later. Milder forms of non-lethal skeletal dysplasias, you can have later. Things like hydrops, hydrothorax and all. And then there are the biggest problem these days is the high BMI. I think the BMI in Indians has really, really gone up. Poor sound penetration has become a norm. Now, I don't know what happens with others, or maybe my center has become my center was a second opinion referral center before. Now it has become a center for the high BMIs. Nobody wants to, they give the money back to the patient and they say कि ये सर के पास बहुत अच्छी मशीन है, बड़ी मशीन है, सर के पास चले जाओ. Because औरंगाबाद में एक ही पागल आदमी है जो पूरा दिन लगे रहेगा उसको कुछ तो भी करके, they try to come to some conclusion. But yes, that is the reason, one more reason that you may miss subtle things. You may find that yes, there is a kidney which is not seen in the renal fossa, but you may not be able to pick up a pelvic kidney at that time, but you will see it later. VSDs, even, like Manoj showed today, prenatal diagnosis of TAPVC at times in poor sound penetration. Otherwise also it is difficult, but it will become more difficult in poor sound penetration. Now, this is a list of anomalies from the Palladini group, where this is again one list we should have, where he has talked about which are the ones which will always be seen in the third trimester, which are the ones in significant number of cases which will be seen in the third trimester. Also, only after birth they have also given that. So, this is something you should have. So third trimester scan. Now I come to this question, is it a routine scan? Yeah. I get one scan 20 weeks done from an expert and rest all scans I do myself. Is it a routine scan? There is one case where a radiologist did a scan at 20 weeks and all other scans were done by the obstetrician. Now, they missed something. So radiologist came to me for help. Anirudh knows that. So I guided him and I said, this is evolving. So this should have been picked up later. Then the obstetrician came to meet me for the same. And she said, I got an anomaly scan that time. I said, yes, it could have been picked up. It's not that it could not have been picked up, but then it could have also evolved. Now the whole issue is, this person wants to put the blame on that, the other person wants to put the blame on that. I said, best thing is you both sit together and come to one conclusion, or you both come to me, we'll find one solution where both of you do not have an issue in that. So, it is not a routine scan. You are looking for anomalies has to be a part of every scan that you do. I'm not saying that you will be able to do the complete protocol of things, but there are certain things which should be a part of your... So third trimester scan is not just about looking at the fetal weight and Likert. Third trimester scan is also to look for structural abnormalities. So but then the detection will depend upon what is the type and size of defect, technical consideration, what machine you are using, what is the fetal position. Alertness and experience of the operator is very, very important. And the pickup rate will increase if it is a high-risk pregnancy. If it's a low-risk pregnancy, the alertness is also less. But if I know this is a high-risk pregnancy, or somebody has said that my first child had this problem, automatically my alertness is more, and so the detection rate in the third trimester increases. So at my place, my third trimester checklist, of course, my checklist otherwise is huge. Even like I practically anybody who has come to my clinic will realize we look at most of the things again, but then definitely look at the ventricles, the cerebellum, cerebellopontine hypoplasia can occur later. Look at this, at least the Sylvian fissure in the parieto-occipital sulcus, and try to look at the corpus callosum. Heart, look for symmetry of chambers, tricuspid regurgitation, because these are two things which give you a lot of clue. You find that the LV is appearing narrow, you will go down and look for coarctation. You find there is a tricuspid regurgitation, you will look for premature ductal constriction. So that is an important thing. So whenever you're taking, you all take heart rate in the third trimester? Lete ho na? Always take a PW Doppler across the tricuspid valve. Aapko kahin to lena hi hai na? So you put that. So once you take that, you will always get the TR. If there is a TR, you are going to find them. Look at the stomach and the bowel. Anything, any clue. If you can, try to put the perianal muscular complex as a part of your, because if you put it in your protocol at 19 weeks, a lot of times you will be false positive about that. So at least in the later parts you have it. Look at the renal pelvis and the bladder, and rest everything, of course, whatever. It's these are certain, we say ki my checklist is different if I have done my 20-week scan, and my checklist is different if I have not done the 20-week scan. No. Both ways, my checklist is the same. If I am done my 20-week scan, I am more scared. Only thing, my statements are different. If I have not done the second trimester scan, I will give a declaration and say that yes, the anomaly detection at this stage is going to be limited, and this limitation needs to be taken into consideration while making clinical decision, especially so if the third trimester scan has been done by us for the first time in the third trimester. So we will give this kind of a declaration there. So what are the implications in clinical practice? Genetic testing, management and outcomes, termination of pregnancy, and counseling. And I'll take you through. Should we do a genetic testing if you pick up an anomaly in the third trimester? Anybody has a say on that? You can. Yes, you should do it. There is no, the law doesn't say you should not do it. You can do it because you will have a more precise diagnosis. And it is always, you can involve the geneticist, and you will have a complete this thing. Maybe at times a genetic diagnosis will change the management, probably from a cesarean to a normal delivery if you are dealing with this thing. Then, because the medical legal aspects now, after 24 weeks also, you are allowed to terminate the pregnancy with the permission of the court, but the medical board will always want a complete workup to be done before taking a decision. So, and DNA storage is something that you need to look for. The legal limit has gone to 24 weeks. It is possible to terminate even after 24 weeks. We should be aware of that. Complete workup before going to a medical board, and help the patient, guide the patient, tell them, yes, this is the way you can do it. Now there are lawyers available who will do it, and abhi to bahut quickly the court also and the medical board gives a decision very, very fast. Outcome, the mode of delivery, the obstetrician will think of. Generally, the mode of delivery just does not alter. If you find there is no hurry in, you don't need to deliver, if there is a urinary tract obstruction or this thing, an early delivery does not help in any way. Deliver in a tertiary center whenever is necessary, that is more important. The problem is, why was it not picked up earlier? That is the most difficult question to answer. So counsel the patient. ऐसे time पे कभी भी hurried counseling नहीं करना. And most important thing I will tell to all the radiology or the imaging people here, when you see an anomaly in the third trimester, you can ask for the patient's file, go to your room and read it, but don't ask the patient कि आपने 20 week scan किया है कि नहीं. वो पहला statement anomaly scan नहीं हुआ है कि नहीं, वहाँ से वो पूरा problem शुरू हो जाता है. And you can land up in a situation where you may say, पहले स्कैन नहीं किया क्या? किया था सर. कहाँ किया था? आपके पास ही किया था. मर गया. So don't ask this question at all. Keep it for, read the file, and then, so everyone from the imaging specialist to the clinical obstetrician and to the pediatric specialist, they should all speak the same language. That is the most important thing that we need to do. So counsel patients about this possibility at mid-trimester scan. Do we do it? No. Mid-trimester scan is normal, we don't. We do write a statement that all anomalies cannot be picked up and all. But subtle findings that you see, put it on paper. There is nothing wrong in it. You find borderline subtle findings, put it on paper and say that yes, this is, and talk to the patient and tell them this is just a borderline subtle finding. This may turn out to be absolutely normal, but today I can't make a final call. Let's repeat after 3 weeks. Let's reassess this, and then we will come to this thing. Wherever you have a doubt, take a second opinion. The wrong notion that everybody has is that second opinion is a higher opinion. No. Second opinion का मतलब है कि एक चीज के लिए दो लोग अपना opinion दे रहे हैं. Because I am dealing with a subtle finding. Let two people see it. That will also keep me legally safe. That yes, both of us felt the same thing at that time. Then, third trimester scans are not just growth scans. Looking for structural anomalies should be a part of every scan. You may detect previously undetected structural anomalies. Such diagnosis and subsequent management, including selection of timing and place of delivery and postnatal investigations, can potentially improve the postnatal outcome. There are still a few anomalies which would be diagnosed postnatally, because baby is born with a presumptive diagnosis rather than a symptom. Thank you very much.
Thank you, sir. I am sure everybody will be awake till now. We now move on to the next talk by Dr. Aniruddha Kulkarni, sir. He will be speaking on internal loss and cervical assessment throughout pregnancy. Sir is a professor of radiology. He is also the joint secretary of IRIA and the past secretary of Maharashtra State IRA. His areas of interest include urogenital, neck, and pediatric ultrasound. He is the author of the book, textbook of radiology of 2 chapters, and he has indexed publications approximately 23 in number. He is also the reviewer of British Journal of Radiology and a national and international faculty. We welcome you, sir.
Thank you very much. It's really wonderful to see the audience in the hall, in spite of 2 lectures post lunch. Internal loss and cervix throughout the pregnancy. No financial disclosures. Images belongs to my clinic, and this material has been specially designed for Scholar MD Advent. No copyright dispute. in next 20 minutes or so, because it's my responsibility so that I can help the organizers to reduce my timing to as minimal as possible. We'll discuss about scanning technique and protocol, certain tips and tricks for key features of cervix, cervical morphology in early pregnancy, mid-trimester and late third trimester, what is mean by cervical insufficiency as far as imaging is concerned, and certain what you can say key point regarding elastography and role of MR. As we all know, cervix during pregnancy is a barrier for microbes. It holds the pregnancy throughout its tenure. It allows easy passage during the labor, which is the effective way of delivering the baby. And it is expected to remain closed throughout the pregnancy till it reaches to the stage of preterm labor. Labor. Transfer ultrasound, we need to tell our all PGs that it is the gold standard at any gestation, for that matter, early pregnancy, mid-trimester or third trimester. You still can apply transabdominal ultrasound or translabial ultrasound, or many instances transrectal ultrasound also. And this is how the non-pregnant cervix look like. We need to teach ourselves that the endometrium, it pinpoints to what is called as anatomical internal os, and this is the entire length of endocervix during non-pregnant state. So we must train ourselves to identify the non-pregnant internal os and cervical region, so that we can identify any differentiation in early pregnancy and second trimester. In case of early pregnancy, why the internal os and cervix is important? Because we need to identify what is inevitable abortion or non-viable pregnancy with cervical and internal os changes, sac separation and bleeding zone which is adjacent to the internal os, which we need to mention in our report, and very important thing, that is a low implantation sac and its subsequent analytical approach or algorithms, and certain cervical ectopic pregnancy, cesarean scar ectopic pregnancy, in which the internal os and cervix is mandatory to be assessed in a detailed fashion. Now this is how the internal os and the cervix looks like in early pregnancy. So here you can see that the pregnancy is implanted well above in the upper uterine segment. Here you can appreciate the anatomical internal os is absolutely normal. The anterior and posterior lip of cervix is hypoechoic and well preserved, and the cervical length is absolutely normal in early pregnancy. What is meant by low implantation? Just a passing reference. Whenever the implantation of a gestational sac, that is the lower margin of the chorionic glutoplastic activity, is less than 5 cm from the external os, then we are going to say that it is a low implantation sac. And it's very important because we need to differentiate the important 4 conditions, that is a cervical pregnancy, caesarean scar pregnancy, cervical stage of a miscarriage, or what is the cervico-ischemic implantation closer to the internal os, that is the implantation below the insertion of uterine artery, which is a precursor of morbidly adherent placenta eventually in late second trimester and third trimester. Now whenever there is a low implantation, as you can appreciate here, it's a low implantation sac, you can appreciate the caesarean scar over there, and it is a very in close proximity, less than 5 centimeters from the external os, so it's a low implantation. Usually presents with a bleeding PV or the pain, and we need to follow certain algorithm to decide what kind of fate this pregnancy is going to have. We are going to see for sliding sign, and the second other sign is what is called a crossover sign. So what is meant by sliding sign? You give a sustained pressure by the transvaginal transducer. Is the suspicious gestational sac slides over the cervical canal or the myometrial step, we say it's a positive. We are not worried about all those low implantation sacs. Whenever the suspicious gestational sac is fixed and does not move along with the transvaginal transducer pressure, then we say that its sliding sign is negative. Okay, so the inability to displace the gestational sac from its position at the level of internal os using gentle pressure applied by the transducer is a sliding sign. So negative sliding sign is very, very important. So whenever you consider low implantation sac, if there is an absence of peritopoplastic activity in low implantation, the sliding sign is positive, it slides very well. We are dealing with cervical stage of a miscarriage. If there is a presence of peritopoplastic active flow, sliding sign is negative, there is a fixity, we decide about 3 conditions, that is caesarean, that is gestational sac within the myometrium, cervical pregnancy, near the scar with anterior deficient myometrium, and cervico-ischemic implantation for the future. So it's a cervical pregnancy, caesarean scar pregnancy, and depending upon application of cost criteria, it is a crossover sign, and presence or absence of multiple uterine scars, you need to follow it very meticulously in second and third trimester for morbidly adherent placenta. In case of a cervical stage of a miscarriage, you can see the products or sac intact which is detached from the fundus, which is a non-viable within the cervical canal, and you will see a widening of the cervical canal, ballooning, peritroplastic flow is usually absent in those individuals. Now in this patient, very interesting, you can appreciate that at the level of the vaginal introitus, the entirely intact gestational sac along with the CRL can be appreciated very well. Now, in case of an inevitable miscarriage, which is a technical term used, you can see products of conception or intact sac closer to the internal os or cervical region, which is a common feature in case of a miscarriages. On many instances, you will see that there is a history of a passage of products of conception, and at the same time you can appreciate that the entire cervical canal is having small amount of fluid, which is in continuation also is appreciated within the endometrial cavity. So depending upon the previous history of either MTP or passage of products, we can say that it's an inevitable miscarriage or complete miscarriage in that individual. What are the changes that occurs during cervix during the pregnancy? Eventually, as the pregnancy advances, there is a cervical shortening. Internal os should be closed till we reaches to the stage of labor. There is a collagen and elasticity changes which eventually needs to be appreciated in third trimester as well as always during the labor stage. And we will see that there is an apparent myometrial thinning, which obviously you can notice from second trimester to third trimester. Here you can see there is a myometrial hypogenicity is well preserved, and during the labor you will find that internal os is open, there is a cervical shortening, but the amount of hypoechogenicity and vascularity involving the myometrium is definitely going to be altered. Now a lot of emphasis was given to the uterine mounds, which can be seen in second trimester, and we used to say that it's a cervical internal osseous competency is maintained, but it has lost its significance, and we have what is called the classical cervical length screening, which has been taught by Clear or the perinatal.com. So what is the transvaginal protocol? Whenever you are suspecting cervical insufficiency, you must empty the bladder, you must keep the transducer in anterior fornix, you should take the sagittal cervical mucosa, demonstrating it from the complete length of endocervix starting from external cervix to internal os. You should scan the cervix dedicated fashion for at least 5 minutes and then comment, just wait for any uterine contractions to subside. Withdraw the probe till you can get a blurred vision, and then you can demonstrate the external os very well. At least 2/3 of your screen. That means the depth and the zoom while evaluating the cervix has to be a adequate one, 70 to 80%. So take at least 3 measurements from external os to internal os through the endocervical canal. The shortest measurement possible should be considered, or you can take a mean. Apply gentle fundal pressure for 15 seconds to see whether there is any amount of fluid within the endocervical canal or not, whether the internal os is really open or not, and then just comment regarding the same. So this is a website. I think you must always follow this website, that is clear.org. What it suggests, the anterior and posterior lip of cervix should be symmetrical. That means its width should be normal. Entire cervical canal should be noted. You should mention the echogenicity of the myometrial stripe. You should say that the internal os is flat, and the shortest 3 base measurements should be taken, and you can take either the shortest one or you can take a mean of the same. So now let us take this serial loop and look at. Now what I am trying to do is that I am trying to put a more transducer pressure initially. I am withdrawing the transducer pressure so that the anterior lip of the cervix and posterior lip of the cervix, they are equal in dimension. I can see the internal os very well. You can see the dimple over here. I can see the external os very well in this patient. And then you should measure the entire length of the distance between the internal os to the external os. I am very happy to see that it's a homogeneous in appearance as far as the anterior and posterior lip of the cervix is concerned. You can see that the depth and zoom of this cervix region is quite adequate and satisfactory, occupying more than 70% of the screen at this period of time. So I am very happy that technically I have done a satisfactory job in stating that internal os is close, anterior and posterior lip of cervix is equal in weight, it's hypoechoic in nature, the endocervical canal is absolutely normal, and the cervical length is say 3.2 centimeters, which is absolutely normal in nature, and there is no herniation of membrane in this patient. So this is how the difference occurs. Now here you can see that I have applied more pressure. You can appreciate that the anterior lip of the cervix is little bit thin as compared to the posterior lip. As soon as I release the pressure, you will realize the internal os is in fact was open, and there is a minimal amount of funneling which is obviously noted, and you can see that there is some kind of a cervical shortening in this individual. So it's very important to have what is called a gentle pressure release after doing an initial scan for that matter. Now there are two ways of looking at it. You can take either the complete length internal os to external os. When you have a curved appearance as far as the cervix is concerned, you can take 2 or 3 measurements rather than taking a curvature, because curvature will always give a false long length of the endocervical canal. So you take one straight measurement, second straight measurement, and third straight measurement. So and add into that so that you can take an endocervical canal in terms of length. So what is meant by short cervix, the commonest terminology that we use, it's basically we need to understand after stating that it's a short cervix, whether the internal os is open or not, what is its diameter, what is the length of funneling, what is the functional length or the effective cervical length, and what is the total cervical length, and depending upon that you can calculate what is called the funneling percentage. So this is an image from the same website that I have mentioned, that is a clear, that is, this is the width at the level of internal os, this is funnel length, this is the effective cervical length. At the same time, I am hoping, probably I will see to it that the anterior lip and posterior lip of cervix, they are equal in dimension. So what is meant by funneling percentage? Funneling percentage means funneling length upon additional of funneling length plus cervical length. So that is A upon A plus B, it gives the funneling percentage. So practically what is effective cervical length, it's a closed portion of the endocervical mucosa that we are measuring. Okay, that's very, very important. So one more criteria which was used in 2010, 2020 for that matter, that is uterocervical angle. So this is uterocervical angle. Increasing wide uterocervical angle after mid-second trimester may require cervical encirclage. What is meant by wide? That is more than 95 or more than 105 as far as this angle is concerned, and it's said to be responsible for spontaneous preterm birth, depending, that is 95, that is less than 37 weeks, or more than 105, that is less than 34 weeks. So you can use uterocervical angle in combination with the cervical length screening, and then you can give a better what you can say criteria for the preterm birth level. So cervical consistency index is one more index which was used in between. So we have what is the cervical length and the AP diameter of the cervix, where we have taken the anterior lip of the cervix and posterior lip of cervix to be equal. Now you give a sustained pressure. So one is with pressure, the other one is without pressure or releasing the pressure. You take both the measurement, that is the cervical length measurement as well as the AP diameter measurement at the level of the midpoint, and then you calculate it. So what are we calculating? We are calculating AP upon AP dash into 100, that is called a cervical consistency index, and this is a chart which helps us in stating what is happening in first trimester, second trimester, or third trimester, and there is a standard deviation which you can apply. So cervical consistency index is one more thing which was tried in the 2010 to 2020 decades. In terms of cervical insufficiency, ACOG has stated that the inability of uterine cervix to retain a pregnancy in absence of a signs and symptoms of clinical contractions or labor, or both in second trimester, is cervical insufficiency. It's usually the painless cervical dilatation, and it may result into what is called the recurrent pregnancy losses. Merely stating that the short cervical length is not sufficient enough unless and until you have given a dedicated time of 5 minutes or more in stating that the cervix is open or not, what is funneling width and what is funneling percentage. Now there is one more factor which has been recently introduced, that is the fetal fibrin testing. Now this is a biochemical marker that you can use for the same. This is a book picture which we have been learning since our undergraduate days, that is what are the shape of the cervix depending upon the internal os to be open. It can be initially T in shape, which eventually increasing funneling into the cervical canal, it will become Y, then V, and then U, and we need to consider in terms of history what are the cervical risk factors which are responsible, out of which multiple obstetric trauma or mechanical dilatations, they are the most commonest one, but still on many instances it could be a idiopathic or we do not know the exact cause for the same. In terms of history again, you need to look for whether there is a prior for successful outcome after the encerclage or unsuccessful outcome, because depending upon that the surveillance will be decided, and this is the key feature that we always and always look for: open internal os width which is more than 4 millimeter, cervical length which is less than 25 millimeter, funneling and funneling percentage which needs to be documented after a detailed meticulous scan of 5 minutes or so. In terms of preterm births, which probably is our main indication for screening those cervical lengths, 2/3 majority are spontaneous and recurrence rate is very high. History of previous spontaneous birth is the strongest risk factor responsible for multiple losses. Screening of tool for cervical length needs to be done between 16 to 24 weeks. Short cervix merely you can say for a length which is between 20 to 30 millimeter, but at the same time the cutoff is used is 25 millimeter, and unless and until you follow the criteria of assessment of internal os and cervical length from the clear guidelines, you should not say that it's a cervical insufficiency. And woman with previous preterm birth now has a short cervix, has a maximum risk of population is having preterm births. So cervical stress test, which is one clinical entity, and the cervical length in combination was tried in between, that is in between 16 to 24 weeks, that is a transfundal pressure sustain was given, and the cervical length changes and the funneling length changes and appearances were documented and they were also mentioned, but again it has got more subjective variations other than a quantitative estimations. We need to understand what are the pitfalls in terms of a longer cervical length transabdominally. Here you can appreciate the bladder is over distended and there is no inadequate fundal pressure which is giving the true cervical length. Now in terms of a probe compression, here you can see there is a minimal amount of fluid within the endocervical canal. It's a true dilatation, but whenever you see an interrupted membrane in a fluid within the endocervical canal, that's a pseudo dilatation one, and we should not label them to be a true dilatation as far as the cervical length is concerned. On many instances you might find umbilical cord or fetal parts within the cervical canal and needs to be mentioned. Now you can appreciate the same. Can you see the bladder over here? I can appreciate some amount of fluid over there. And as soon as I transfer an ultrasound, you can see the anterior lip, posterior lip. Here anterior lip, cervix, posterior lips, they are equal. And I can see that there is a funneling over there with intact membrane and effective cervical length is short. That's the difference between how you should say what is pseudo dilatation and what is true dilatation, depending upon small amount of hypogenicity or fluid filled areas within the cervical canal. Now this is how the cervical insufficiency need to be calculated. Now you can appreciate that there is a great amount of cervical ballooning into the cervical canal. Now the next thing that I am going to do is I am going to look at the internal os width. Then I am going to look about the funneling length, and after the funneling length I am going to say about what is called the effective closed endocervical canal, that is the true cervical length, and then I am going to calculate the funneling percentage. On many instances people say that when there is obvious ballooning of the membrane into the cervical canal, why transvaginal ultrasound is done or expected, but it's always better to comment the funneling length and percentage and true effective cervical length available for the obstetrician to treat. It's always better to go ahead with the transvaginal ultrasound, even though there is a classical ballooning which is seen transabdominally. In terms of cervical screening now, with or without history of previous prior preterm births, there are certain guidelines, that is every 1 to 2 weeks as per need of clinical condition in 16 to 24 weeks. In case of a singleton pregnancy with history of preterm birth, you should follow the routine cervical length screening program. But whenever without preterm birth, you need not do in each every patient cervical length screening, but at the same time you should devote certain amount of quality time in assessing the internal os and cervical length in all individuals. After the encerclage, is there any role of following those patients? They say that because there is no additional treatment modality which is available, but still what I would say is that there is a progressive shortening which is less than 10 millimeter even after the stitch should be commented, but you cannot advise is the repeated scan in patients where there is already encerclage done for effective outcome after the encerclage. There is no consensus statement to follow in each and every patient after the cervical encerclage as far as cervical screening is concerned. Now, it's very easy to appreciate the encerclage stage. Can you appreciate this hyperechoic zone which is having a sharp shadowing at the level of cervical region? So, but only thing what I can comment is that I can see that the cervical encerclage stage is nicely seen. The effective cervical length beyond the cervical encerclage stage is nicely noted. So I will say the same, but eventually, even if you see that there is a ballooning of membrane beyond the encerclage stage into the cervical zone, you need to mention the same, but at the same time, it is not going to help because we are not going to do anything additionally after there is a ballooning, even after the encerclage. So that you need to just mention those findings. In case of multiple pregnancy, yes, it is very important to mention whether the cervix is short or normal in the length. Cervical assessment will help, but it's not a protocol in each and every patients of multiple pregnancy. Just to mention about cervical insufficiency in case of MR, they say that in MR they say it's less than 30 millimeter, but we usually follow 25 millimeter criteria. But what is the biggest hurdle? That you are not likely to use it as a screening modality and do not have any added advantage in stating it to be a as compared to TVS ultrasound. So this is how the normal cervix look like on MR. Just to mention few of the cervical elastography articles which is coming in a big way in Western world, particularly for timing the labor and the intervention required, because there the man force is very less. So what is ripening of cervix for that matter during labor? It's a decrease in collagen fiber alignment and the strength. There is a diminished tensile strength with extracellular matrix which is responsible for more and more hypoechogenicity in the cervical region. As far as the myometrium is concerned, there is increased vascularity. At the same time, there is a softening of cervix in that region which can be appreciated on cervical elastography. So there is increase in cervical decorin level. So together leads to what is called as cervical softening, and that's the cervical softening which needs to be commented on cervical elastography, and the equipment, your equipment needs to be having that elastography on your transvaginal ultrasound so that you can see. So in terms of stiffness, what does the color coding means? Blue means it's really hard or tough. Green means it's firm to soft. That's what we expect in case of labor or preterm, or what you can say in late third trimester. And red means really soft one or the loose one, probably just closer to your eventual outcome as far as the childbirth is concerned. So here you can appreciate the different stiffnesses depending upon that, and the color coding can be different from the blue to say violet for that matter. But we are really looking at on as a gross for screening is what is called the firm to soft in consistency in third trimester. Now here you can see the amount of the green or parrot green densities within the cervical canal appears to be more and more in nature. So we are probably sure that we are probably reaching to the stage of say pre-labor or labor, and needs to be commented depending upon that. Now as we have seen earlier cervixes throughout our talk, here you can appreciate that there is amount of multiple hypoechoic to anechoic lucencies within the cervical myometrium, which is a common feature in third trimester or late third trimester. So if you put a color Doppler into this individual, you will see a lot of vascularity involving the cervical canal, and there is a lot of hypoechogenicity. And as you put elastography into that, the amount of parrot green or green densities will appear more and more. So that's how the color Doppler and the elastography will help us in stating that probably we are reaching to a stage of labor in those individuals. Now, can you appreciate the increased amount of vascularity involving the cervical myometrium over there? You can appreciate very well. The initial hypoechogenicity, which was homogeneous in nature as far as the morphology is concerned in second trimester or third trimester, is now being replaced by multiple hypo to anechoic spaces within the cervical myometrium. If you put a color Doppler, you will say that there is aggressive vascularity which is noted in the cervical canal. So these are the two articles stating regarding cervical length and the labor, which never can be what you can replace the Bishop score, which is done clinically. The cervical ripening as far as MR is concerned, again area of academic interest more or less than the practical implication during our day-to-day practice. The only one important message, probably I think many people from our local organizing team wanted me to take some different topic, but I said that I want to speak on internal os and cervical length for the reason because including me for years together used to take internal os and cervix very casually, stating that the placenta is anterior, Liker is adequate, internal os is close, cervical length is normal. This used to be typed before I utter or before I decide that everything is normal. When you face many what you can say clean bold deliveries like Shane Warne, here you can appreciate that the ball is pitching outside the off stump and from there the leg stump is off. So such instances should not happen in your day-to-day practice. So devote your quality time in assessing internal os and cervix throughout the pregnancy, starting from internal os at the level of, say, during early pregnancy, look at the low implantation sacs very seriously, follow the cervical length screening in mid-second trimester whenever it is indicated, and also try to give additional information during this late third trimester as far as the cervical ripening is concerned. Thank you very much for your presence and appreciated your, what you can say, still enthusiasm in being into the hall in spite of 2 lectures post-prandial. Thank you. And I really congratulate local team for putting up a lot of efforts, and I always enjoy coming to Solapur for any reasons for that matter, academic or non-academics. Thank you very much.
Thank you so much, sir.
Open karo. Ye close kiya, kaad lai.
Everyone is requested to please check their Mindray bags. If you found a Maruti car key, please return it here. The bags have got interchanged and the key is misplaced. Please check your bags. Thank you. We now move forward to the next lecture by none other than Dr. Jyoti Taparia, Madam. We will be having case discussions. Madam is the professor and HOD of radio diagnosis at Ashwini Rural Medical College and Hospital, Kumbari. She is also the consultant radiologist at Unique Hospital, Solapur. She is currently the president of Solapur chapter of MSBRA. She is a PG teacher and guide. She has 20 years of experience in the field of radiology and various publications in national and international journals to her name.
This is the last session before panel discussion, and majority of the whatever cases I had selected, majority of the message has been already given by Bimal Sahani sir's lecture and Sumit's cases. So this is just, So, unexpected twist. 28-year-old female, second gravida. It's okay, it happens with me, with the organizer. Okay, so unexpected twist. 20-year-old female, second gravida. She had first trimester lost, G1. She registered with our hospital in first trimester and she had a normal course of pregnancy throughout. She had a normal USG at NT, 20 to 21 weeks, anomaly scan, growth scan at 30 and 31 weeks. At well-being scan at 36 weeks, there was bilateral and third ventriculomegaly, ecogenic ventricular line, and there was a 4.2 by 1.3 centimeter size heterogeneous ecogenic non-vascular lesion in atria and right frontal horn, suggesting acute hematoma. At the first, as soon as I kept the probe, the first thing was who had done the ultrasound previously, and it was me only. So it was ventriculomegaly with an ecogenic clot in the right lateral ventricle. So MCA PSV velocities were around 131 with MOM value 2.4, suggesting severe fetal anemia. The Burl coils were ecogenic. There was fetal tachycardia, fetal ascites. Looking at these findings, we sent mothers all investigations. Hemogram showed megaloblastic anemia, and so her B12 levels were done, which were less than 50. At the same time, we counseled the patient and fetal blood sampling was done, and it confirmed fetal anemia. HB was 10.4 grams. Platelets were normal. PT and ATT were normal, ruling out the alloimmune thrombocytopenia. There was no signs of fetal infection. Only positive finding for fetal blood sampling was serum B12 was of fetus was also less than 50. That was the only positive finding. Mother received 3 doses of injection vitamin K. We followed the case after we follow up USG after 2 days we had done. The ventricular size was enlarged, the size of clot was reduced, fetal MCA PSV were reduced, and fetal heart rate was also reduced. We call patient, she was 36 weeks anyway, so we call patient at 1 week later. This was the 2 days later images. We call her after 1 week. There was dramatic increase in the ventricular size. The clot was almost completely resolved. There were no internal echoes in the ventricular system. BPD, it enlarged by 5 millimeters in a week time, and the severity of fetal anemia was further reduced. So the decision for induction of the labor, this was the images after 8 days. So induction was done at 37 weeks 4 days. The baby boy of 3.1 kg delivered vaginally and shifted to NICU. The cranial ultrasound we done, which again showed the same findings. There was no intraparenchymal hemorrhage. It was isolated intraventricular hemorrhage. The clot was completely resolved. The ventriculomegaly was also constant, and so the neurosurgeons decided to wait and watch. And finally, after 2 months after delivery, we had repeated the cranial ultrasound, and the ventriculomegaly is persistent, so it's the diagnosis of arrested hydrocephalus. The head circumference is normal, ventricular size is same, and the baby is doing well, the milestones are normal. This is second case, rare to rampant. It's a 26-year female, 4th gravida, previous 3 LSCS. She came for the second opinion for the with the diagnosis of PAS at 29-30 weeks. On ultrasound, it was a left lateral low-lying heterogeneous looking placenta. The retroplacental halo was lost. There was severe placental thinning, bizarre vessels which were across the placenta, as well as they were reaching up to the bladder. So the diagnosis of the PAS with possibility of percreta and bladder invasion was kept as a diagnosis. Apart from that, the baby had unilateral brachydactyly involving left hand. All long bones were normal, and left hand, all metacarpals, all phalanges of the left hand were absent, and there were rudimentary soft tissue tags attached to the left wrist. So this was how the left hand of the fetus, it was a isolated brachydactyly. The patient was asymptomatic, so till 36 weeks she was carried, her pregnancy was carried, and at 36 weeks elective classical vertical C-section followed by total obstetric hysterectomy was done. The placenta was low-lying, it was percreta invading bladder up to the detrusor level, but it was not invading mucosa. And fortunately the bladder was separated well, only there were some detrusor lacerations. Now the mother and baby is doing well. This is the specimen of the OH, and this was the brachydactyly, isolated brachydactyly affecting the fetal hand. And this is really a rare encounter. It was 23-year-old primigravida, non-consanguineous marriage. She came for the second opinion with the finding of fetal ascites and polyhydramnios. USG at our center confirmed the same. There were no congenital anomalies. As Sumit said, there is something for polyhydramnios, there is something beyond GI atrasias, NTDs and GTT. Everything was normal. Fetal movements were normal. It was quite a tense polyhydramnia, so amnioreduction as well as fetal ascitic tapping was done. We sent amniotic fluid for microarray, and preserved DNA for further investigation. Microarray turned to be normal, and the fetal ascitic fluid was transudate. So these are the clinical, the imaging features. There was tense polyhydramnios as well as there was ascites, fetal ascites. 1 week later, again the polyhydramnios felt and even the ascites felt. Repeat amnioreduction and ascitic tapping done. And the subsequent ultrasound showed nephromegaly more than 95th centile, foot length was more than 95th centile, there was macroglacia along with the polyhydramnios and fetal ascites, and the diagnosis of Beckwith-Widman syndrome or storage disorders was kept. And she was 30-31 weeks looking at the polyhydramnios. The steroids were given for lung maturity. So this was nephromegaly with normal echo pattern, and the renal length was above 95th centile. This was macroglosia. Patient came in preterm labor at 31-32 weeks. She delivered vaginally. Baby boy of 2.8 kg was born and shifted to NICU. Baby's NICU stay was very stormy. It had RDS, repeated episodes of hypoglycemia, hyperbilirubinemia, and postnatal ultrasound again confirmed nephromegaly and ascites. Almost after 1 month stay in NICU, baby discharged with normal clinical and lab parameters. So this was the immediate postnatal picture of the baby with macroglosia, the protuberant abdomen, and the nephromegaly. The preserved DNA was sent for whole exome sequencing which turned negative for any mutation for Beckwith-Widman syndrome as well as storage disorder. And finally, the methylation specific deletion and duplication analysis study done which suggested Beckwith-Widman syndrome. So Beckwith-Widman syndrome itself, it's not a syndrome itself, it's a spectrum ranging from many findings like macroglosia, ear pits, ear creases, omphalocele, hemiatrophy, cardiac anomalies, organomegaly, polyhydramnios, placentomegaly, like that. This is a baby at present 2.5 month old and doing well. Thank you.
Thank you so much, ma'am. Before we move to the next session, that is the panel discussion, I have some few felicitations to make. On behalf of MSBRI Solapur chapter, we would like to felicitate Dr. Vimal Sahani sir. I request Dr. Vaibhav Meru to kindly felicitate him. Dr. Ajay Bhagwat, Dr. Sajid Sayed, Dr. Naseem, please come forward. We would like to felicitate Anirudh sir. He has been on the Zoom meetings since last 2 weeks and troubling us, or we troubling him, we don't know. So this is a small token of remembrance from Sholapur. You will always remember this. Also to be felicitated, Shilpa Satarkar ma'am. Ma'am has really enjoyed the food and the shopping here in Sholapur, so this is just a remembrance for you. Dr. Sujit Kondkar, is he in the hall? Also, Dr. Veena Panath. She left. Okay. Okay. I request Dr. Chaudhary sir to kindly felicitate Jyoti Tapadia ma'am. Now we shall begin with the video, the launch video of the Mindrate machine, that is Consona. Kindly run the video, please. This is a video launch. Okay, so there's a small presentation.
So good afternoon all. Actually, in behalf of Mindray, we thank the entire SFM team to giving us an opportunity to launch a new product, Consona. So Mindray India has come up with a new system or a new series called Consona with the inherent and the revolutionary platform on Zonare. So I'll just quickly run some slide. This is the ZST platform that is known as zone sonography, which is a platform apart from the conventional ultrasound system. It giving us an excellent 3D, 4D imaging in terms of fetal imaging is concerned, the pelvic 3D is concerned. Many automation tools that nowadays we take for fetal CNS, even for scanning the fetal face, we have something launched called Smart Scene 3D. So you can see this video, you just take a single plane and press the Smart Scene, and the ROI box or the 3D ROI box gets automatically adjusted, and you can get your 3D image very precisely. So not only for CNS, we have for face, even for pelvic floor imaging also we are utilizing this. So this is the unique pelvic floor, that is for pelvic floor dysfunction we can use an automation technique called Smart Pelvic. And not only now, most of us is familiar with this technique called autofollicular counting, which was generally coming in the TVS volume probe. And with this machine, we have launched in normal 2D TVS probe also. So routine gynec studies also we can count our follicular count. So this is another new application, like we call it Smart View, where you can, it is basically for hands-on scanning technique. You scan your plane and machine will detect your scanning accuracy and saves the image automatically. And see, Mindray is always focused on, shared service mindset. So in this machine here, we are also having the shear wave technique, that is a 2D shear wave in small parts as well as for liver. And please run the video. So since we are not displaying the product, we'll just present the product in the video presentation.
tough to resonate. Thank you. Now I invite the panelists on stage. Dr. Shilpa Satarkar, Director of Antarang Sonography and Color Doppler Center, Aurangabad. Dr. Ajit Gandhi, Certified NT Examiner, FMF London, since 2009, practicing fetal medicine, and interested in prenatal diagnosis, perinatal genetics, interventional procedures, and high-risk pregnancies and endoscopic surgeries. Sandeep Kulkarni, sir, practicing pediatrician and neonatologist since 1994, Director of Span Critical Care Center Private Limited. Sir, please welcome. Sajid Sayyed, sir, accredited FMF operator for Doppler studies, pre-eclampsia, risk assessment, trained FMF operator for NT assessment. Sumit Chamaria, sir, practicing fetal medicine. He is a student of KEM Mumbai and has completed his fellowship in medicine from Mediscan Systems. Bimal Sahani, sir, will be taking us through this discussion as a moderator. Over to you, sir.
Thank you.
Friends, please be seated. This is going to be a really interesting session and too much of discussion, too much of exchange of ideas, and let's see who wins.
Yeah, it's really nice to still see so many people waiting at the fag end of the day. And I have a very eminent group of panelists here. Dr. Ajit Gandhi, a very senior obstetrician. Shilpa Satarkar from my own town, who's like evolved into one of the finest teachers of fetal ultrasound in the last few years. Dr. Sandeep Kulkarni is a pediatrician. Sajid Sayyed, radiologist and imaging person with special interest in fetal ultrasound. And Dr. Sumit Chamaria, who's a fetal medicine with a background of obstetrics. Now you need a team of this kind when we are discussing something like fetal growth restriction. It's very important. Now, what is happening is, as far as management of fetal growth restriction is concerned, we have actually three types of people. So there are three groups, I would say. There is one group of people who have a complete understanding about the concepts, but they do not follow protocols. There is another group which has very limited understanding about the concepts. They don't know what is perfusion, diffusion and all that, but they say, okay, this is the staging, this is protocols, and they follow protocols and do that. And group C is where they have concepts also and they follow protocols also. But that is a rarity. There are very few people who belong to group C. Now this group A is wonderful in some complicated case. Very good with that. But if you see the end result, if you look at the overall success in these groups, you will find that group B, the overall results will be far better than group A, even though they understand all the concepts, but because they don't follow protocols. So it's all about following protocols. Now, I'm going the other way around. My first question actually is to a pediatrician. Because we need, the gravity of fetal growth restriction is understood if you really know what are the issues that an FGR baby can have. So I would like to start with Dr. Kulkarni. What are the immediate postnatal and long-term abnormal outcomes in preterm FGR babies?
Right. Thank you. First of all, thank you for inviting me to this forum. And I'm really seeing myself very small person over here. So, as we see, preterm and small for gestational age or fetal growth restricted babies do face some challenges in NICUs. Usually these babies land up in NICUs, and outside there are many cases they have they have died in utero, or they suffer many cardiac, respiratory, neurological complications during the stay of NICU. First thing is that they need a large amount of oxygen, and for a long-term basis they need oxygen. And second thing is they need gavage feeding for a long term, but they have problems regarding necrotizing enterocolitis because of hypoxic damage to their intestines. And second thing is cardiac complications such as there is PPHN, or they can have cardiomyopathies, or even respiratory problems such as bronchopulmonary dysplasias, where the babies need oxygen, but we have to balance oxygen supplement in these cases. And metabolic conditions such as hypoglycemia, hypocalcemia, hypothermia, and they need to be a lot of monitoring. Many of these babies also have polycythemia, which can give rise to complications such as neonatal convulsions and hypoxic damage to the brain, and even renal insufficiency is also seen in these cases.
Even long term, these babies, okay, they have gone from the NICU and everything, can they have problems later on in life?
Yeah, definitely, because as they have suffered a lot in NICU and in utero also, their long-term complications such as immature lung complications, the lung development is not very complete, so they may come back with recurrent respiratory infections, or they can have insufficient hypoxic damage to the brain, so they may come as cerebral palsy or other metabolic neurological complications.
Sir, can I add?
Yeah.
Well, see, the these babies, we need to mention. The small growth restricted babies, they have the learning disabilities, there are cognitive abnormalities, the attention deficit, and sometimes they may have autistic behavior. These kind of outcomes are known with the severely affected babies, growth restricted babies which are delivered.
Type 2 diabetes mellitus, again they become prone to,
yes. Late metabolic syndrome.
Late metabolic, cardiac problems later on, yes. So, we've started with a very negative question, we've talked about so many things that can happen. Now, Dr. Ajit Gandhi, you one of the very senior persons in the field of OBGY. I just want to ask you, so how important is it to diagnose FGR? And I also want you to say that are we doing enough for that?
Yes, there is no doubt that we need to diagnose FGR. Just now we have seen what is happening with those babies. Now the part 2, are we doing enough? I'm sorry to say, it may hurt some people, but then when we try to look into what we listen, what we do in the academic stage is not translated into the practice. Most of the reports we see are, please excuse me for if I'm using any offensive word, most of the reports which we see are funny. Say for example, the BPD shows 2 weeks growth lag. What does it mean? I don't understand anything about growth lag of 2 weeks. The growth lag of 2 weeks at 20 weeks is a sinister thing. But maybe at 34, 36 weeks, it's not a much serious issue. But then it doesn't convey the exact meaning. Or say the casualness about the reports. I see some reports, the growth chart is printed in the images. This very much thing, this shows that you haven't gone through the growth profile of the baby. Just you have put whatever has come on the screen into the print, and that's all. Most of the reports are like, whatever you get on the screen, just that is put on the paper. If I see something different, can add to it.
No, sir. Very true. And not just from...
If you see a series of reports done by the same person, you will find different EDDs assigned to the same baby. How this can happen? And since the ultrasound has come so many years, this has been discussed thousands of times on this ultrasound stage, that LMP and assigning date. And in spite of that, most of the reports, even done by the same person, contain the different dates. What does it mean? There is no interpretation applied to whatever information you get in the screen. It's just, I would say, a technician's job, that you take the paper the material on the screen and just put it on the paper and give it to the patient. The clinician is left to the interpretation part, and then he will try to sort out what information is there in this report. So I think hardly very few reports, they show the growth profile. I doubt how many radiologists, they go through the previous history of the patient, previous history of the previous record, the ultrasound record, whether they go through the previous scans. I really doubt it.
Yeah, sir. I feel there is an overall neglect towards fetal growth restriction. See, 26% of Indian fetuses are SGA.
Sir, may I add?
Yeah.
So, Shilpa, may I add something, sir?
Yeah.
Right now I'm the National Coordination for Samrakshan. It is a project of IRI where we are doing preeclampsia and FGR screening. So what we have found that in India there are 30 million births per year. Out of that, 10 to 15% are FGR, means 3 to 3.5 million fetuses are FGR, and they are not detected properly. And that's why the perinatal mortality of India is the worst. We are first in the perinatal mortality. It is around 35 per 1,000 births. So if we all start doing the FGR screening according to the protocol, FGR management, FGR diagnosis according to the protocols, we are going to definitely have a very good results in saving our children.
Thank you. Now the thing is, I think opened a Pandora's box. Now this is something which we all agree that only recently in the last 2-3 years we have started taking FGR very seriously. You know, now if you look at this chart, this is Indian prevalence. You look at T21 here and look at severe FGR. But if you go to any conference, you will find one half day on NT, half day on neuro, 1 day on cardiac anomalies, and somewhere on Friday evening 4:30 there used to be a small talk on fetal growth restriction. This was the common scenario. See, there were 200 people in the hall for all the anomalies since we were talking about it. There's 25% of that remaining for FGR. I think the most important talk in this whole day, the most important was this panel discussion, because this is something which the volume is too high. The volume of FGR is too high. So that is the kind of neglect we have done. But yes, from the Society of Fetal Medicine, we have seen, we've taken it up very seriously. I think I've given about 200 times I have given lectures on FGR. I think everybody has heard on YouTube or somewhere. I've gone about, banged and tried to speak on FGR and FGR only. To the extent that people started asking me, sir, were you born FGR? I said, no, I was not born FGR. Why are you, you take FGR very, very seriously. But I felt that the need of the hour was that this country needs more and more time. Because like sir said, same thing is being repeated in every event. But still, eventually there is no point if you listen and go back and you're not going to try to put it into practice. If there is a fetus with a 34 weeks gestational age, your parameters are 31 weeks. If you call it as 31 weeks, you have lost an opportunity to call it as FGR. Because you have not correlated with the CRL. The CRL in the first trimester was corresponding. So you have to say this is 34 weeks of gestation, but today the biometry is saying 31 weeks. That means it is less than the 5th centile, and that is why I am calling it as FGR. Your ultrasound age is not the gestational age of the fetus. The age of the fetus is not going to, if the fetus was 10 weeks, 25 weeks back, the fetus has to be 35 weeks today. If the fetus is looking as 30 weeks, does not mean that the age now is 30. So that is the most simple thing for FGR. Even if you date properly and if you don't keep changing your EDD and if you date the current pregnancy as per as the CRL that or the corrected dates you have done a great job. Forget Doppler, that will come later. That itself is one of the most important thing, and I thank you, sir, for taking out this point because that's a very, very important thing here. And nobody takes it. It's not about the people who are diagnosing. Even the people who are managing also do not take it very seriously. Mild IUGR, moderate IUGR, anything is going on. We talk about interpretation. The interpretation of Doppler is such an important thing. Radiologists will say, okay, I have given the PI is increased, the story ends. The obstetrician says, the interpretation should be provided. They will call the radiologist and ask, काय करायचं मग थांबू का अजून एक आठवडा? No, I think we all need to understand the interpretation because it's a teamwork. We need to come together. We need to provide information. We need to talk to each other and so that we can help the baby. Now, Shilpa, what is a small fetus? My question is very, very clear. I'm not talking about FGR. I'm saying what is a small fetus? And then you tell me what is FGR.
Okay. So the fetus, by definition, the fetus who is less than 10 percentile, EFW, it is less than 10 percentile, then we call it as a SGF, it is small for gestational age fetus.
Okay.
And then when these SGA fetuses can be what can be the cause for the fetus to be small? It can be a constitutionally small fetus. It can be because of some infections.
I'll ask you one question in between. Okay. Now you have a fetus less than 10 centile. So can you call it as FGR?
No, I need something more to call it as a, between 3 to 10 percentile it is a SGA, but if it blanketly, if the EFW is less than 3 percentile, yes, I'll call it as FGR.
Okay. So, but all small fetus is not FGR.
No.
So now what is FGR?
So FGR is basically a process where the fetus is not able to attain its biological potential to grow because of some pathological process. And these pathological process, we cannot actually identify, means we cannot exactly judge what is the growth potential of that fetus, and therefore we use the fetal size as a proxy to identify the small fetus, pathologically small fetus.
So, because we don't have any other option, so we are using size as a proxy. So, size can also be deceptive, but then there is nothing else, so we are using size as a proxy to determine the growth potential of that. And but then, as you rightly pointed out, this can be so small. So, yes, sir.
See, all this 10 centile, 3 centile, these are not watertight compartments. That we have to understand. If you find a 4th centile baby, this is not FGR, it doesn't go so. So this baby is going towards FGR. You have to be, if it is a 10th centile baby, you have to be under thorough surveillance and you have to decide whether this is a SGA or FGR baby. And that way you have to go. It's not, because if the baby is 20th centile and now this baby won't have FGR, it doesn't show. These are just the guidelines or the non-watertight compartments where you are likely to find the most affected babies or where you will be picking up the most of those FGR babies.
Yeah, because more number of them would be in the less 10, but then those who are more than 10 centile also could be FGR, and not all who are less than 10 centile are FGR, they could just be constitutionally small. So how, okay, I have a fetus with a less than 10 centile. Now, how do I differentiate whether this is constitutionally small or this is an FGR?
So we have to find out the pathological reason in that. So we have to evaluate for, and means we have to rule out that there is no infection, there is no aneuploidy, and then we have to, in the last trimester, we have to do the Dopplers in these fetuses to find out the pathological process, and with Dopplers, if there is alteration in the Doppler, then we say that it is an FGR fetus.
No, but do you want to differentiate between the two? Do they behave differently?
Yes, definitely, sir. Because FGR is now associated with some pathological process, we get placental insufficiencies in the signs of Doppler, signs of placental insufficiencies. Then because of placental insufficiency, the fetus is compromised, and then we get the signs of Doppler signs of fetal adoption are there. And these fetuses, because now they have this alteration in the Dopplers and other things, they are very much prone to go in complications. And usually a very poor perinatal outcome is there, and IUFDs are very common in these fetuses. And we have to have a very close monitoring in FGR fetuses. Pregnancies usually are not to be prolonged beyond 37 to 38 weeks. While SGA fetuses, it is an constitutionally small, the placenta is, having no disease thing, there are no signs of fetal Doppler adaptation. And these pregnancies usually being small constitutional and no pathological processes there, we can prolong them up to term.
Thank you.
Well, let me add one point.
Yes, sir.
This is more of a retrospective thing, whether this baby is SGA or FGR. Any baby which you find, small baby, you need to follow it till she comes out, till the baby comes out. SGA baby is not immune from developing FGR. Even a SGA baby can develop a FGR at any point of pregnancy. It could be a late FGR, it could be early FGR. So taking it as a SGA or is more of a retrospective rather than a prospective thing. And I see today Doppler is normal, and so this is the SGA baby. It doesn't go that way.
Yes. So SGA is not it's not the final this thing. Like if at one stage, if you say this is SGA, doesn't mean that now you can say, okay, no problem, this is SGA because the Dopplers are normal. No. If it is an SGA, it can. So SGA can go into FGR and AGA can become SGA. So all these things are the ones which you need to follow. Dr. Sajid, you have a fetus less than 10 centile, she said. She said it is very important we need to differentiate between the two. Now, you scanning, you find a fetal weight. Now, how will you say that, no, this is FGR, this is SGA? In simple terms, what are we going to do?
Good afternoon.
Yeah.
First, I need to distinguish whether between FGR and SGA, I need to determine whether this fetus is at risk of bad perinatal outcome. And for that, I have to look for additional signs of any adaptation in the fetus. And I will need additional data regarding Doppler studies in this fetus.
Suppose the fetal weight is less than third centile. Is it SG or FGR?
By a solitary diagnosis, this is a FGR fetus.
Okay. So fetal weight less than third centile, forget it. Whether Dopplers are normal, abnormal, it is FGR. But now this is between the third and the 10th centile.
I will need a Doppler studies.
You need to do Doppler, okay. So what criteria will you use?
A contributory criteria including uterine artery, PI greater than 95%, CPR less than 5 percentile PI, and uterine artery, umbilical arterial PI more than 95 percentile.
Yeah. So if you have fetal weight between third and the 10th, if it is less than third centile, FGR. Between third and the 10th centile, you have actually any Doppler which is becoming abnormal, you will call it as FGR. And if it is between the third and the 10th centile and your Dopplers are normal, then we end up calling it as SGA. Fine. Now, Sumit, this whole thing about early onset and late onset, is it really important to classify them as early onset? And how are they different from each other?
Okay, so it's utmost important to, we have to classify them as an early onset or the late onset. In simpler terms, the ones which we see earlier than the 32 weeks, we call them as an early onset IUGR, and later than 32, 34 what we get are the late onset ones. Now, why there is a need to differentiate these two? Because the pathophysiology, the management, the outcome, everything differs. In the early ones, how to manage is difficult. Like if we have somewhere around 28 weeks gestation and early onset IUGR, the management becomes difficult.
Because of prematurity.
Prematurity, NICU, the quality of NICU which we have in tier 2, tier 3 cities, so the management becomes difficult. While for the late onset IUGR, as you said, as madam said, the diagnosis is difficult. We end up in missing these cases. So the difference between the two has to be made, and accordingly we need to take care of the fetuses. So the problem in management, the size of the fetuses, the pathology. In the early ones, the placental pathology, placental disease is high in the early onset ones, and as a result of which we get the high umbilical artery resistance in the early ones, while the same might not be true in the late onset IUGRs. So yes, we have to differ these two, and 32 is a good cutoff for the.
Is 32 arbitrary cutoff, or you can say this is the gospel truth? Okay, let's diagnose before 32 weeks is early onset and diagnose after 32 weeks is late onset.
From ultrasound point of view, when we see the Dopplers, we rely more on the umbilical, the ductus venosus, the ductus resistance. So till 32, we rely on the ductus venosus, and after 32, the CPR, the uterines, and the other things. So 32 is a good cutoff.
Okay.
Well, can I add?
32, yeah, yes, sir.
Well, see, the FGR definition has gone through many changes. Since last 30 years, the absolute weight, then the percentiles, and then the, and finally, some consensus has been drawn in, I think, 1916,
The Delphi
Delphi consensus, and most of the countries, and most of us are now following this Delphi consensus, which they have divided it into 32 as a cutoff. The reason is the babies which develop, the fetuses which develop the early FGR have a different kind of behavior in utero, in the Doppler as well as growth, compared to the babies which develop at the later gestational age. Previously, most of this cutoff used to take as 34. Now the consensus group has taken it as 32 weeks.
So less than 32 weeks, it is the nutritional deficiency which actually becomes the important parameter. After 32 weeks, it is the respiratory deficiency which is more important, and that is the reason most of the time, when we talk about 32 weeks and before, these early onset fetuses, like I was talking yesterday also, because they can tolerate hypoxia for a long period of time, eventually the heart will have a lot of time, the heart will function more, and that will get reflected in the ductus venosus, like Sumit said. Yes, so early onset, the ductus venosus becomes the critical endpoint. Now in the late onset, first of all, everybody has to move this out of their mind that in every FGR, it is the umbilical artery which will become abnormal, then it will become absent diastolic flow, then it becomes reversal of diastolic flow, then the ductus venosus is normal. Very true. This cascade is for early onset FGR. In late onset FGR, you may have a normal umbilical artery. The umbilical artery in most of the cases of late onset FGR is normal. And that is why the CPR becomes an important thing. The MCA becomes important in the third trimester. Okay. So now there is a consensus definition of early onset FGR and late onset FGR. We have the ESWAG, the FIGO, and all and actually it came from the Delphi consensus, which actually everybody is following. So what is the consensus now to call it as, for defining an early onset and late onset? Please give us both. Okay. For everybody to, I'm sorry, I have put it on the slide also so that, people can take a look at it. Yes.
To define the FGR, there are two factors. One are the solitary and then there are the contributory. In the early onset, when the AC or the AFW is less than 3 percentile, we blanketly call that as early onset FGR. And when in the umbilical artery we get absent end diastolic flow, that is also an indicator of FGR, early onset FGR. And the contributory factor, when we have to use this contributory factor when the EFW is between 3, AC or the EFW is between 3 to 10 percentile. In that case, when the uterine artery PI is more than 95th percentile or the umbilical is more than 95th percentile and the CPR is altered, then we say that these are the contributory factor and these contribute to the early onset FGR. While in the late onset FGR, again the solitary criteria is AC or EFW less than 3rd percentile, and in the contributory factor at least 2 of the 3 should be present. First is that either AC and EFW should be less than 10 percentile, AC and EFW crossing more than 2 quartiles, and the Doppler we get either a uterine artery PI of more than 95th percentile or the CPR values of less than 5 percentile. So these are the consensus definition to identify the late and early onset FGR.
Yeah. So for all practical purposes, what we spoke in very simple terms before, that you have an AC, AFW less than third centile, or then you have it is between the third and the 10th, and you have these Doppler abnormalities, we take it. Only thing is that in the late onset, they have added this crossing 2 centiles. Now 2 centiles, 2 quartiles. Now each quartile is 25 centiles. So the whole concept is that if the fetus was growing at the 80th centile and now has come to the 20th centile. Now because it is more than 10 centile, we will say it is normal, right? But it has gone from the 80th centile to the 20th centile, so it has dipped by more than 50 centiles, and that also is one of the criteria to label it, especially for the late onset FGR. Now, Gandhi sir, now I am coming to the obstetrician's point of view. We talked about where the imaging people are going wrong. I want to ask you whether the management and decision making in FGR, are people following protocols, or is it still based on personal experience? Or acquired wisdom, which is a very difficult thing to define, where the wisdom has come from.
Yeah. Well, see, quantification or protocolization has its own advantages. We developed those skills before all these quantifications and protocols were developed, and by virtue of understanding the whole pathophysiological process, we were able to do the decisions in these babies. But then I would agree with you that following a protocol is more advantageous, and the protocol has a clear advantage of what I say that it is stage 2. It's stage 2 for the person sitting across me. If I say umbilical artery is absent and DV is antegrade and circulatory redistribution, all those things I put in the report, the person sitting next to me may not understand the whole pathophysiological process of what I am saying, and probably may go in a wrong way. Then putting it in the protocol will have the advantage. The disadvantage is sometimes, though we have defined the stages, there are some gray areas between those stages, say the stage 1 and stage 2. It all depends on how thoroughly you acquire the data, how thoroughly you get the waveforms, and how you interpret them. That all decides what you put in the stage.
So this Barcelona staging everybody is talking about.
Yeah.
So I wanted to ask you whether obstetricians also know about this staging and they do follow it, and
well, see, very few obstetricians are aware of that. But then I'll explain this Barcelona staging.
Yeah, I want you to explain, sir.
See, it's very simple. The main vessel which you look at is the umbilical artery. The other vessels which help you to differentiate between the stages is the middle cerebral artery, the aortic isthmus, and the ductus venosus. Now, in all this, the culprit, जिसने सब ये मिस्चिफ की है, उसको भी देखना जरूरी है, the uterines. Okay. So now, if we look at all this, when the FGR is a result of nutritional deprivation followed by the defective gaseous exchange. These are two overlapping pathophysiologies which operate when the baby becomes growth restricted. Okay? So now what happens? First we look at the culprit, the uterine artery. Now uterine artery fails to supply the adequate amount of blood to the placenta, fails to supply the adequate amount of nutrients, the oxygen, the gaseous exchange. As a result, what happens? The fetus tries to get that, and in that process, see now the second thing which there are two things which we look into the FGR. One is the baby size, and we have come to the consensus that less than 3% weight is very likely to have a FGR. Now second part 2 is Doppler. What does Doppler tell us is about the vascular pathophysiology. Now vascular pathophysiology is sensitive to the fetal oxygenation. Now, when there is a oxygen deprivation, when there is a inadequate oxygen supply to the fetus reacts in a vasoconstriction way. Whenever there is a vasoconstriction, see now what is a diastolic flow? Let us understand what is a diastolic flow. So when the heart contracts, it pushes the blood into the vessel. Now all of us, we know that the blood vessel has got an elastic coat and a muscular coat. See, in a healthy individual, when the heart pushes the blood into a great vessel, the elastic coat, it just expands. It's not that the flow goes like this. When the heart pumps the blood, the elastic coat will allow the vessel to expand. Before the beginning of the next cardiac cycle, this elastic layer of the vessel will press the vessel and the blood will move forward. Now this forward movement of the blood we see in the diastolic flow. Okay. Now when there is a vasoconstriction, the muscles of the vessel, the tone of these muscles will increase. As a result, the expansibility of a vessel following the contraction will be less. So that it results in an increased resistance of the vessel. Now what happens is, where we see it is the decrease the diastolic flow. Now we quantify this. We put it on the centiles. If we look at the umbilical artery, the umbilical artery will have something like a 95th centile. No, PI value of 95th centile. Now remember all these indices, SD, the PI, the RI, all these, increase means increased resistance. Decrease means decreased resistance. So these, the values goes this way. So now when you find that the PI is increasing, it's going towards the 95th centile, that means the resistance of the vessel is increasing.
Sir, let's not get into the hemodynamics, because that will take a lot of time to explain. Okay. I think we go pinpoint to this thing that, okay, because we are going short on the time also. Can we sum up, this, we talk so much about the Barcelona staging. What does this staging is telling us actually? In the sense, how do we define as stage 1, stage 2, stage 3 and stage 4?
There I am coming to.
Yes.
This is a stage 1. What is stage 1? You find that the uterine artery will have a high resistance, the PI will be above 95th centile. You look at the umbilical artery PI will be above 95th centile. So this is the stage 1 where there is a beginning of the placental insufficiency. Now in the stage 2, the pathophysiology still worsens, and you find that it becomes an absent diastolic flow. What we call it is a ADF.
Yeah, that is the stage of severe placental insufficiency.
Severe placental insufficiency. That is stage 2. Stage 3 is where there is a reversal of the flow, but still the antegrade A is maintained in the DV.
Yes.
There is some retrograde flow into the aortic isthmus. Okay, because the left ventricle fails before the right ventricle. And as a result, there is a retrograde flow into the aortic isthmus. That is the stage 3, or the stage 3 is the beginning of acidosis. Stage 4 is a decompensation, where the right ventricle also fails. As a result, the right ventricle fails to pump the blood forward. There is an increased afterload, and the pressure is transmitted to the venous circuit, and that we see as a negative A wave in the ductus venosus. So that is the last thing which happens before the fetal death. That is the stage 4, or the stage of circulatory decompensation.
And because we don't have computerized CTG now, only 1 or 2 centers have it. So do you feel the conventional NST that we use is good enough?
This conventional NSTs will still pick up this abnormality. There will be a loss of BBV less than 3 millimeters. It will be more of a straight line. The conventional will pick up, but the computerized will do a better.
Yes. Now see, we've seen what are the staging. Now then it comes to decision making. Now it's this is a two-step approach. One approach is first you identify fetal growth restriction. Second is decide when to deliver. The only management that is there for fetal growth restriction is getting the baby out at the right time. Neither too premature nor too hypoxic. Definitely we try to avoid it to be acidotic. So what actually you are doing in this decision making in simple terms is you have to have a mental fight between prematurity and hypoxia. At this moment, what is more dangerous for the baby? Is the prematurity more dangerous or the hypoxia more dangerous? Because every single day the fetus spends in utero, the morbidity, before 28 weeks, the morbidity reduces by 2%. Between 28 to 32 weeks, it reduces by 1%. So every day that fetus spends in utero. So we want the fetus to spend as much more time as possible in utero. At the same time, we don't want the fetus to become acidotic. So that is a balancing act that you need to do. And I explain it, I always do it, you must have heard this way I say this, is in simple common man's language. You are in a building which is 20 floors and the building has caught fire. Now whether to jump or not jump will depend upon what floor you are on and how severe is the fire. And then we also have the safety net. We also have to think how good is the safety net, and safety net is Dr. Kulkarni here. The NICU. So you need to take all these things into consideration when you are trying to say. So suppose if I am on the 14th floor, so I am using it as 26 weeks of gestational age, and there is a fire which is coming from down. The fire has reached the 5th floor. See, there is no elevator. Fire होने के बाद सब elevators बंद हो जाते हैं. So you have to climb down. Now you are on the 14th floor, there is a fire which is there up to the 5th floor. Will you jump or will you not jump? What is more dangerous for you? Jumping from the 14th floor. You want to jump from the 14th floor, anyway you will die. You will die if you jump from the 14th floor.
Don't jump.
You don't jump.
Climb down.
Yes, because the fire is still the 5th floor, you have checked it, like Dr. Sir said, that it is, it's there, it is just showing you high resistance flow in the umbilical artery. It is just up to the 5th floor. So what you do is, you start climbing down. You want to go as down as possible and then jump, so that your chances of dying because of jumping is less. But at the same time, when you are decided that I am going to climb down, you will have to keep every floor you come down, you open the window and see where the fire has reached. So I climb down to the 12th floor and then I see again and I realize the fire has gone to the 7th floor now. I will jump or I will not jump. I will still wait. And I come down to the 10th floor. Now the fire has reached the 9th or the 10th floor. Now, whether I will jump or I will not jump, I will jump. Because if I don't jump, I am going to get engulfed with the fire. So, I have reached 30 weeks and this has gone already into a stage 4. The fire has become so severe that anyway, if I still want to climb down, I am going to anyway die. But 10th floor is far better than the 16th floor, and I keep some faith on my safety net and I jump. Fine. So this is what the staging helps you also about it, So the staging is telling you about the severity of the fire. It's telling you about the severity of the fire. The gestational age is telling you about the floor you are coming down. Now suppose I am on the 3rd floor and somebody lights a cigarette and I'm smelling some smoke coming, I will jump or I will not jump? I'll jump. I don't know. You know, there are not many floors for me to go down. I will jump because there is, you know, there is a fire. I don't know what is the severity of the fire. I don't know. And there is a safety net. If at all, maximum what will happen? I will break a finger or something. That's all, nothing else. Do I take that risk of trying to come down and check again? By the time this is what happens in late onset, this thing, it may cut bulke, there is no DV, there is no moving from absent diastolic flow to reversal of diastolic flow, and all that thing doesn't take place in late onset FGR. So if I have reached 37, 38 weeks, fine, I have got a CPR which is less than 5th centile, I'm finding Doppler abnormalities, I will take a call. This is the methodology that you need to take on a case-to-case basis, and that is where the staging helps. That is where the staging helps. Like sir said, it is the, you know, he talked about two things. He talked about nutrition and he talked about the respiratory, this thing. So, as I said, if it is late onset, which Sumit said that occurs after 32 weeks, the baby has already gained enough weight. It's already gained enough weight. You may not necessarily find that it is a, you know, it will not necessarily go into a severe form of a small fetus. And that is where, that is what the Barcelona team also says, that okay, you have any of these issues, they talk about using the same thing for both early onset and late onset. I personally feel that yes, in practice, this thing is very good for early onset FGR, but late onset, not necessarily all the criteria come into picture, but because people still feel that yes, umbilical artery, there was a time umbilical artery karne, agar normal hai to nobody used to do the MCA also. That was the only thing that was done. Now we have realized that it doesn't happen like that. So the Barcelona protocol also tells you about the stage also, and they say that if it is stage 1, then you deliver at 37 weeks. But if it is stage 2, you can deliver at 34 weeks. Stage 3, you can deliver at 30 weeks. Stage 4, you can deliver at 26 weeks. Because stage 4 is, like sir said, it is just before demise. So you have this 26 weeks. Again, also depends upon the quality of NICU that you have. But if it is stage 1 and you have not reached 37 weeks, you will monitor weekly. So you will come one floor down and every time you will go and check. But if it is stage 2, then you will monitor bi-weekly. If it has not reached 34 weeks, you will monitor bi-weekly. So, जो stairs रहते हैं, वो directly ऐसा एक floor नीचे नहीं रहते. They are like this and like that. So in between also there is one window. So that window you can check in. So every now and then, so it is all about monitoring. It's all, fetal growth restriction is about 3 steps. One is you're identifying, second is deciding on the surveillance, how closer follow-up that you need to do, and the third thing that comes into picture is then the final decision to deliver, what is the cutoff and all. So this is a complete layout of the Barcelona thing. They have also given us what is the mode of delivery that you can. The biggest problem everybody says is, since the time you say that Doppler for all and all, it has increased the number of cesarean sections. But the Barcelona protocol does not say that stage 1 you do an LSCS. They are saying that yes, you induce labor. But we feel that there is any Doppler abnormality, we need to do an LSCS. And yes, if we go by that, then definitely a regular use of Doppler is going to lead to that. Okay, ISWA guidelines and all, they are actually telling the same thing, but yes, it becomes more important for late onset decisions. In late onset FGR, there are changes of hemodynamic redistribution. So CPR will go less than 5th centile, MCA will be 5th centile. You need to put them on strict surveillance and follow-up. You monitor for dipping CPR, look for fetal breathing movements. The brainstem is very responsive to hypoxia in the third trimester, and so you look for fetal movements. That is where the biophysical profile comes into picture. If you have an abnormal biophysical profile or an abnormal CTG, then go for delivery. Otherwise, consider delivery at 38 weeks of gestation. And this is exactly what the ESWAG guidelines also say, that between 36 to 37 weeks, 6 days. But if you have an umbilical artery PI or an AC less than third centile, you need to deliver. And if there are, after 38 weeks, if there are any signs of cerebral redistribution or any other feature of FGR, then you get this baby out. But the problem comes with the AGA fetus. I was discussing with sir during lunch that, sir, are all AGA fetuses, can AGA fetus be FGR?
Yes, do.
Exactly. So the 10th centile is not the absolute marker. You can have an AGA fetus which can be growth restricted, and this is one study which shows that, of course, the majority of the FGR were SGA, but then there is still a lot of FGRs which were AGA. This is from the Leona Poon, that is the Nicolaides group study, where they found that majority of preterm stillbirths are SGA, but majority of term stillbirths were actually AGA. AGA means 10th centile that we are using as the cutoff. Now, all this we talk about 2 quartiles going down or estimated fetal weight. The problem is, what chart are you using? Now this example is, this baby has a fetal weight of 1917 grams. Now if I put it in the Mediscan charts, it's 23rd centile. Hadlock chart 4.6 centile. That is, here it was AGA, in this chart it becomes SGA. Intergrowth, it is again AGA. WHO, again it is SGA. So that is, so we don't have a final answer for that. But yes, we need to put it on a standard chart. I've used Mediscan all my life, but then we realized that, okay, Mediscan chart is a population reference chart, it is not a population standard chart. Now, intergrowth is a population standard chart. It also has its own limitations, but as of today, intergrowth or Hadlock is a standard chart which you can use for that. Dip in growth velocity. That dip in growth velocity has become so difficult because scans are done in different centers. NT done somewhere, dating done somewhere, anomaly some, and for the growth scan the patient has come to you. How do you get the growth profile? So many people have not even written the biometric measurements. They have written BPD 20 weeks, 2 days. Now, I don't know what chart that has come from. So standardization of planes and measurement is always questionable. Centers use different charts, and that is a problem there. So with all these things as regarding the estimated fetal weight less than 10th centile for a gestational age, I want to ask all my panelists, do you agree that a scan at 30 to 32 weeks and 36 weeks should be a part of protocol in every pregnancy? And the second part of the question is, should Doppler be a part of all growth scans? We can have different opinions, no problem. Because this is a controversial topic. I would start with you, sir. What is your opinion?
Well, see, ideally, yes. Practically, there are some problems. And how we have dealt with this is, at the anomaly scan, we look at the growth centile. The babies, we show the growth at less than 50th centile at anomaly scan. We definitely will scan them at 20 at 30 weeks. If they have any high risk, we have a real-time high risk allocation protocol. The moment patient becomes high risk at any point of the pregnancy, or high risk because of the prenatal factors, or because of her characteristics, these are the patients we will definitely will go for this scan. With the very low risk patients, a multipara who had a normal obstetric history before, her scan is normal, her growth at 20 weeks shows 70, 80th centile growth. These are the patients whom we can skip on a patient-to-patient individual basis. But as a protocol, we would do that.
Okay, and do you feel Doppler should be done in every scan?
Yes, of course.
Even if it's an AGA?
Yes.
Sajid?
if first trimester scanning has revealed some preeclampsia risk, I would better prefer if an anomaly scan is also showing decreased percentile EFW.
No, anomaly scan is absolutely normal. 20 weeks corresponding. Do you feel that if we add a 32-week scan or a 32-week scan or 36 weeks, it is going to be very helpful?
I will directly go to 36-week scan.
Okay, you want to restrict the number of scans. You are a radiologist. Why do you want to reduce one scan? Patient is going to come to you. But do you feel that we should do a Doppler in every growth scan?
Doppler should be part of the growth scan.
Okay. Sumit, what's your opinion?
We, as a protocol, we do a scan at 20 weeks. 28 weeks we see, again the Dopplers is a must, even the uterines we do see. And we do call the patient at around 36 weeks again. Compulsory. That's the protocol in my institute.
Okay. Shilpa, what do you feel?
Yes, sir. 28 week scan rather than 30, I will prefer 28 week scan first and the 36 week scan. So that is my say on it. And Doppler, yes, Doppler, growth scan should be there. Growth scan must include Doppler. The Doppler growth scan reporting without Doppler is not a growth scan.
Only if one scan can be afforded by the patient in the third trimester, then I think that should be the 36-week scan. Because clinically, if everything is going okay, but 36-week scan is something which is mandatory. But one scan, if can be added, say around, some may feel at 28 weeks, some at 30 weeks, 32 weeks, that definitely helps a long way. And I feel Doppler should be a part of every scan, because we do not, there is all this business about the charts, this thing and all that. I would rather do it and use hemodynamics as a method of differentiating that. Now, Kulkarni sir, do the clinicians involve you in the decision making for when to deliver as a neonatologist or a pediatrician?
Definitely there should be a consensus between the...
But does it happen in practice? That
yeah, usually we get a call whether we should wait for another week or so, or we should go ahead with the delivery right now. So usually we get a call from obstetricians, and that is a really must.
It helps you if you are...
it helps definitely.
Okay. Now I ask you a very stupid question actually, but then I feel it's very important. Suppose there is a fetus with gestational age 29 weeks and has a weight of 600 grams, and there is another fetus 32 weeks and a weight of 600 grams. Which one is the one which is more likely to have an abnormal outcome, sir? In the sense, what is more important for you? Is suppose a decision has to be taken. What do you feel more happy about, the weight or the gestational age that the fetus has reached?
It all depends upon the 600 gram is persistent since how many weeks, or how long the baby is hypoxic or in that abnormal condition in utero. And that will decide definitely, because even if it is 600 grams at 29 weeks or 32 weeks, we need to be very, on the toes in the NICU. But it all depends upon how the baby has come to this point.
The maturity, of course, anybody would prefer a 32-weeker the gestational age has received. But if it is a 32-weeker and which has been grown from only 580 to 600 gram in the 4 weeks, is more likely to be acidotic in a very bad condition than a 29-weeker which is 600 grams.
According to Barcelona, it should be stage 4 or something like that.
See, the neonatologists are also talking about Barcelona staging survey. Yes, sir.
About the pediatrician, we don't ask the pediatrician whether we should take out or not. The decision lies with me. What I convey to the pediatrician, depending on the Doppler findings, that you are likely to face these difficulties, maybe primary pulmonary hypertension, necrotizing enterocolitis, the intraventricular hemorrhage. So the likely complications which you anticipate by way of interpreting the Doppler, those things I convey to the pediatrician so that he is aware of in management, and he would take due precautions about that. He would start a late feed if we tell him that there is a necrotizing enterocolitis risk in this baby. And this happens when there is a reversal of diastolic flow. Many babies develop NEC in the when they start the feed.
Yeah,
So
but in
that will
tricky situations, it's always better to have a multidisciplinary counseling in the sense because the parents are, because there are times when दोनों तरफ से, you have to tell the patient कि if एक तरफ खाइए एक तरफ कुआं है, so somewhere down the line we have to even sometimes it is left to the patients also to take a call, and I think that is the time when involving a neonatologist who can counsel them on the post this thing, even to the extent of the long stay that the baby may have and everything really becomes important. Yes. Now we'll see some quick cases. Now I've made teams of 2 each. So Sajid and Gandhi sir, any one of you can keep answering that. There is a 28 years primary for a scan at 30 weeks. Fundal height is 26 to 28 weeks. Healthy, gained 7 kg since early pregnancy. Blood pressure is normal. Now, so she has come for a scan at 30 weeks. Her earlier scan, 8 weeks was corresponding. Mid-trimester anomaly scan was normal. Now, the AC is at the 10th centile. Estimated fetal weight is at the 14th centile. Now, is this FGR?
What is maternal BMI weight?
Sorry?
Maternal weight BMI.
Maternal weight is normal, sir. I didn't weigh that patient actually, but weight was normal. Means routine, otherwise unhealthy mother.
Okay. Well, she is a small baby. Obviously, the AC is at 10th centile.
It's at the 10th centile, not less than 10th centile.
Yeah, it is at 10th centile.
Yeah,
So
yeah, 10th centile.
she should come in the surveillance.
Yeah, but will you call it as FGR?
Potential candidate.
Or you want some more information here?
Yeah, obviously Dopplers. If you have
Okay. Now the Doppler is otherwise fine, but CPR is at the 7th centile.
Okay. So she is moving towards
Yeah.
FGR.
But still, protocol-wise, we won't label it as FGR. So when would you like to follow this up?
30 weeks, two weeks.
Okay, 2 weeks. Because we have not yet called it as FGR. We are still in this thing. So follow up after 2 weeks, he said. Okay, I agree. I also had done the same thing. So 32 weeks she came. Now the AC is 8th centile. Estimated fetal weight is 10th centile. Umbilical artery is borderline. CPR is less than 4th centile. Now is this FGR?
Well, so she fits into the stage 1 of.
Okay, so this is stage 1 of FGR. So will you like to follow this up?
Yes, after another 2 weeks.
Why? Stage 1.
Stage
Yeah,
1.
okay.
It should be 1 week.
Okay, but 1 week bola, lekin patient came after 2 weeks. This is again, the problem from the obstetrician side also, because not necessarily always from the patient side, but generally if we say after 1 week, they send after 2 weeks. If we say after 3 days, they send after 1 week. That is again, they keep trying to reduce the number of scans, but that is where sometimes the protocol goes for a toss. But anyway, she came at 34 weeks, now it is 4th centile, estimated fetal weight 4th centile, umbilical artery PI is high, but there is a diastolic flow, CPR is at the 3rd centile. What stage is this?
Still stage 1.
Okay. Would you like? No. Gandhi sir, delivery?
No, we'll wait for.
We'll wait for
another week or so.
Okay, 35 weeks.
We'll give steroids. We'll prepare her for labor.
Okay, so you want to give steroids at this stage itself because now you know that you have labeled it and already okay.
We may have to go for induction. We have to prepare for that.
Okay, so this is 35 weeks, 3rd centile. Still, umbilical artery is showing diastolic flow. Ductus venosus is normal. Still, it is stage 1. And now 35 weeks you want to deliver, or you still can wait for some time?
We can wait and we'll aim to deliver around 37 weeks.
Okay, so we will keep following 36 weeks, similar kind of a finding, the MC has gone down. This is again a time when we wait, and 37 weeks there is, though the findings are same, it is still stage 1. Now would you like to deliver?
No, I would rather prefer to deliver her at 36 rather than 37.
You would prefer
the
to?
stress of standing the labor is better in an intact baby than a baby which is deteriorating.
Okay, that's, the protocol puts it the other way around.
Baby is not putting on any additional grams. There is no point in continuing the intrauterine stay.
Okay.
The Doppler abnormalities, they they show the interpretation is that the baby is going towards a pathological milieu, a sort of not exactly acidosis, but then it is not a very conducive for the intrauterine stay.
Okay, so you would like to do it, but
Yeah,
we followed a protocol and we said, okay, we will do it we'll repeat out 37
The
weeks.
advantage is that the baby which I would deliver at 36 will stand the labor better than the baby which is deteriorated with Doppler at 36 weeks.
Okay.
The chance of birth asphyxia or delayed cry, passing meconium, all those things would be there if we stretch it to the last limit.
Okay, so but we decided to go by this thing, and we waited till 37 weeks, and 37 weeks.
Chance of C-section would increase at this point.
Yeah. So, but then finally we delivered at 37 weeks in this case, and so the lesson learned is that
vaginal or C-section.
This went by a normal induction of labor, and she delivered. And iatrogenic prematurity can be, we delivered means I don't deliver, sir, I am not an obstetrician, the obstetrician delivered. So iatrogenic prematurity can be avoided or minimized by an evidence-based algorithmic approach and clinical surveillance. Because there was a protocol that we were following, we had the confidence that, okay, let's wait, and we could take it till 37 weeks. This is case 2. Dr. Shilpa and Sumit, and I will take some inputs from the neonatologists also. 29 years primary, obese, IVF third cycle. Early pregnancy scan at 8 weeks was showing a 7 weeks 4 days. Dates have been corrected that time, and now this patient comes at 19 weeks 5 days, and these are that's the growth the centiles that you see. All parameters are less than the third centile, AC is less than first centile, estimated fetal weight is third centile. Now, is this FGR?
Yes, it is
This
FGR.
is FGR. Do you want to do something more? Do you need any more information in this case? Sumit?
She's a case of IVF. Has she undergone the first trimester screening?
Which one? In this case, there was only one dating scan which was done at 7 weeks for this.
Should have.
Yeah, should have, yeah.
Dopplers.
Okay. FTS was done in this, sir. So in this case, FTS was done, which was low risk. And only thing, the uterine artery evaluation was not done. In this case, it was done, yes.
So, such is very early onset FGR. So, we need to rule out aneuploidy infections. We have to look for these signs also. Because very early onset FGR, these things we need to consider.
Yeah, so very early onset FGR, all parameters looking down, we also need to take into consideration that this could be because of a fetal cause, and that also should need to. Now, there were no structural anomalies, no soft markers of aneuploidy, and you had a mean uterine artery PI which was high, and you had umbilical artery PI which was greater than the 95th centile. Ductus venosus was normal. Now, what stage is this?
She is stage 1, sir.
This is stage 1. Any other investigations you would advise? Sumit?
Anomaly scan is good. We have infection is another cause. So for infection, I would do a torch titer in this case. So that is one.
Would you
and
amnio?
We know that even the chromosomal anomalies are associated with early onset IGR. So amniocentesis for the chromosomal purposes. So from my side, anomaly is done. So a torch and amniocentesis to rule out the main aneuploidies. So microarray.
Definitely, that is all we will ask for.
These two, I would have suggested this patient.
Would you advise termination 19 weeks, severe FGR?
No, as you said in the first slide, she is a third cycle IVF.
Exactly.
So I would prime her about the things what is going on.
Yes.
But not straightforward, ask her to terminate here.
Stage 1, when would you like to follow this up? Sumit?
By rules 1 week, but at 20 weeks it doesn't make sense calling a patient weekly.
Exactly. What will you do? Yes, protocol. These are the places where the protocol goes for a toss. Because suppose I call after 1 week and there is an absent diastolic flow or anything. What am I going to do? So Shilpa, when would you want the patient to come for the next scan?
So maybe 4 to 5 weeks, after 4 to 5 weeks.
Yeah, so somewhere you want to go closer to 24 weeks and then, because at least, because even Dr. Kulkarni will agree that, kuch to you give us some maturity before this thing comes to this thing. Now, so this is early onset FGR, there were no structural abnormalities, no torch test was done. Patient refused any testing for chromosomal abnormalities. They just wanted to give the best chance to this baby. They were very, very particular about that. So I suggested them after 5 weeks at 24 weeks, but the patient directly came at 26 weeks, 5 days. Because somewhere somebody had told them that anyway 26 weeks tak to chahiye. So they thought, hamari anxiety mein we should not end up. So they wanted to give the best shot to the baby. So 26 weeks, 5 days, and then we know, yes, this is going down. The growth was dipping, fetal weight was also dipping, and the Doppler showed a reversal of end diastolic flow in the umbilical artery. Aortic isthmus and ductus venosus were normal. What stage is this now?
Stage 3, sir.
Stage 3, 26 weeks, 5 days, stage 3. Will you deliver?
No, sir.
No.
There is one thing about the Doppler. The babies with a lesser gestational age tolerate the Doppler abnormalities.
Hypoxia for a long time, yes.
For a longer time compared to the babies at a later gestational age. See, if you notice this kind of thing at 26, 27 weeks, the baby may progress to 30 weeks with this kind of Doppler. And
because the ductus venosus were absolutely normal in this case. So now you said this is stage 3. So when would you like to follow?
Sir, ideally, protocol-wise, it should be every 3 days now. Bi-weekly, it should be there. But again, considering that patient may stay in this stage for a long time.
No. But now that 26 weeks, 5 days, Dr. Kulkarni is happy with it. At least there is a decent gestational age. So he says, okay, fine. Now, okay, whatever extra you give, wonderful, but then this is fine. So we will ask for after 3 days. And then, but as I said, this patient was little, ahead of times, and she came directly at 27 weeks, 3 days. That was the time when there was reversal of end diastolic flow. Of course, it was always there. And the aortic isthmus was also showing reversal. Of course, see, the aortic isthmus has now suddenly lost its significance. It is again out of the radar. It comes, it goes, it comes and it goes now, because the current evidence does not want us to include aortic isthmus into this. But I personally do still feel at times that it comes off to some use, but my personal opinion has no meaning in that. I don't have evidence to back that. Now, 27 weeks, 3 days, DVPI greater than 95th centile. Now what stage is this? This is still stage
3.
3. Do you want to deliver now?
So maybe we'll wait till reversal. Means by protocol wise, ductus venosus A-wave reversal, but now it is the take of pediatrician and the gynecologist what to do.
Sir, Abhi, this patient has been sent to you with all these Dopplers and all those things. 27 weeks, 3 days. Do you want them to take a call?
Actually, considering all the history and the baby is not gaining weight, so it is better to terminate the pregnancy within maybe 2 to 3 days or something, 4-5 days.
Now, what happened by this time, the patient had gone through complete Barcelona and everything, and basically, started believing in me also, because they Google searched and they went through some of my talks also on FGR, and they were like, the patient used to tell me, lekin abhi sir stage 3 hai na. I said, this is the way the patient had gone into. So they came back again after 2 weeks, and there was a reversal of A-wave in the ductus venosus. Of course, this is clear-cut a decision. Maybe practically I would have preferred it at the previous. The 2 days probably would not have gained too much, but 2 days could have led to a great loss. But at least this time they did not come after a week. Probably if they would have come after a week, it would have been IUD. So this is, again, this has gone into stage 4, and a 485 grams female baby was delivered. The baby spent 40 days in NICU and went home. Now I want to ask you, now with this kind of do you counsel them about the long-term outcomes?
Yes, definitely. Now, as this baby is very small weight, around 500 grams, and stayed in NICU for 40 days, naturally she has undergone many turbulence in utero and after coming out also. So we need to, and already the parents are with us for 40 days. So we had a talk every day regarding the baby's future and all. But while discharging, definitely I will have to talk about future of this baby. Because this baby, as we have monitored since last almost 7 to 8 weeks, and the baby's weight gain was not proper, and baby's uterine artery reversal of the umbilical artery, that was something bad, and maybe the baby had acidosis at the time of delivery. So with all these things put together, the neurological outcome of this baby could be abnormal. So we have to ask them for constant follow-up. They have to undergo ROP screening. Already it has been started in the NICU, and also for auditory screening. And every 15 days we have to call them for follow-up of neurological development. Also maybe for the respiratory component, because the child may develop respiratory complications even after the discharge. Anemia could be a big problem, because that could also worsen ROP if it is there. So put all these things put together, we have to counsel about a guarded prognosis regarding the neurological outcome of this baby.
Yes, and can we do something? Yes, sir.
Also, somewhere around 2010, there was a multicentric data on the babies with a Doppler abnormalities like this, delivered between 26 to 28 weeks, 28 to 32 weeks, and 32 plus babies. The babies less than 28 are 80% of the babies are likely to develop CP. That was the statistics somewhere around 2010. Maybe the improvement in the neonatal care might have come down this figure, but still the figure has to be significant. Between 28 to 32 weeks, the CP was quoted, the risk of CP is about 60%. Once we cross the 32 weeks, the CP risk is much, much reduced.
So the lesson that we learned from this case is that in early onset FGR before 30 weeks, the critical endpoint should be an abnormality in the ductus venosus, and every day a fetus spends in utero before 28 weeks reduces the morbidity by 2%. Case 3, 28 weeks, second gravida, for a scan at 29 weeks, 5 days, fundal height is 28 weeks. Now she has a history of hypertension from 27 weeks in her first pregnancy with an emergency LSCS at 34 weeks in the previous pregnancy. The fetal weight was 750 grams and the baby is currently alive and healthy. This patient's mother was also hypertensive. So this is all the history that is there. And NT scan at 12 weeks, 3 days was corresponding. Mean uterine artery PI was high. So it was 2.95 at the time of the NT scan. Now, should a PAPE and PLG be added to the mean uterine artery PI in this case, sir?
Yes, definitely. A properly done, I repeat, properly done PAPE and PLGF, if it is included in a good software, you will have a risk assessment of around 85% for developing preeclampsia as well as FGR.
In this case, who's already got an history of preeclampsia in the previous pregnancy and
yes,
all
that is a risk factor, background risk factor,
yeah.
prior risk factor.
Yeah. Will you
Mother
start?
Also had that is a prior risk factor. The uterine artery is abnormal, that is a prior risk factor. Now, one point which I would like to add, in which I haven't so far read any references, in last 2 years, we have been doing the anti-nuclear antibodies in the patients who have a high PI values. At the first trimester scan, that is that NT scan, if we find that the PI is more than 3, or at the second semester 20-week scan, if we find that the PI is more than 2, we find that almost 3 out of 10 patients have a positive ANA.
ANA, okay.
That is somewhere around 30%, but still our data is small. It may be about 25-30 patients in the last 2 years that we have come across. And this is something significant because that is not the frequency of positive ANA in a general population. And these are the patients which are to be treated on a different line than just aspirin.
And so you will start her on There's
Aspirin.
no second doubt about it, starter one aspirin, right? And
Aspirin is must.
yeah,
It is 150 milligram. Yeah,
no second thought about it. That 150 should be the dose. Will you agree that still most of the people give 75 milligrams? I see quite a few.
I started using aspirin in 1996.
Yeah.
My starting dose was 50. I changed it to somewhere around 75 in 2005. And with the FMF guidelines in 2015-16, I switched on to 150. And right now I've been using 150 for all the patients.
Sujit. So what is the recommended dose? We have confirmed, so it is 150 milligram. Now, so this patient came at 20 weeks corresponding, everything was fine, PI was increased, which was already there before. Now, in the light of her history of hypertension and FGR in the previous pregnancy, when would you recommend the next scan in this case? She has history of preeclampsia in the previous pregnancy, FGR in the previous pregnancy. When would you ask for the next scan here?
20 weeks, PI is 2.1. Can I get the growth centile at 20 weeks?
Everything was normal, sir.
Centile?
Everything okay, no problem.
Means 50, 60, 70.
50th centile, somewhere around 40th and 50th centile, no issues about that.
Centile, then I would repeat after 6 to 8 weeks.
So, agree Shilpa? 26 to 28
26 weeks,
Yeah.
yes.
So, she came at 29 weeks, 5 days. Now, this is the time where you have the estimated, these are the parameters there. You have a CPR, an umbilical artery PI, which is high. Okay, this is stage 1. The blood pressure is 170 by 92, pedal edema, albuminuria. Will you deliver this now? Stage 1.
See, you have noticed the albuminuria. No, see, what is the 1 plus 2 plus 3 plus? Or
Sir, इतना मुझे पता नहीं. I was told that उसको albumin plus positive है.
See, the albuminuria we take it very seriously.
Yeah.
My protocol is if I find albuminuria in 3 consecutive days, which is more than 2 plus, I check for the albumin level. Because it's very difficult to do a 24-hour urine albumin.
Definitely must not have been very high because she was.
Do a albumin level. If the albumin level is less than 4, then I would prefer delivering this baby. Because once there is a proteinuria, these patients, they deteriorate very fast. They develop the ascites, all those symptoms which are due to reduced oncotic pressure of the blood.
Okay.
And they would develop effusions. There is a rapid downhill course of the fetus, and delivering these babies with all this becomes a mess.
Now, stage 1. Shilpa.
Yes, sir. Means if that albuminuria issue is not that much, we'll go for a, this will be stage 1 and then we'll go for a follow-up.
Okay, weekly follow-up, BP is nearly the same, things otherwise are looking okay, the level of albumin, whatever was told to me was okay, there was no deterioration further, so this was still stage 1.
Stage 1.
Yeah.
Again follow-up.
31 weeks, 6 days, still stage 1.
Yes.
But now there is minimal maternal ascites that has cropped in. The BP is 210 by 140 with all medications practically controlled. So,
Deliver format means.
Deliver? Radiologist.
Reason you have to deliver. No, you are stretching the mother to the limit.
Yes,
210,
she
140,
was,
will
yes,
She
yes.
can develop pulmonary edema, she can develop renal failure.
So it should have been delivered in the previous week
I
itself.
would not stretch to this limit.
Okay, yeah. So, but then definitely, whether the stage 1 protocol and all these things do not matter as long as the maternal condition should supersede everything. So that is right. It should have been delivered a week earlier because, but trying to balance with the fetus and this thing, but the maternal thing now, here it is stage 1, we don't need to take it to 37 weeks because the mother's issues, that actually is the indication for delivery, not the fetus and the Doppler. There, 27 weeks primary at 34 weeks of gestation, first and second trimester scan normal corresponding with LMP, 34 weeks, 6th centile is the AC, EFW is also 6th centile, the CPR is 4th centile.
It is FGR stage 1.
Okay. Late onset?
Late onset FGR.
Okay. Will you deliver?
No, I will follow up weekly.
Okay. 35 weeks? Same 4th centile, CPR is 3rd centile.
Still stage 1.
NST reactive. Now sometimes, I also want to say that, yes, if you are using NST also with this, it's better if you can go ahead for a midweek Doppler and a weekend NST, or a weekend Doppler and a midweek NST. It's always, rather than doing both on the same day and then waiting for a week, you're doing two things, let it go into a gap, so you're actually not stretching 1 week also, you're basically getting an opportunity to do something in between. And so this is still stage
1.
Yeah, stage 1, fine, this is late onset, but we have a CPR which is low, rest of the biophysical profile is normal, 36 weeks, 3rd centile, umbilical artery 94th centile, CPR 1.01, CPR is going down definitely, but NST and everything is still reactive, all other parameters.
Still stage 1.
Stage 1, yeah.
Follow up weekly.
Weekly. And this is now the CPR is 0.99, dipping, has reached 37 weeks.
Yeah, it will be delivery by induction at this stage.
Enough, 37 weeks. We stop. Yes, sir?
I would stop at 36.
You will stop at 36.
Well, see, I would prefer to give a good shaped baby to the neonatologist than a baby which is damaged.
Yeah.
Number one. Number two, the risk of stillbirth is increased. And you know that in private practice, even one stillbirth is something which would take away your sleep for 1 year.
That is what I just want to say one thing, that all these protocols which come, all these studies that we are seeing, these are all coming from university hospitals.
Yes, that is what exactly.
There is a difference between private practice and university hospital.
They have the best kind of facilities. They have the.
I was just discussing with someone like, there is another Dr. Bijoy who is again very popular with his hospital growth. We both have some contradictions in our, we are very close friends and we do discuss and we have, because again there is a difference between an institutional model and a private practice model. In a private practice model, you definitely err a little towards prematurity because you can't afford to have a stillbirth. And that is where that little difference is going to happen. Yes, you are not going to deliver at 32 weeks, but sometimes, and because all these studies actually come from 37 weeks. This reminds me of a story. This gentleman wanted to hire a driver. So what he does is, he calls all the drivers to one place, which is on a cliff. And then at the end of the cliff, there is a huge, what you call, valley. Now he says, anyone who can take me the closest to that edge of the cliff, I'm going to hire. So one guy goes, he goes about, stops 2 meters before, the next one goes, then goes 1 meter, someone goes and tries to be about 2 feet before the cliff and all. Then this one driver actually goes and around 3 meters before that he stops. Then this guy says, anyway you've lost the race then. He said, sir, I have brought you all the way through this cliff, through this bad road. Now, you can walk this last few I don't know how bad that valley is. I have not seen what is there. Should I risk your life by trying to go towards the edge of it? Let me drop you at a place, because you have already passed all that difficult journey that you have taken up. आपने सब कुछ क्रॉस करके यहाँ तक ले आए. सर आप 1-2 मीटर चल लो यहाँ से, आप चल सकते हो उतना. I will, because I don't want to risk your life just to prove. So that is what this is all about. But then, yes, you can take it to 37 weeks. But 37 weeks you're going to deliver. 90 weeks, 1 day scan done at another place, which was normal. And this thing, I have put those findings here. Shilpa and Sir. Now, at 34 weeks, 6 days, it's come AGA, fine. Should I do Doppler or should I not do Doppler? You all said that we should do Doppler. Yes. I do Doppler, and I find that the mean uterine artery PI is 95th centile, CPR is 6th centile, AGA fetus. Should I be worried? No, I don't panic, right? AGA. But should I put this patient into surveillance?
Of course. Yes.
Okay, so I'm not calling this as FGR, but even though it's an AGA, I find a borderline CPR, I need to put this. The umbilical artery is absolutely normal. The follow-up scan after 2 weeks, 36 weeks, 6 days, fetal weight is now come down to about 5th centile, and I find that the umbilical artery PI is now high. The CPR has dipped to less than 1st centile, so there is a rapid dip. She's reached 36 weeks, 6 days, closer to 37 weeks. So the patient was advised either very close surveillance, maybe delivery, or, we spoke to them, explained things, but then both me and the obstetrician, we discussed on that, and I told them this is late onset FGR. There was no concept. This is an old case. And I said, this is late onset FGR, and this is how it is going to be. So patient opted for a second opinion. Now the second opinion was done from a very senior person, and who said, Dopplers are not that bad. Umbilical artery is only high. ह्याच्यानंतर आता ॲबसेंट होईल, ह्या नवीन मुलींना खूपच घाई असते डिलिव्हरी करायची, आणि असं करून शी सेड वी विल रिपीट आफ्टर 10 days. पेशंट केम टू मी आफ्टर 2 weeks with an IUD. So definitely the thing is, these concepts of, these old concepts have to go, the new concepts have to come. We need to understand hemodynamics, or if at all we don't have any understanding of hemodynamics, at least let us follow some protocols. So, identify a small fetus, do Doppler, distinguish between FGR and constitutionally small SGA, stage the FGR and plan surveillance, and then take a decision on when to deliver based on protocols. I would always say, please do it based on protocols. An objective protocol-based approach to decision making is now validated. Ductus venosus evaluation is the cornerstone for assessing when to deliver in early onset FGR. The CPR ratio is a critical index in the late onset FGR. Scans at 36, 37 weeks and 30 to 32 weeks along with Doppler are becoming increasingly justified in our population because we have a very, very high incidence of FGR. So keep calm and follow protocols. And I always end my talk on FGR with this beautiful poem, which is not written by me, by some unknown resident who had written it from Dublin, that I am a fetus in the womb, I fear it may become my tomb. If only I could give a shout to make my doctor get me out at the right time, neither too premature nor too hypoxic. Thank you very much. And I thank you panelists for taking us through this wonderful session.
So indeed, it was a wonderful session. Sir, your examples shall always be remembered. I think they were the best part and kept us all alive. And two good examples, I think, even what we can even not even think of. So those examples will help us remember your words of wisdom. So thank you so much, sir.
Thank you. So next time you find an FGR, think on what floor you are on.
I now request Magai ma'am to kindly come forward and felicitate Dr. Ajit Gandhi. I also request Bakul Jagitar to please come forward. Dr. Bakul and Magai ma'am are both gynecologists and obstetricians in Sholapur. Bakul ma'am to felicitate Sajid Sayyed sir. Now I request Jyoti Taparia ma'am to please felicitate Sandeep Kulkarni sir. Our sponsors for the day, Life and Mindray, do we have their representatives here? Lifecell and Mindray, do we have their representatives here? Before we end this function, I request Jamma Madam to propose the vote of thanks.
Good evening, one and all. I, Dr. Anjali Jamma, President SOGS, thanking each one of you, especially thank you Sahani sir, Aniruddha sir, Konkar sir, for allowing us to associate with this mesmerizing academic feast, which we have imbibed since yesterday. A big thank you to all eminent faculties who have enlightened us with crisp and clear take-home messages. It was a nice experience to work with Radiology Society, especially Dr. Meru, Jyoti and Anshu. Thank you Mindray and Lifetrail for supporting us. Thank you all the residents who are helping us since 2 days. Thanks Saminder for excellent AV. Thanks Mohan, Aivare, Nishant, Ravi and all the staff from Sarovar. Last but not the least, all the delegates without whom this was not possible. Sorry if by mistake I have forgotten anyone. Thank you all from the bottom of my heart. Thank you.